production, and I know from Dharamshala, but now they are all changing gears and changing brands. Um, and Dr. Tarun, I think, is not here. Uh, Dr. Vipesh Sheth, can I ask you to join this as a moderator, please, because you are an expert. Please, please, please.
Mic is not working. हेलो हेलो माइक की जरूरत नहीं है अच्छा इट्स ओके ठीक है श्योर गुड मॉर्निंग एवरीवन आई थिंक I have been given the mammoth task to wake everyone up in the morning with the first session, which is very hard after a beautiful night yesterday with the entire team members. So, good morning. And before I go into it, a huge thanks to Dr. Rahul and Dr. Srinidhi for having a session on multiomics. I think when Dr. Srinidhi said that the entire concept of this event was AI, new technology, and we were very keen to have multiomics, right? Because that is where we are standing at. So, my name is Krishnendu. I am from Thermo Fisher. A disclaimer, I'm a genomics person. I am also extremely new to proteomics. So I think it's like learning as we go. And that is one of the major reasons why proteomics interested, because the reason is that when we have been dealing with proteomics, I'm a genetic counselor. We have understood that there are many times genomics alone does not give an answer. There are gaps. There are gaps that maybe the West is answering, but we are not able to answer it in India. So that is where multiomics comes into play. So just starting. So this requires no introduction. We know the highly heterogeneous hematological malignancies. We know that there are multiple disease cohorts that we deal with. They're genetically complex. And this is one of the areas where the precision oncology research is rapidly advancing. There is growing importance of molecular testing. And before a disclaimer again is that so Thermo Fisher has integrated so many technologies in the past. You will find my slides to be of different formats. Different companies had so many different formats. So and it is all coming together. So you will find different color combinations. That is just the wide variety of technology. So the idea is that when you are talking about cancer biology, genomics, epigenomics, transcriptomics, proteomics, metabolomics together gives a complete understanding. The world of omics is extremely large, and it is basically we are talking about the central dogma. The question that we were trying to answer, or the question that we are still answering, is a central dogma. So we understand DNA, we understand genomics. Time was 5 to 7 days or even more. Additionally, it has also been informed that the risk stratification biomarkers are recommended within the first cycle of chemotherapy. So, this plays a major role not just to the patients but also to the pharma companies and the amount of health economics involved in it. So, this is where rapid NGS comes into play. So, NGS has been there since many years, and we have beautiful NGS technologies. But what rapid NGS does is that they provide these actionable mutations in a record time. So, and that is something that we have seen Dr. Rahul implement wonderfully, right? So, from the sample to the final reporting, multiple biomarker, instead of doing stratifications, instead of doing iterative studies, a single testing now can provide more number of known and rare alterations. This in turn has multiple uses. First one is it reduces the lab work. That is extremely important when we are dealing with a lab of scales of, let's say, Agilis, Fortis, Medgenomes, etc., etc. The number of manpower that is required is extremely tedious. So having an automated system that frees up the laboratory resources for mostly into the identification space. The second one thing that I keep hearing in all the talks from all the heme oncologists is on the sample. Tissue becomes the issue or sample becomes the issue. We have extremely minimal amount of sample. So an automated system like the one that Dr. Srinidhi is using, it spares the precious tissues for other biomarker testing analysis. It helps in biobanking, and it also helps in utilizing the minimal amount of tissue sample or the heme sample for the studies. So, and we're looking at a broad molecular profiling. So now we are at a comprehensive genome profiling stage, right? We are not looking at a single testing for lung cancer, myeloma, etc., etc. We are looking at comprehensive genome profiling, and this also increases the eligibility to treat more patients, including those with a rare fusion, and enhance the trial accuracies. Ultimately, this helps in accelerating the clinical decision making. So the one that the rapid NGS that is on board in Fortis is the Genexus one, the two Genexus systems, and I think it is for us also. It's a case study globally. We always tell globally that if Indians can do it, if Dr. Rahul and Srinidhi can do it, why not outside? So we have seen great success in it. And this is one of the case examples wherein they had done myeloid amplification based NGS assay versus the orthogonal method. And couple of things that stands out in this study is that first thing, the PAT. The PAT plays an important role when it comes to patients, right? That and the specificity sensitivity. We are looking at specificity sensitivity of above 99%, and the key variants have been detected in these studies. So taking this into consideration, wherein for us this area is extremely important, we had launched an Oncomine research grant. It's a global grant that is running through, and one of our winners of the Oncomine research grant has been Dr. Srinidhi itself from here, wherein she had given amazing write up, and we were able to support her in that. So this is a bit on NGS. I'm not going a lot deeper into NGS, but for any queries, I think better than me is Dr. Rahul and Dr. Srinidhi to answer any questions on Genexus. So, getting to the next part of my talk is on the proteomics. So, where proteomics comes into play, and one second, my okay, I have to just move my slide. I'm just having. Okay. So, as a community, we have had barriers in implementation of proteomics. There has been challenges in how clinicians approach proteomics. So, when I said that I'm from genomics background and proteomics is new, it's because that as a genomics person, we're not extremely exposed to proteomics. So we have been convinced that there are more of, we have been convinced as a community that research has been showing NGS based proteomics approaches have been able to enhance the studies that is happening in the genomics community. Couple of challenges that we have seen, there has been limited choice of panels that is representing the entire proteome. The workflows has been extremely complicated. Basically speaking, we have not been able to understand the language of proteomics. That is a huge barrier. Understanding the language has become a barrier. So that is where Olink comes into play. And so Olink was a technology that was incepted in Uppsala, Sweden in 2016. So it is a scientist-based technology, and Thermo Fisher just acquired the technology last year. So in this was a very simple language for me. So basically, in this case, is that they had identified around 5,000 plus proteins from the human proteome at least, and in these proteins, they created antibodies. Each protein had they created two antibodies. Each of these antibodies had a DNA motif attached to them. So when these antibodies and a DNA oligonucleotide attached to them, and when they bind to the target antigen, they come in close proximity to each other, the normal DNA process takes place. They hybridize and then they get extended, right? So normal NGS comes into play then. So these antibodies will get into an NGS workflow. And because they are extremely specific, because the DNA oligonucleotide is there, the specificity increases. Once they come in close proximity, they get extended and then it is amplified. So the readout becomes either qPCR or NGS. And That is it. It is a very simple technology. You have you have identified your proteins, you have your antibodies, and DNA comes into play. So in this case, why this is very important is that couple of issues that scientists and clinicians have faced when it comes to proteomics is low sensitivity, lack of specificity. How do we identify that this protein is actually responsible for it? High sample is mostly required and limited dynamic range. So this simple but elegant PEA technology has solved these challenges for protein multiplexing, including the specificity, sensitivity, precision, dynamic range, and throughput. So specificity is an extreme hallmark of this technology, and they have very strict validation process. Each of the sample goes through around 31 validation process. And it is available on the open access website. So it is a very transparent process that is there. For example, when they had to create an Explore HT, that is a discovery platform which contains around 3,000 assays, they tested over 7,000 antibodies. So when I say it is a very scientist driven technology, it is. And a very, very less amount of sample is required. So up to 1 microliter samples for a smaller throughput readout, 1 microliter sample is required. And the thing is that most of this is run on the NGS platform. So since we do have a larger NGS database in India, we do have a lot of these, lot of Illumina systems or element systems, NGS systems, etc. The backbone is NGS. So you are just utilizing the backbone and building on the same. So this is where it is. So it is the only platform that is going from discovery to translation. In fact, now Dr. Rahul and Dr. Srinidhi will be going for a reveal study that is of 1,000 proteins. So when I say discovery platform, it is basically that when you have a sample type, suppose let's say the sample type is myeloma samples. These are the proteins that has a relevance or the pathways associated according to the HUPA, and you run your samples, you identify that out of the 1,000 proteins or 5,400 proteins, there is 194 proteins that are relevant. Once you identify that, you have to run validation studies. This is still research based, right? You have to get that into the clinical translation. You verify that, you make your own panel of these hundreds of proteins using the target one. And this can, again, the readout can be on a qPCR. qPCR makes it extremely cost effective. And finally, after you run your samples, you identify that I have 8 proteins that are important in this type of heme malignancy. And then this panel can be implemented into the clinical audience. So I have a couple of examples for it. This is the entire range. Uh, this is the entire range of offerings, and when you're looking at clinical range, the flex, focus, and ones give you absolute quantification. Again, comes into clinical study. So these are the problems that early scientists and the clinicians have been able to are using for. So you can identify the biomarkers that are causal of the diseases for selecting novel drug targets by combining proteomics and genomics (PQPs). So this strategy has been shown to increase the chance of success for the drug approval by around fourfold. So when you Google, you can Google on Scallop study. So Scallop is an international cohort study that used this strategy and now has the world's largest collection of proteogenomic association. It is a UK-US study that has been done. Second thing, to understand the biology and the underlying pathophysiology from the health to disease, extremely important. But mostly for us, I think it is also important to predict the disease or the disease outcome. So these biomarker stratification for the disease subtyping is extremely important. That can be done using proteogenomics and getting to the clinical endpoint. For example, if renal function is getting affected, that can take a long time for us to understand using other parts. So we need to identify the biomarker that can serve as surrogate in this case, and Olin can help in this thing, and early diagnostics, of course. So couple of studies, I'll just go into 2 studies. So this was a study, I can share the link later on. It came in Nature. So this is in next generation. So they were able to identify 83 upregulator proteins that can discriminate different cancer from different 12 types of cancer from non-cancers in this case. So this is on the, I'll share the study with Dr. Rahul and later the team. So the challenge in this case, the challenge statement was that cancer is highly heterogeneous. How early on can we identify the cancer types? And what is a non-invasive technology that is required? We have seen that the genomic data, using the genomic data, we're able to say that, okay, this person has a BRCA mutation, this person has a PAL B2 mutation, but exactly when does it get translated onto it? So in this case, what the scientists did is that they screened and detected multiple cancer types simultaneously using a single multiplex protein from minute amount of blood. So they used the Explore one, that is a discovery platform, and they screened around 1,500 patients that had 12 different cancer types. In this, what they were able to see is that they identified 83 proteins that was able to correctly correlate different cancer type, including early stage, discriminate between early stage lung and colorectal cancer. So this was first of a kind study, and what they're doing now is that from the panel that they have made, they're using this for clinical implementation. So they are offering this to patients after suppose there's a family history, suppose there are early symptoms wherein the patient is coming from, so they are using this as a panel for early patient identification. Another one that I was just discussing with ma'am before is on the lift factor. So in again, we know that in this case in ICB, only 30 to 35% of ICB has been seen to support the patients. So what they did is that, yeah, so immune checkpoint blockade drugs have only 30 to 35% effectiveness in advanced cancer stage, and it is extremely expensive. And in India, we talk about money all the time. So why should we be going for a treatment that can have a negative response? So what the scientists did is that using the proteomic technology, they were able to see that an increase in the a reduction in the lift factor that was inversely correlated to the response to the ICB. So the circulating level of lift is inversely correlated with the presence of tertiary lymphocyte structure in the tumor microenvironment, and lymph can be a potential drug target. So this is important, especially for yeah. This is important, especially when we are looking at anti-PLD1 treatment cases. So this is couple of studies that I wanted to show. There are around 3,000 plus studies that's ongoing. So the third one that I wanted to talk about, and we can take this discussion after this. Third one that I wanted to go into was discovery proteomics. So this might not be for the audience here completely, but more from the research point of view. So what they have seen is that this what we are talking about in Olink was more of the targeted proteomics. For a pharma company, for a large scale cohort studies, it is important to look at proteomic discovery, and that is when mass spec as a technology has always been utilized, a high throughput analysis system, and based upon the what is the protein that is discovered in the mass spec, you can do the following studies up. So again, technologies that are there, so depending upon your requirement, there are different mass spec technologies that are available today, from discovery to targeted for macromolecule identification, peptide proteins, small molecules, etc. So this is the last study that I have. So this was a study again in AML where they combined genomics and mass spec together, LCMS together. They did whole genome sequencing, identified the markers. They did RNA sequencing, and they looked at the express transcripts, and they correlated this with the peptide database. And on the LCMS, they looked at the spectra data per TMT set. And based on the entire study, they were able to identify novel peptides. They were able to identify novel peptides in AML. So, where proteomics stands now, so from discovery to clinical translation, along with genomics, it forms a consortium. So, it is basically concluding the talk, it is basically an integrated multi-omics approach that we are looking now, with rapid NGS being one of the systems that can help with the oncology testing, targeted proteomics, genotyping, low high throughput NGS, discovery cytogenetics. So, this looks at the entire paradigm for oncology testing. And yeah, so that was my talk about. Thank you so much. Since I'm not the expert in most of these subjects, there are other people who can help you in this, so I'll give you the names of them. So thank you so much. If any questions, do let me know.
Thank you. Thank you for the excellent talk. So I have a question that how can this multiomics
Yeah.
will help in prediction of relapse post transplantation, and we give the donor lymphocyte infusion like that. Do you have?
Yeah, I mean this ये थोड़ा बहुत ज़्यादा हाई-फाई हो गया मतलब. Okay, so what ma'am is trying to ask is that if we how genomics, transcriptomics, or proteomics, or maybe epigenomics help in predicting the risk of a relapse. So I think we also have somebody from MedGenome, Dr. Shruti. Hi. So, I can tell you that we are definitely doing a lot of good technology in terms of flow and genomics. They also have one of the most advanced technologies in house as well when it comes to clonoSEQ, when it comes to Olink, the machine they already have, which we are now trying to do. It goes to a sensitivity of 10 raised to minus 10. So I think in terms of proteomics, if we can identify a signature today when the patient is treatment naive, we will know what the signature is, and then probably in the MRD time points, if we continue to monitor more frequently, we'll be able to pick up the lowest possible residual disease at 10 raised to minus 10 sensitivity and probably be able to predict that. Also, Dr. Vipul is there. He's an RNA expert. He'll be able to tell us if transcriptomics can help us predict any relapse at an earlier level. That is not my domain at all. Right now, I'm just very new to transcriptomics. And methylation is something which is coming very rampantly. In brain and sarcoma, we already have. In AML, it's in the research mode right now. There are certain companies which have launched a 2 hour whole genome methylation, where in 2 hours, we can actually diagnose an acute myeloid leukemia based on the methylation marks. Just like in genomics, we say mutations. In epigenomics, we say marks. So methylation marks. But that is still yet to be clinically validated. Like for it to translate to use in clinic, I think that'll be a phenomenal technology when it does get validated. It's still in the research. And somebody in TMH is already, my boss, my mentor, Dr. Nikhil, is already doing it in TMH. He's trying to do it, and once that data comes out, probably we'll have more uh, insight into it. But Dr. Vipul, I'll take your answer for transcriptomics if we can predict and answer ma'am's question.
So I have never done proteomics. We used to outsource it to dogs. We get it metabolics and transcriptome. Transcriptome, we got 3 dash when we were 5 dash and we used to prefer 3 dash. So you will just get the transcriptome profiling, right? So you are going to make it into heat map. So like what ma'am is asking, patients who relapse versus non-relapsed, there will be a difference in the signature. I mean, genome, you'll get thousands of genes, right? You have to validate it. So I think proteomics is much more relevant. Protein level, gene level might be true, might not be true. So I mean, patients who relapse, patients who do not relapse, you can ask any question and put the signature for that. And after that, we do gene enrichment analysis because it has to be pathway. It has to make some sense. We've got 1,000 genes, but we group it into pathways where the cell cycle was a problem or metabolism was a problem. And then whatever you get, you need to validate it, right? I don't think genomics by itself can do anything. So that's the approach we had. I've never done proteomics in my life.
I also personally feel proteomics is going to be the that is why we do flow cytometry because it detects proteins. So proteins are, I think, more reliable compared to genes when it comes to MRD. I think I'll take Dr. Shruti's opinion on proteomics because they're using that machine. What is your experience?
Yeah, actually, we aren't using it yet. So we were planning it for Olink. So when I saw her talk, I thought I'll have some more doubts and, we thought we'll clear the doubts. We are yet to start with Olink. So when I saw the topic which you had shared, I was interested. Yes, we have the machine and we are planning to do it. So definitely, I think for the MRD, maybe this could be helpful in future because we'll be using peripheral blood here. So rather than the invasive, doing bone marrows. So I think this should be a useful technique in future. So I think let's have a discussion with Krishnendra later.
It's possible that again it's a translation product. So once we break it down and we're able to identify what exactly are the markers that we can use for monitoring for relapse, then it becomes much easier. Then it becomes much easier in this case. So I think we'll do that study with Dr. Srinidhi now. That's a good study topic. Yeah.
I mean, as a mom, you'll get thousands of markers, right? Then finally, you'll use artificial intelligence to boil down to 10. Then you have to validate those 10. So, um, Srinidhi, I have one question I wanted to ask you. With the bypass sequencing coming, there is a role of karyotyping now, and is there any role left?
So that is the one for which they are giving me money. The clinical research grant is what I have written, that low pass whole genome to replace conventional carotid. And I think there is a wonderful paper by Dr. Eric Dunkowitz in NEJM which talks about this in AML, that you can do away with conventional cytogenetics because it detects all chromosomal abnormalities. We've done around 34 cases till now. We've got more than 95% concordance. What it misses is the I am 21 in ALL, but right now, since we're talking about AML, we can right now maybe leave the ALL out. The other thing which it misses is a hyperdiploidy in ALL again, because it gets confused probably, or maybe we just need to refine the pipeline a little more. The thing about low pass whole genome is one more thing, that if we do it on cell-free DNA, then we'll be able to even calculate the tumor percentage. We have a lot of pipelines to do that, and I think that is the way to go. Where if we want to do away with bone marrow-based MRD testing in hematologic malignancies as well, because it's invasive, and in cell-free, what we can do, we can use peripheral blood, extract the cell-free DNA, do a low-pass whole genome, find the tumor fraction, what we do in solid organ malignancies. Again, Dr. Shruti will know that because she also does solid organ malignancies. So, in solid organ malignancies, what is important is the tumor fraction. What is happening? How much of tumor fraction is there in the body? It can go up to 0.1% of detection. So, if in hematology, if we can do that, that will be a game changer. That you do away with the invasive bone marrow based testing. So that kind of gives you also the leverage to do more MRDs compared to, you know, only 3 months or whatever, however you space it, because it's just a blood sample. So that is where low pass will also help again.
Can low pass be used for MRD also? So
Yes, that's what I said. Low pass whole genome on a cell free sample, that circulating nucleic acid sample. If you do that, you can calculate the tumor percentage. Again, that study is still ongoing in a lot of places. I think at Fred Hutch is one.
so for what we used to not do this. We used to do
No.
duplex or error corrected NGS.
Right, but right now I mean, when I was at their Oncomine Scientific Gala meet, where we had the entire forum of people, so one of the talks and one of the studies which has got funded from Fred Hutch is on this, and Cecil Young and everybody is really working on that.
And then, is there any role of forget karyotyping, SNP karyotyping, or optical gene mapping, or low pass replaces everything? Can you pick up LOH in low pass?
Uh, so
And
for LOH,
can you pick up LOH is one thing, and can you pick up what do you say?
That
so so
That's
so
where
I
SNP karyotyping.
yeah, so LOH typically requires SNP base, because in solid organ also we do 19,000 SNPs across the genome to calculate the HRD, almost 19 to 20,000 SNPs. And on that basis, we actually calculate the LOH, which I am not a very big fan of again, because I think it's very biased. And so LOH basically is done to understand how much of instability, genomic instability is there. I think we're yet to get there. We need to define how to do that right now. Low pass will not be able to do that because you are giving only 0.5x coverage. So SNPs we can't.
There is still role for SNP karyotyping or optical gene mapping. I will.
Yeah, but optical genome mapping in India too
It's true.
expensive. So, so I'll take the first question. Immune transcriptomics is something which we are right now piloting. We have done 32 cases. What we've done is we've used 395 cytokines, chemokines, and some tumor necrosis factors and all those things to, and we go back to the RNA level expression of those genes. So we try to, predict CRS. We try to see how much of inflammation is there. What we've done in the 32 cases are that they are all upfront AML cases. So to understand how much inflammation is there, with the hypothesis that Indian AML, there will be inflammation. So do you need to add that dexamethasone early so that it breaks that inflammation barrier and allows your chemotherapy to work? So we've actually found that the inflammation score varies across the mutation subgroups. We have seen that the inflammation, we've tried to make an inflammatory score, although the sample size right now, 32, too less to be very definitive. We need a bigger study, but that is what we are presenting. Dr. Rahul will be there at ASH to present that. It's got accepted. And um, um, we have also found a difference in the inflammatory signature between North India, South India, people from East, West, and across mutation subgroups. And I think that is the way forward. And we have what we have also been able to categorize in immune transcriptomics is the types that, what is predicting what? Is it predicting CRS? Is it anti-inflammatory? Is it myeloid? So it kind of also tells you whether your myeloid cells are coming back after transplant, if you want to know engraftment, whether your platelet engraftment is coming back. So there are 395 genes in that panel for RNA expression based. For nanopore, when it comes to RNA based, I will again tell Sir to take that question. But then in nanopore, what we are trying right now to do is the HLA testing, which has right now come, and it offers a phenomenal TAT of 1 day, and it's not at all expensive. It is as good as your normal 11 loci high resolution HLA. The other thing which nanopore does good is it's a long read sequencer. Okay, so what it will do good is we expect for fusions and fusion MIDs and the FLT3 ITDs, because in those you can actually pick up long ITDs. So it is expected to do well, and that's not very good to detect mutations. And we, at least in my previous institution, failed miserably on solid malignancies. In hematology, we don't expect it to fail because it's not in a paraffin block. So it has pores. Okay, it has semi-permeable membrane. It has pores, so they get clogged if there is too much of protein, if there is too much of contamination. So in solid organ malignancy, we faced that issue that the pores were getting clogged early, so it was not detecting. But in hematology, we don't expect that to happen. It is wonderful for culture. It is wonderful for metagenomics. It gives you an answer in sepsis in hours because you can run one sample. And trust me, that machine, the smallest machine, is as big as a Seagate hard drive, and it's like a plug and play machine. And it was built for point of care NGS device that you have somebody to make the library, you run it in your clinic, and you get the answer in hours. Actually, it was built like that. In India, I think that is yet to come and be in the clinic, but we are getting there. We're trying to get there.
Thank you, sir.
Um, So, so we will skip the next talk because we've already spoken so much. And what we will do is we'll do the panel discussion. Unfortunately, Dr. Anil Handu sir cannot join us, and This panel will now be moderated by none other than Dr. Rahul Bhargav. And I will invite the panelists on stage, Dr. Astha Gupta, who is our lead hematopathology at Fortis Gurgaon, Dr. Nikhil M. Kumar, he is, we fondly call him Nikhil M, means Nikhil Myeloma Kumar, so he obviously has to be a part of this panel. Dr. Mukul Agarwal from All India Institute of Medical Sciences, New Delhi, in hematology, clinical hematologist, very eminent. Dr. Moshmi Kar, again, my beloved friend. Dr. Sachin Jain, hematopathologist. No one needs him to be introduced. He is the man. And Dr. Shruti Mahesh, I've already spoken about her. She's from MedGenome, who actually, she is part of this panel because no one here knows about clonoSEQ and Olink, none of us. So they are the only guys who have the technology. So we curated this panel discussion. This is a little this panel is a little with a twist. Um, there might be just names written on the slide, but please feel free to answer anyone. Okay, and there is no data on this panel. There are no Kaplan-Meier curves, nothing. These are just questions and so
I think, and then the most important thing is how does the clinician feels and how does that translate their practices from the lab side. It's a mixed panel for a clinician and those people actually who does the wonders of giving us the MRD. So we all know about the MRD and what's new in MRD, myeloma MRD. Does it really matter? Does not. Where does it go every time? So this is where we work. So wow, but there is a problem working with these places is because then the expectation is setting is so high and the tat is all like do it tomorrow yesterday not tomorrow they give it yesterday. Sachin knows, Asta knows about how we function in these centers. I mean we everything need everything there and then itself. So benchmark for 3 days NGS now coming to 24 hours. We have started believing that can we get an NGS in 24 hours. We thought HLA can we get in 1 day. So that's what happens when you work at this time. Demands of patient and clinicians, and the deadlines was yesterday, as we talk about. The unmet need beyond the microscope, traditional methods, availability, and the accessibility is what we need to remember. Because India is a large country, and there are, uh, uh, I think, there are barriers across the places to send the samples. Good morning, sir. MBA Reval sir has come in, so thank you. Good morning, sir. So evidence, IMWG recommends NGS and NGF as a preferential methods for bone marrow MRD because MRD negativity predicts better PFS and OS. When we talk about next generation flows, is it only 4 color, 8 color, or 12 colors? And wow, and I'm moving to 25 colors, spectral flow. And as we talk about, probably by next year, Asta will be running on 25 color flow and telling about all the different colors. I didn't know there are 25 colors actually speaking. So we'll have a flow cytometry, we'll have 25 colors. Euroflow NGF is standardized and offers very high sensitivity with rapid turnaround suitable for routine diagnostics. That's a word I like, rapid turnaround. clonoSEQ is FDA cleared for MRD in lymphoid malignancies and demonstrate high analytic sensitivities. NGS often picks up a low level positives that NGF may miss, and the two methods can be complementary, not antagonist to each other, and not replacing one or the over the other. Emerging blood-based proteomics and other circulating protein metabolite signature may help in immune microenvironment phenotyping and non-invasive surveillance. That they are still largely translations and not yet replacement from bone marrow MRD. Probably single cell sequencing in the bone marrows is becoming a routine on the way to understand how and why myeloma becomes refractory over a period of time. The single cell sequencing will be the buzzword by the 2728 or 2030. Single cell sequencing will be a part of our daily routine practices as the cost comes in. So let's begin the first case, classical deep response dilemma, 58-year-old male, newly diagnosed, standard risk, treated with induction VRD, ACT, lineal maintenance. At day 100 post ACT, both NGF and clonoSEQ are MRD negative in bone marrow. Moderator. So does MRD negativity by both methods allow us to de-escalate maintenance therapy? Is there a data-backed case to shorten the duration or lower dose? So Dr. Tulika is not there. Nikhil, we'll start with you.
So I think this is a very typical scenario that we face in our practice. But as of now, at least in guidelines and routine practice, we do not have enough data to de-escalate treatment based on MRD. And that is partly because of the MRD dynamics also. So the IMWJ gives more importance to sustained MRD negativity, which basically means MRD negativity twice at least 1 year apart. But even then, we have seen a lot of patients who are MRD negative who eventually go on to relapse, and the other way around also. The patients who are MRD positive sometimes stay on for years with low level of MRD positivity. So I think till we have more data from clinical trials and more data to back time limited treatment, as of now, we are not going to make changes based on this.
So, Dr. Mukul, what is your thought in 2025 and moving on? Should you use MRD results to change therapy in routine practices? Your take on dual MRD negative patients post ASCT and persistent MRD positivity post consolidation. So, what are your thoughts? Do you actually, because the no sales for MRD says we are not going to act upon it? You have been a very busy practice. People come all across all walks of life to you. They are rich, they are poor people. Do you think in myeloma it is as sacrosanct as ALL to do a MRD in myeloma patients because it costs money? And do you change or do you not change?
So it's very important, but not as sacrosanct or established as in ALL. I'll say that the data is like often Nikhil said that you need time points for two points, 1 year apart. So here's a persistent MRD negativity. At day 100, you are not taking many decisions. You just take a decision to start the maintenance. At present, the standard is for standard risk cases is lenalidomide alone, but for high risk cases, you can add two drugs, whether it's the other drug can be bortezomib or daratumumab for that matter. The duration can vary. There is emerging data that after 2 years, not much role if there is persistent MRD negativity, but that is again only for standard risk
Dr. Mukul,
cases.
I will interject into that. Do you think that it's the same for the standard and the high risk?
So
Because you can still escalate in the high risk group, but in the standard risk, it does not change as much because you are going to achieve the MRD negativity. If there's a no sustained MRD negativity in a high risk, you can actually act upon it before and give a longer progression free survival. What are your thoughts on that?
So for the high risk myeloma groups, as of now, most of the paper they say that you have to continue, don't stop maintenance at 2 year point, and it continues till there is a persistent or a relapse of the disease.
Perfect. And what is your thoughts, the clinicians all across? So, what do you think that is the flow MRD sufficient, or you really need a clone seek? So, I'll come to Dr. Astas, Dr. Astas smiling. But for the clinicians, what is your general perception, and to the audiences, that have we reached to that point of NGS based MRD in myeloma? Do we need it as a country? Do we not need as a country, or flow is good enough? Just an opinion poll, and anybody can chip in and say and raise your hands for the clone-seq kind of a MRD versus flu MRD. So if somebody has to say, what is your ask for 2026? Do you think the clone-seq is there?
So we need clonoSEQ.
You will need. So,
I mean, we definitely need an MRD with a sensitivity of at least more than 10 to the power -5 or -6.
Minus
And
6 to -7, we can reach for the clonoSEQ.
clone-seq 10 raised to power -6 to
It's
-7.
-7.
Mukul, what is your thought?
So all these things are complementary. So
Yeah.
uh, you- better if you have both the techniques, but
Yeah.
these things are complementary. It's not like that you have NGS and then you can get away with.
So it depends on your clinical scenarios as well as the patient, condition, especially since ours is economic based. So if it's negative by flow, maybe we have to look in for the next step. That's the clonoSEQ.
In a similar fashion, the way the blinatumomab is going to hit the market, we need clonoSEQ kind of an MRD because the flow MRD is not sufficient to stop the treatment or not to do transplant on blina ponatinib based regimes. So we need a 10 raised to a -6. Nicholas Short paper categorically says until it should not reach to 10 raised to a -6, you cannot stop the medication then itself.
So
So actually,
Yes.
initially, like when I remember the early days when the BMRDs has started. So I think myeloma MRD in that phases because when BMRD has come at that time, the same questions have been asked. But now, after almost 7-8 years, we can see how the BMRD is helping in the diagnosis. So same way, myeloma MRD is going to come. But this will happen only when the clinician will start thinking about it and they will order it. Right now, also, when we will
So-
talk to the clinicians, so they will just say myeloma MRD is not much role. Now, yeah, now it's
So
coming.
Sachin
It's
is
good
saying
thing.
its onus is on the clinicians to
Yes,
first.
precisely. Yes, we are ready to develop the test, but unless and until you will not order and you will not understand, we can't develop the techniques. So we have the techniques, but onus is on your clinicians.
We know that both the techniques are complementary, as has been proven in even AML and other diseases. But the only thing remains is when one technique is negative and the other is positive. How do the clinicians act on that? That's what will decide in the further course of action whether that 0.01% positivity or 0.001% positivity by NGS and not by flow, how did it matter to the patient? That will be seen in the times when they come, where the treatment was given or escalated or de-escalated based on that. It will, I think that will.
Dr. Asta, what is your tell us your three non-negotiables for bone marrow MRD sample to trust. The NGF is negative and one common laboratory mistake that flips a negative into false negative.
Yeah, so one most important thing is hemodilution. So if a marrow is hemodiluted, then definitely the negative results cannot be relied upon. Obviously, we can say that there are no abnormal plasma cells in that case, but we cannot say that it is negative. So that is a very important thing. And the second important thing is the treatment history. If we have not gotten the treatment history of the targeted immunotherapies like daratumumab, then in that case, if we use the general flow cytometry protocols that have been used for flow, then a false negative result can come, because like for us, we use in daratumumab cases, we use CD38 multi-epitope antibodies. We even use 229, 319 antibodies to act upon, so that we can get a better and a more targeted kind of a recognition of the abnormal population. So that's the two most important thing: the treatment and the
I
time
think the
point.
color of flow cytometry really matters between 4, 8, 12, 16, and now 25. And somebody came up with 50 color flow cytometry also.
Yeah, it has gone up to 180, sir. So color mattered when it was less than 12. Definitely, people started, like Euroflow still uses 8 color approach, two tube 8 color approach. So and they have been using it for decades, and currently in the era of even 25, 50 colors, they are still using 8 color approach. So the approach, the number of cells that you can acquire, that is a very, very important thing, because that's the denominator by which we reach the sensitivity of any MRD. So color will matter if we are able to add, as and when again more and more immunotherapies are coming, we need to add more markers to identify our abnormal cells, and for that the color will matter.
So
Just
Asta
to add,
did pitch
just
for having a spectral flow to the Fortis. I think that's
just to add the non-negotiable thing, I think in the myeloma MRDs, the sample time is also very crucial,
yes. I was about to ask.
because we have to process the MRD in specifically in myeloma within 24 hours, preferably within 6 to 8 hours only, but not beyond
I think that's where
24 hours.
CloneSeq has got a better, uh, has been able to remove all the variabilities and better approach because you do not require that
Yeah, that's true, but
criteria.
that's true, but I don't know. I think in clonosec the baseline diagnostic you need.
Yes.
So
we can-
means,
that will come.
so that's an essential part, because
So yes.
that's
So
an additional cost to the patient. But yeah,
yeah.
if you are
So
to
so
use
we
the
have been able to standardize that, say, as clone scan and clone track, equivalent to clone seek, and we have been able to validate on a couple of samples with clone seek. So Dr. Shruti, when MRD positive by clone seek but negative by NGF, how do you report and counsel clinicians to on clone type stability, limit of detection, and clinical significance, and also how one often should clone type be remonitoring be done in first 2 years?
So we already discussed about this limit of detection, because the
Can you
flow.
just brief the audience what is clone seek? What do you want? What is the baseline sample? How do you do that? What
So,
is the turnaround time?
yeah, turnaround time is actually clonoSEQ is done with the adaptive technologies, which we outsource it to the US lab. So the turnaround time for it is 14 days, because they have to do it for the baseline as well as for the MRD. So baseline, they'll be accepting FFE block as well, because I'm sure that especially what we have outsourced it, we get only when they need the MRD. So during that time, we send both the baseline sample as well as the MRD sample. So MRD sample will be the bone marrow aspirate itself. That's a liquid sample, but the baseline will be FFE block, or if they would have kept the like if they start from the baseline itself, they can send the marrow aspirate. So coming to the sensitivity or the limit of detection test, it is clonoSEQ is better. So it's 10 to the power of -6, and it can reach below than that. But when it comes to the flow, I mean, NGF flow, so that is 10 to the power of -5 limit of detection. So when they say that if it's positive by clonoSEQ, yes, the clinicians has to consider it.
And what do you
Because
consider as positive? I mean, how do you report? Can you tell to the clinician what does the report of clonseq say?
so
Just
actually, so
positive,
clonoSEQ,
negative?
yeah, no, no, clonoSEQ is what we see is the gene rearrangements.
Okay.
So that's the signature. So once they get those gene rearrangements by the baseline sample, from the baseline sample, so the same will be followed up with the MRD samples.
And does the report only comes as positive, negative,
No, they this
1%, 0.2%?
yeah,
Is it quantifiable?
it is quantifiable test. So we get the number of the ID sequences. So that's called ID. So we get that how much ID sequence is present in the MRD. And it,
Cutoff limit. So we know that for flow it is 0.1%. So what is the cutoff limit or sensitivity or detection of that?
so it is one gene signature or the one ID for per 1 million cell.
For 1 million cell. Wow. So wow, genomic insights starting with a healthier future. Dr. Sachin, cost, stats, standardization, or real world constraints for a medium sized center in India for a similar resource setting, pragmatic MRD programs which test to offer in house, which to send out sample volumes to bank, and a minimum QC plan.
Yeah, means cost is always constant in India. That also for clinicians. So for MRD, I think if you will talk about that, so that will like the flow. Obviously, it will be the fastest in 1 or 2 days. Uh, but I want to ask you parallelly how much your time frame in the you have when MRD positive or negative. So how much time frame do you have for the treatment decisions to
So
take?
in a myeloma, it
So
is not a urgent treatment. We can still wait for 3 to 4 days to a week because it's not an urgent treatment which makes a decision changes. You can still give it within a week's time. So even if it comes within 10 days, but it is our own anxiety that we want everything for 24 hours. It does not change the treatment. It is not going to change the treatment of MRD, myeloma MRD, but it's just for our own satisfaction and instability into our mind that we start jumping the moment we do a marrow to give MRD. That's for us.
yeah, we can understand that. Anyway, and the standardization part is standardization part. Obviously, it's lots of standardization you have to do in terms of MRD sensitivity. So you want to achieve 0.01 or 0.001. So if you want to suppose, for example, you want to achieve 0.001 10 to the power -6 one flow, that's doable in myeloma, but you have to acquire the events more. Like from 1 million, you have to go to the 10 millions, then you can achieve.
So, Dr. Mosby, which for this question, what Dr. Sachin is saying 10 is to a -6. We can go up to 10 is to a -6. Do you agree to that?
Yeah,
I mean, I know
actually,
you're a
sir,
flow
in
person, so
yeah.
she's going to be biased. She's going to say we're going to 10 is to a 6.5.
No, 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 sir. Actually, what it is, no, it is not all size fits all like of situation. Like as we go to a market and we see small, medium, and large size, it's about the patients, how they can go and what is suitable for them. Obviously, clonoSEQ is going to be more perfect and more sensitive, but you are going to MRD doing by clonoSEQ, you have to decide at the baseline only. So you have to get that first
So,
thing.
for a clinician
So
like us who do not understand too much of a flow, what is the minimum event or a maximum
yeah,
event
actually,
we can see
Euroflow,
positive,
yeah,
negative?
yeah, Euroflow says that we need to go till 10 millions. So and IMWG says at least minimum 5 millions. If five less than 5 million, then and I am getting positive, then obviously I will give it positive and give it a note that the sensitivity may not reach that percentage, but we have acquired this much percentage of cells. But if it is less than 5 million also, like I am getting 1 or 2 millions, if it is positive, still I will call it positive. No, because the positivity of MRD is not actually about the disease burden. It nowhere it is telling that I am getting 0.01% is 0.01% disease burden is present. Disease burden will be much more. But if I am getting negative, then what to do? Then obviously I will say that this is negative for this year, but the sensitivity is not reaching that much, and this is dilute sample. So of course you have to add some different methods like NGS. Still now that you can go for it if you have baseline clonoSEQ data.
Perfect. So poor clinicians can't understand 10 million, they can go up to million. So at least 10 million you can see on the flow report next time.
At least 5 million,
5 million.
5 million. I am the wise,
Okay.
at least 5
So
million. I
5
have
million
confidence.
events have to be seen to say whether
We are already reporting now.
okay.
Since 7 million, 10 million already we are reporting. Since we have standardized the myeloma MRD in the Fortis, so always you have shared the report in the US. So we are always acquiring
Also
10
said
million
that
events.
if how much hemodilution is there, we can see if there is mast cells present, if there is hematogens present. There are few indicators in the flow which can tell us that if we are not able to acquire that much also, but if mast cells are present and hematogens are present, maybe I will call it the sample. Maybe it may be adequate. You can rely on that.
So, Dr. Shruti, what is your take on Olink and other circulating proteomic assays? Because we are very excited about the mass spec coming as an MRD,
Yes.
as a peripheral blood MRD. So, I've also not touched upon the peripheral blood MRD, where many US centers are talking about peripheral blood MRD in myeloma. So, first, Dr. Shruti, you can answer on the Olink and the other circulating
So
proteomic.
Olink,
Flow cytometry people can actually tell us about the peripheral blood MRD. What does it, and what is the future of that? So, we have
so Olink, I think Krishnendra has already explained it much better way. So definitely, if we standardize Olink and the other, as you said, mass spec, so that would be much better for us for the follow-up as MRD, because mass spec can be done with the peripheral blood. So, but still, it's in the research mode. So it has to be, there is so much more validation to be done for it. So it's still in the research side, and maybe that test can be as an add-on test with the other current methodologies what we do for the by NGS or NGF. It has to be added onto it. But in future, definitely, if we go for the peripheral blood MRD, that's much better for the patient, so that we avoid the invasive techniques there.
And I think the clinician has to go back with a message back home that we need to start developing the research module for a peripheral blood MRD so as to avoid the invasive bone marrows every 6 months to 1 year.
Yeah.
Dr. Astha and Dr. Mosmi and Dr. Sachin, what about the peripheral blood NGF based MRD? So do you think we are reaching onto that?
I don't think so that I will approach case of NGF in a peripheral blood, because I will always want a bone marrow sample.
Bone marrow sample.
Than a peripheral blood in case of flow cytometry.
Yeah, peripheral blood is bone marrow is always better, but European group already has published the circulating tumors, circulating plasma cells from peripheral blood. So results are exciting. So it's not future is because that. So generally in the peripheral blood, the sensitivity is almost 10 to 20 logs lesser. So, but yeah, because that's a non-invasive, future is that. And another thing, just I want to add it here, uh, in myeloma and BALL, so that flow MRD and NGS MRD is not, difference is not going too much only in the terms of sensitivity, but that chances like AML, where we will get more chances like flow cytometry is negative, MRD, NGS is positive, so that are more chances in AML. But in BALL and in myeloma, that's generally it's quite less. Sensitivity will vary, but it's BLL and myeloma, that's thing. So
And most of the time, the discrepant reports have come in the post-transplant thing, not in the pre-transplant. In the pre-transplant, the data is almost equivalent in NGS and in NGF.
Actually, we have to also think about the ctDNAs. ctDNA is becoming the science in lymphoma. It has taken up very beautifully. We still have to adopt to ctDNA. Dr. Srinidhi has done almost 150 unique patient ctDNA for a lymphoma with each and every cycle. I think ctDNA concept will also come in AML, will also come in myeloma, because I think cell-free DNA and ctDNA things are becoming the norm now. From the lung cancer space, it has really taken off. And last 2 years, if you see the papers in Lugano or in ASCO, it was all full of ctDNA. Everything was ctDNA in a lymphoma space, either the CAR T cell or the ctDNA. Dr. Mukul, what is your quick thoughts about that? We have got 3-4 slides more left.
I'll just draw a small analogy with CML. We don't get deep molecular responses with interferon or hydroxyurea in CML. So likewise, if you're treating with, let's say, proteasome inhibitor IMiDs alone, you are less likely to get such deeper responses which will be required, which are the more common regimes. So if you're using MABs, bispecifics, CAR-T in for CR1, CR2, maybe at most CR3, those kind of patients who might benefit from such a deep level of immunities.
And Dr. Nikhil, what do you think that with the teclistamab coming up, there's a definitive therapy plan which has now come up? Will the NGS MRD clone-seq kind of a thing will help you out to know when to stop teclistamab? Because from if you see from Wisconsin paper, they're talking about 6 months of teclistamab. That is a definitive therapy. What are your thoughts on that?
So I think I agree with Dr. Mugul. The utility of MRD actually comes in patients where they receive treatments which are strong enough to make them MRD negative, be it daratumumab, be it teclistamab, be it CAR-T. So at last IMS meeting, there was a very interesting oral presentation by Dr. Meera Mohan, where around 70 patients who were on teclistamab and stopped the treatment at 7 to 8 months. And the main reason for stopping treatment was recurrent infection. They were followed up, and almost 70% of them remained disease free and MRD negative at 2 years of follow up. So, what I mean to say is, in an Indian setting where we have financial constraints and we will be looking at a time limited teclistamab strategy sooner than later, MRD would help in two ways. One is it may be able to tell us when to stop the treatment, and more importantly, it may be able to tell us when to restart the treatment. So I wouldn't want to wait till the patient has an overt relapse before restarting the treatment.
So I
Just
think
one caveat I would like to add: all these decisions should be backed by strong and robust clinical trials. Till the time we have randomized data or we have data from clinical trials, we really don't know how deep an MRD response is good enough. If a patient has an MRD negativity of 10 to the power minus 7 or 8, are we going to do better than someone who's MRD negative at 10 to the power minus 6? We really don't know. So till we have data from clinical trials to see what level of MRD, when to check the MRD, how can we escalate treatment or have time limited treatment strategies, I think these will be always points of contention.
Dr. Mukul, what is your thoughts on to?
So at present, we are checking it at least once after transplant. So not after that. Usually, then it's the monitoring is with the peripheral blood test only. So marrow is not repeated unless relapse is suspected. So 2 time frames. Present, we are not doing that often. So and stopping maintenance is currently out of question.
So I think the deeper NGS, deeper MRDs are probably going to sway your time limits of giving the chemotherapies. Probably these are the tools which are helping in the clinical trials to understand whether we can actually stop. And Dr. Nikhil has said very rightly that we need more data onto that, but the data generation will actually come from here because we have the largest population who will stop the treatment. So when they're stopping the treatment, spending 60,000 rupees on a clone-seq or Indian version of clone-seq, clone track and clone scan, actually, I think it's worthwhile because rather than just giving blindly, if the patient is not taking the medication, this is the field actually we can actually develop because like Americans, they're not going to stop teclistamab, they're not going to stop daratumumab ever, given a choice to them. It is in India which can actually give us the right direction to the world when to stop based on this deeper MRD. So I would encourage people to do the deeper MRDs, probably if you are planning or the patient is not willing to take the treatment forward. So I think we will be more peace knowing what next to be done. So last two questions, anybody can take this. So this is the oligosecretory discordancy which is there. Peripheral blood protein panel shows a subtle inflammatory signature on O-link, elevated CXCL9 and IL-6, but no measurable M protein, moderators, discordant assays and oligosecretory disease, which results due trust to guide additional therapy. And
So, we won't say that it's a discordant assay because each assay has its own limitations. So it's by the clonoSEQ, it anyway shows it as positive. So this has to be considered as positive, and maybe treatment according to.
So last final word, Doctor. Starting from Dr. Nikhil, what is the future of myeloma MRD? Just quickly brief.
So I think the future for myeloma MRD is bright. Before, people used to frown upon doing MRDs in myeloma, but now almost all the recent trials have accepted MRD as an endpoint, be it to avoid transplant, be it to de-escalate treatment, or certain trials like Master Trial, which are looking at time-limited treatment approaches. So I think once these results are out, just like ALL or AML, we are going to be using more and more myeloma MRDs in the future. And the most important thing is to have a sensitive assay. We need to have a myeloma MRD assay, which is at least 10 to the power minus 5 or minus 6 sensitive to make these decisions. So it is going to be a time when you're going to do MRD at multiple predefined time points, and that is definitely going to guide our treatment in the future.
Dr. Mukul, from a clinical standpoint of view, because you see a lot of patients who does not have the money, do you think even a 60,000-70,000 rupees worth an MRD is going to change or going to be health economically better and cost effective?
So most of our patients they leave treatment because of cost issues. So it's a double-edged sword. The one thing I like to add is that the technology and the science behind improving the MRD techniques is going at a rapid pace. What we see now, 5 year down the line, it will be something more better than that. So unfortunately, the trials are not keeping pace with that, and the trials which are going on now, 5 year down the line, we will have better techniques with the trials are still to evolve.
But we have to also see, Mukul, that very well said. 2 years back in US FDA never had a surrogate marker as an MRD to give the clinical trials go ahead. Now they are considering that as a surrogate marker to approve or disapprove the drugs. So within 2 years, the US FDA, rather 3 years, US FDA has moved from no to yes in MRD space. Dr. Asta.
So MRD has become the surrogate marker for the endpoint of trials in almost every disease. So that's the current and that's going to be the future. Definitely increasing the sensitivity and complementing the tests will always be helpful.
25 color flow will going to bring down the cost for us.
Let's see,
for
sir.
clinicians like us.
Let's see.
Let's see. Mosby, your take on the MRD.
Sir, of course, MRD you have to do in every cancer and every hematological malignancy that if it is there. Because with any other thing, you can't predict that how the disease is going to behave later on. But obviously, the cost is a matter. But previously, computer and phone were also very costly. So now, after using and using, you if you're using something just one, then the cost will be more. If you are using it in thousands, then the cost will be lesser.
So, I think the test more and treat less concept should Indian hematology should pick it up more. We should be testing more and treating less. That's what Mosby is.
No, you have obviously sometimes I already told that it is not all every size fits all. You see the patient, if he can spend and he can follow the everything, then I think you have to do that clonosec baseline and then follow up accordingly. But if the patient has a lesson money, then obviously just focus on treating the patient first and then follow.
So, Dr. Shruti, you have got everything in your lab. I mean, MedGenome has got every single machine in the world. How do you see the proteomics jumping on and moving ahead from the flow or the NGS MRD?
Yeah, that's actually good if we jump onto it because it's since we are the lab person, but still we also think about in terms of patient. So if you do a simple blood test, which will give you the result, I think that's better.
And we did a cost effectiveness for mass spec. Actually, the mass spec is going to be much more cheaper
Yes.
than the NGS or
NGS and
flow MRD.
Yes.
It is going to cost you like almost how much it's going to cost is 500 to 1,000 rupees. If your lab is running,
It's that the machine is costly, but not our test cost
but
is lesser.
mass spec is per test is not expensive. The machine is of 4 crores. So if you can, one Indian center can put in that machine and can run samples, it will be much more cost effective to have a mass spec based MRD if it's proven in the science. Sachin, what is your thoughts?
MRD negativity already has come into the clinical guidelines, so it is going to be common.
Perfect. Thank you, panelists. Thank you, everybody, for patiently hearing this. And the future is bright. We are going to move towards proteomics soon, and mass spec based MRDs are going to be the future. Dr. Ajay is there. Dr. Srinidhi is there because we have also seen one extent evaluated one platform called Extend, which is only mass spec based MRD, only mass spec only for myeloma. And they say you if you have got 1,500 samples a year, it will be the cost will be like 500 rupees. So every 3 months you can do the MRD. All they want is the 1,500
Yes,
samples.
sample load.
Yes.
Yeah, now the
Extend.
number.
Yes, sir.
Uh, a very good discussion. Very informative. Thanks for actually including this topic. As a clinician, certainly I would like to use MRD available by NGS and NGF whenever it is available. Actually, now we are discussing because we are at a stage when, for example, to give that analogy given by Dr. Mukul, CML, when we did not have second generation TKI, we used to question why are we doing BCML. Today, because we don't have the CAR T in India, maybe we are not using it. So that's why we are questioning it. So moment we go into that stage, the MRD will be important. But we need to remember that for there are certain problems with the MRD as on today because high risk in high risk disease, if you see that Karma trial, that people who were MRD negative and some 2 years later they had disease positivity. So, combining MRD with other modalities like whole body imaging and all will certainly be required, even if we have the as sensitive as NGS modality.
Perfect. So there are two things: radiological MRD, which is of course we know about the PET scan and the MRI. The whole body MRI is much more beneficial than the PET scan because the radiation does not go in. But अजय सर एक और इम्पोर्टेंट चीज ये है कि जब अपन 10 साल पहले या 15 साल पहले माइलोमा को ट्रीट करते थे तो हम एवरेज सर्वाइवल 2 साल बोलते थे. आज वो सर्वाइवल बढ़ के स्टैंडर्ड रिस्क में 10 साल हो गया और हाई रिस्क में डबल एट को हटा दीजिए तब भी 5 साल हो गया. So with understanding the biology of the disease always helps you to frame those trials which will increase your survival. So DLBCL में next year जो ट्रायल आ रही है, जो इंडिया में ट्रायल लॉन्च करने वाले हैं कि DLBCL में 6 साइकिल के बाद में CTDNA अगर पॉजिटिव है तो दे विल randomize between a bite therapy versus observation on the based on the CTDNA. CTDNA will be done in US. So idea is why even a single person should die. Idea of these trials and these deeper MRDs are so that we understand the disease biology, de-escalate for the people who does not require it, escalate for the people who require it. लाइक ALL में आज की तारीख में अगर हमारे पास पैसा होता, सबके पास 1 सवा करोड़ रुपए इलाज के लिए होता, तो ब्लिना और पोनाटेनिब से प्रॉमिसिंग कोई एजेंट ही नहीं दिख रहे, क्योंकि पहली साइकिल के बाद घर पे ट्रीटमेंट करते हो, MRD नेगेटिव हो तो यू डोंट गो थ्रू द ट्रांसप्लांट problems. So I think MRD and the newer technology is helping us to better define our disease biology and helping us to decide when to stop. That's how we see at this present moment of time. Okay. Thank you. Thank you, everybody.
Thank you so much, sir. Thank you, all the panelists. For the next talk, we have Dr. Mukul Agarwal, sir, who will be speaking on myeloma in 2030.
Thank you, sir. Thank you for inviting me here for this interesting talk. The talk is on myeloma in 2030, the future as you see it. We had a lot of gizmo stuff just in the prior two presentations. This presentation will be slightly down to earth. In that regard, we are clinicians and the trials, as I said, they still lag behind the lab data to large extent. For the purpose of this presentation, I have just included data which is available over last 2 years, that is 24 and 25, and hopefully I will be able to discuss and predict something which we should be able to do in 2030. There is a brief outline discussing about epidemiology, risk stratification, MRD, already done, frontline therapy, cellular therapy, and some practical recommendations. So, what are the current standards for risk stratification? So, for risk stratification, we have extramedullary disease, gene expression profiling. This might come in soon. PP53, by whatever method you want to test, this is a must. And fish, definitely for all the patient at diagnosis and at relapse. Circulating plasma cells, this can be improved further, and more and more techniques to detect these circulating plasma cells can be there. Lastly, yes, this is something which all of us do. Tumor burden by beta 2 microglobulin and LDH. So the black ones are the available drugs in India at present. The blue ones, which are there in the West, most of them will probably some of them will come into the market by 2030 with us. Isatuximab may be coming. Selinexor, yes, we had trial. Venetoclax has already come with the limited data to support it. So, like in the previous slide, for transplant eligible patients, which is the current norm to divide the patient into transplant eligible or ineligible. In most scenarios, for the standard is transplant eligible, you go for an early transplant or a delayed transplant. Most of the time, you're preserving the stem cells after 3 to 4 cycles. For standard risk, it's the limb maintenance. For high risk, early transplant always and a dual maintenance. There is data to support DARA maintenance with limb maintenance in such scenarios. Hey, the slides are not working. For the transplant ineligible patients, it's like 1 year, almost 1 year of therapy and limb maintenance, or DARA RD based therapy until progression. For high risk, it's DARA VRD or DARA VRD plus dual drug maintenance for long term. If based on the MRD, the patient have sustained MRD positive, you continue till there is disease progression. If the MRD is negative for the standard risk, you can consider stopping at 2 years. But if it's a high risk patient, you need to continue till progression. Multiple trials on cars. We all know that all cars are not same. The incidence of just to highlight with respect to the future, this trial with Celta 4, Latitude 4, where the number of prior lines of treatment were 2, and just compare it with the with the Latitude 1 trial, where the number of prior lines of treatment was 6, and the number of triple refractory drugs are pretty high. The response rate, the overall response rates are kind of similar or slightly better in the phase 1, phase 2 trial and slightly inferior in the phase 3 trial. What does it tell us? That even if we increase the prior number of lines of therapy, or if the number of lines of, if the CARs are introduced earlier in the therapy, the results are going to be somewhere in the 80 to 90 percentage range only. What about risk stratification? So just a brief shot at the epidemiology. These are wild guesses. There will be rising detection, definitely, but certain underassessment, this will persist even till 2030. We know that India is still a growing country. Younger age will be continue to be there, but a lot of aging population will be there. So the number of patients will be far more, far more. The regional disparities in access to transplant to diagnostics, this will persist. What Rahul sir is doing at Fortis, probably we shall not be doing similar kind of things at AIMS even at that time. We'll be closer, but the distance will keep on increasing. And yes, the managing the long-term survival will become a challenge. The infection mitigation strategies have to come up. Palliation and survivorship programs have to come up. A lot of things has already been said about NGS and fresh. I'll just skipping this. So emerging molecular markers will be there. There will be a role of gene expression based profiling and MRD. And probably what we need in addition will be biomarkers to personalize these therapies and reduce the toxicities. So all the new therapies, whether it's a bispecifics, whether they are CARs, they all come with their inherent risk of toxicities, which will persist even if they come in the earlier lines of therapy. So perhaps we'll need some biomarkers which will help us predict these toxicities and reduce the toxicities then and there. We all know that age is just a number, but many of these elderly patients, beyond the comorbidities, they will require all these parameters to be assessed, be social support, psychological support, polypharmacy, all these play an important role in the prognosis of the patients, as can be seen by various geriatric assessment guidelines. We commonly follow the IMWG or RMCI ones, but these things have to come up. The patient as a whole needs complete treatment, and it is to be evaluated along all these lines for better judgment of prognosis. And yes, beyond the physical needs, the psychosocial and the social needs will also come into play. Hopefully, down the line, we'll have more trials and more data looking into these perspectives. From the lab, yes, Flo, Dr. Astha, she's just left. So Flo is here and will continue to play important role, especially emerging role will be there in immune profiling of these patients, like the bone marrow microenvironment, T cell population, NK cell analysis. These will come up. Monitoring beyond MRD, yes, probably circulating tumor plasma cells, treatment response and disease progression will be there, and some prognostic markers will continue to be there. Already discussed. So future innovations will be there with respect to MRD as well. Coming to the treatment part, so uh, you know, early treatment for smoldering myeloma might become a norm by 2030. This is what I propose. Uh, there are multiple trials in this line. One of the interesting thing which I came to read about the trials is that patient acceptability for toxicity need to be there. All these trials, the incidence of grade 3 to 4 adverse events is there, and it's a realistic event. So whether you're dealing with the data alone, and there are trials even which deal with the teclistamab alone. So all these drugs, they come with their own inherent risk of toxicity. Do you want to give that drug to the patient with that toxicity even in a preclinical stage? Probably yes, some patient will benefit, but that selection of patient need to come. Frontline therapy will be more individualized for myeloma. Commonly, induction regimes, quadruplets will be there. Definitely, BCMA or daratumumab containing regimes will be the backbone. ISA-VID will be an option for our patients. Most likely, we will have MRD-based guidelines more established by then, and fixed duration or rather than continuous duration, continuous therapy will be something which will be evaluated and will have results. And there is more importance for quality of life and toxicity management. What dose of carfentanil is going to go forward? This is evident from this slide where most of the trial they're evaluating this 56 milligram per meter square per week dose. And I feel this is the dose which will go on further in the trials and will come into the market. Most likely, carfentanil being the more potent PI, it will replace bortezomib from most of our clinical practice. So stem cell mobilization has been a problem with some of these drugs. Most likely, we will have a different mobilizing regime with GCSF and plerixafor being the current standard, but hopefully, with introduction of chemo-based mobilization, problem of mobilization, the problem of poor mobilizers will be far less. Now, the most important question: to transplant or not to transplant? This will still remain unanswered by that time. That is my proposition. We will have multiple options, but all of them will be preserving stem cells after initial quadruplet regime. So after the initial quadruplet based induction, stem cell collection will be there. Here the transplant will become an option, especially the early transplant will become an option. The other option will be the continued quadruplet therapy or alternative therapies like CAR-T or anti-BCMA therapies, bispecifics. You can continue with the maintenance and subsequent MRD evolution. If there is a persistent disease after that, you can consider a transplant after repeat inductions for these patients. Why this approach? Many of the trials are having the similar kind of approach, like the Pharma 4, Cartitude 5, and Cartitude 6 trial, where stem cell transplant is still there as one of the treatment options. So I propose that it will not be retired to the museum. It has stood the test of time with all the current available therapies, be it PIs, IMiDs, or MAPs. Hopefully by 2030, we'll have more than 250 or 300 centers doing the transplant. More likely, deferred transplant will become a more commonly explored option than the early transplant. But we'll need better stem cell storage facilities if transplant is to be deferred. So most of the trials, they are preserving the stem cell at 3 to 4 cycles and not beyond that. So cell mods are something which will be the new things, which will probably replace IMiDs. Sequencing of these therapies, be it CARs, bispecific or cell mod, that will depend on the prior exposures and the depth and duration of responses. Most of these will come into fewer and multiple year relapse cases, and the non-resistant combos and clinical trial will remain the key. This is done. There's some potential issues with CAR-Ts and BiTEs, and this will persist even if they are introduced in the newly diagnosed myeloma or even at the first time of relapse. So the parties antigen escape, poor cell persistence, immunosuppressive tumors, microenvironment high cost, they will continue to remain a problem. And with biospecific, there are yes some inherent problems like one third of the patients are primarily refractory to in triple class exposed patients. There can be tumor associated factors like BCMA sink effect or extramedullary disease which have inferior prognosis. Antigen escape can be there with inherent mutations in the BCMA or GPRC5D loci or tumor interesting factors like compromised effector T cell functions. What are the ongoing trials in this field? So most of the trials are with bispecifics. Most of the trials are with CARs and some with cell modes. So many trials are going on that it's difficult to keep a pace with them unless you become Nikhil M. Kumar. The proposal is that the cell modes, that is like iberdomide or mezigdomide, they will be replacing the legacy drugs like len or pomalidomide in these settings, and the trials are active. They are recruiting, and if you see the primary endpoint, they still continue to be PFS or even MDR, CR in some of these cases. So one of the things I suppose that why it was given as 2030 and not 2050 is perhaps this. We'll have the patent of daratumumab expiring somewhere around 29 and at 31. By that time, a lot of biosimilars will explode the market. I presume, like rituximab, the cost will come down somewhere between 15 to 30 to 20,000. And more than 75% of the patient will be receiving either it in the newly diagnosed disease or at the time of first relapse. Origin has published its phase 1 data already. By 2030, the product should be available and will have good phase 2 or phase 3 data to use indigenous CAR-T for our patients. So this is the last slide. So innovations and especially the indigenous ones will be the key for myeloma management in 2030 and in India. There will be more transplant centers, more in government institutes. MRD with best available techniques, be it flow, NGS, all will be available and acceptable. Bites and CAR will be more likely to be used to even first relapse and maybe even in the newly diagnosed disease. But there is need for rational use, generates biosimilars, and a possibly national support policy. So the future will be personalized will be based on personalized medicine, integrating the MID and novel immunotherapeutics, and advocating for access, affordability, and clinical trial participation. Thank you, and I invite questions. So,
Dr. Mukul, one cannot agree more with you when you said that transplant now the more and more maybe a bit late because it's a fact that if with DARA and other such products, if you are achieving a state of deep molecular responses and perhaps the MRD inactivity also, so would transplant be useful? High dose melphalan be useful in that situation? That question may be actually pertinent, and I personally feel that if that situation comes when we are using these drugs upfront, DARA, KRD, and all, so does transplant remain relevant in that situation? So should it at all be considered as consolidation at that stage? And maybe even in relapse, today we are thinking that maybe it will be used much later in relapse, but perhaps there also with CAR T coming up. So there is a big possibility of either there may be change in conditioning for the auto transplant also, and CAR T may be much more relevant to replace transplants. Do you have some thoughts on that?
so like I said, the transplant has stood the test of times. Even the data is available that with DARA-based regimes, the transplant still offers benefits. So even now, if you are offering DARA to your patients and you still offer transplant to your patient at the early transplant to your patients, with the availability of CARs and bispecific, yes, there is a possibility, there is a strong possibility you are offering it more for deferred or delayed transplant. But the problem is that so most of these patients you need to preserve the sensors early on only. Those facilities are somewhat questionable in India and not very, I won't say trustworthy or reliable, but yes, that the feeling of deep rest is still lacking in those facilities. So most likely for at least for the Indian practice, transplant will continue to play an important role. More likely, early transplant will be offered. It comes at a pretty dirt cheap cost as compared to the other drugs. Yes, there is an inherent mortality risk, maybe around 2% with transplant, but isn't that risk present with all these other drugs as well?
Have you analyzed the incidence of relapse post data? So obviously, what we have seen that the patient respond very early and the potent response, but you have to keep on maintaining to give the data. If you don't, most of the patient relapse. So there will be, I think, role of transplantation.
There are no further questions. Thank you.
Thank you so much, sir. Next, I would welcome on stage Dr. Subhaprakash Sanyal, who will be giving us a presentation on bispecific sequencing in myeloma. Please, sir.
Good morning. I think this topic, when given to me, which is fully very coherent with the theme of the entire program, which is called HEMENEXT 2025. At present, our life is very easy. We have only teclistamab. When the triple class therapy failed, we have only one teclistamab. But there are a lot of other bispecifics are available. CAR-T is there. So how is the sequencing? That will be the main motto of this talk. At 15 minutes, I spent 3 to 4 minutes on the teclistamab, 3-4 minutes with the talquetamab, and CAR-T2. Already Dr. Mukul shown the trials of the CAR-T in relapsed refractory myeloma. I'll highlight a little bit about the CAR-T2 trial too, and then the 3 recommendations by the myeloma group. So teclistamab, we all know, it is basically redirects T cells to mediate T cell activation, cytokine induction, and subsequent lysis of the BCMA expressing MM cells. So it is basically targets the BCMA of the myeloma cells through secretion of the perforin and granzymes. It is very specific, targeted. Off-target effects are very less here. So it is administered a personalized weight-based regimen, very convenient with a subcutaneous dosing schedule. And we all know the step-up dosing schedule. Step 1, step 2, and then we use 1.5 milligram per kg once in a week to continue till there is a disease progression. Now there are a lot of data is coming, make it a 2 weekly down the line. More interestingly, it's a definite versus indefinite. Teclistamab can be used for the definite therapy or not, that is a question. And I think that will be very interesting when we talk about in hematology in the world now. Definite therapy versus indefinite therapy. So that debate always is there. Patients prefer definite therapy. Doctors prefer definite therapy. And when you do the costing and everything, the definite therapy is always more easier to handle, both by the patient and the doctor. But if some data comes, which probably will come, I believe, the teclistamab, the definite therapy, and the CAR-T is again the definite therapy, then I think the match will be more evenly placed. That is my idea about what will happen in coming 2-3 years. So Majestic trial, which is actually the key trial of the teclistamab, it is a first in human, phase 1 to open level, multi-cohort, multi-center dose escalation study to evaluate teclistamab in relapsed refractory myeloma. So what is the criteria most important here? At least triple class therapy. So triple class therapy means bortezomib, pertuzumab, IMiDs, DARA, all three failed. And when there is a triple class exposed and then on the last therapy, the disease is progressing. So that is very important. And no prior anti-BCMA therapy allowed here. So that is the whole idea about this eligibility criteria of the Majestic trial. You can see here, it's a beautiful demographic characteristics, covered everything. Bone marrow plasma cells more than 60% is almost 11%. High-risk cytogenetics, almost 25%. So almost one-fourth of their cohort is actually high-risk cytogenetics. Extramedullary plasmacytoma is again almost 17%, which is almost 20%, you can say. Triple class exposed, all 100, and pentagram exposed is 70%. Prior lines therapy, they already discussed with you. So if you see in this entire cohort, so almost 78% of the triple class refractory and 26% patients had a high-risk cytogenetics. It is a disease profile. So if you see the response, you can see the overall response is almost 63%, and the CR rate is almost 46.1%, almost half patients, with a deep and durable response to 2.5 years of follow-up with patients with triple class exposed relapsed refractory multiple myeloma. So if Majestic trial is a 165 patients pool, so they took some pools of the Chinese data, some Japanese data, and has increased that patient pool to 217, and the overall response rate is almost same, almost 66%, with a CR of almost for 50% and VGPR of 63%. In Majestic trial, one more thing is very important here. When you are using this drug, teclistamab, so if you use around 3 triple class failed, then your response rate is 74% with a CR of 60%. But if you delay, then your overall response rate comes down to 50% with a CR is 41%. So bottom line is in clinical practice, when you're triple class refractory or triple class failed, then bring teclistamab as quick as possible in your lineup. You can't wait a big player who can hit 6 fours at the 8 down or 9 down batsman. So you have to make the batsman more earlier. And I'm pretty sure that Amukul already told that down the line, the teclistamab will be pushed much earlier. The high-risk trial, high-risk diseases, we know that a lot of trials are going on with a DARA teclistamab combination and all these things. So best batsman, he has to prove that he's the best batsman. That is very important. But at the same time, when you prove that he's the best batsman, he should be pushed earlier in the T20 or T50 matches. So you can see here, this is a beautiful slide, I believe. You can see all risk groups. So overall population is a 63% response rate. But if you dissect that, into the refractory, almost 60% response rate, in the CR of 40%. High-risk cytogenetics I already mentioned. Age more than 75. So older people, right? Older people, when you are 75 plus, 82 octogenarian population. But also it does really does wonder. Bone marrow plasma cells more than 60, extramedullary disease, ISS stage 3. So all across the class, it is responsive, very, very comparable and durable. So in heavily pre-treated patients with prior exposure to Citro, Majestic trial, there is no prior BCMA therapy was allowed. With prior exposed to BCMA targeted therapy, teclistamab showed a promising overall response rate, median PFS and median overall survival, and responses occur early, depend over time, and were durable. That is very important. So if I summarize the trial, the teclistamab has demonstrated efficacy across patient subgroups, including high-risk patients, patients who have received prior BCMA targeted therapy, and patients with triple exposed relapsed refractory multiple myeloma. And the most important, the Majestic trial efficacy has increased in patients with earlier lines of therapy compared with those in later lines of therapy, supporting the use of teclistamab earlier in the treatment course for patients with a triple class exposed relapsed refractory multiple myeloma. So 2.5 years follow-up. There is no new safety signals. We all know that CRS, cytopenia, infections are the common complications. We know now the prophylactic tocilizumab becoming in a big way, which reduces the CRS significantly, and there is a 65% relativity reduction. The trial is already on. People are trying to figure out that how can you reduce the CRS. ICANS, hardly may see, only 3%. Though in my personal experience, I had a very bad ICANS experiences with the grade 4 and I lost the patient also. But generally in the trial, and if you see the overall perspective of the colleagues' idea, that we don't see much ICANS here. Infections, yes, but if you are moving to the Q2 weeks schedule, the infections down the line is coming down, and generally don't require any dose reduction and dose changes about that. So this is the overall just a glimpse. Screening, what we do, prophylaxis we all learn, IgG replacement we all do, growth factor support we do, and monitoring we all do. CRS neurotoxicity infections, we are all learning that. I'm not going into details. I come to a little bit about the talquetamab. How it acts? It's a different target. It binds to the CD3 receptor expressed on the surface T cells, it's the same thing, but it acts on the GPRC5D receptor expressed on the surface of the multiple myeloma cells, and most important, non-malignant plasma cells, as well as some healthy tissues like epithelial cells, in keratinized tissues of the skin and tongue. So there are some off-target side effects you can expect here, like a loss of taste, like skin toxicity. This can be, you can see in this particular drug. Dosing schedule is almost same principle, same philosophy, step-up dosing. And if you see the trial, the Monument trial, we have a 3 cohort, 0.4 milligram per kg weekly, 0.8 2 weekly, and 0.4 and 0.8, whatever you do, but prior TCR is allowed. So prior anti-BCMA, ADC, CAR-T, or bispecific followed. The clinical criteria, again, the baseline is very nicely managed. Overall response rate, you can see almost 74%, which is quite exciting. And across the group, it is see around 60 to 70%. High risk cases, which is almost the same, or is very comparable. The most important, T-cell reduction therapy exposed cohort, longer follow-up. This is the baseline characteristics. Efficacy outcome is quite well preserved. It is the same thing. And this is the summary. We are seeing that. I will talk about little bit about this trial, about efficacy and safety of the cilta-cel in patients with progressive multiple myeloma after exposure to non-cellular anti-BCMA immunotherapy. This is the Gratitude Trial 2, Cohort C. I just focus on the Cohort C. This is the trial design. If you see here, the most important thing, the response to cilta-cel was associated with a shorter duration of exposure to last anti-BCMA agent and longer time from last anti-BCMA treatment to apheresis. This is a safety, nothing more. It is a clinical benefit in this population that was previously exposed to anti-BCMA therapy and more heavily pretreated than Cartitude-1 patients. That is the most important thing. Now I'll spend a little bit 2-3 minutes about these 3 slides, last 3 slides. How you do the sequencing, that is very important. So when you use PI, IMiDs, monoclonal steroid, don't worry at all. You can use either any sorts of T-cell engaging therapy. Only thing, aim for a 2-week washout between the last dose of PI, IMiD, monoclonals and the apheresis. And most important, avoid high-dose alkylator, bendamustine prior to TCR therapy. And if you're going for CAR-T, aim for a 4-week washout. That is very important. Suppose you have all the equal access, so ground is very leveled. So pursue BCMA targeted TCR ahead of BCMA targeted ADC, given its higher efficacy. That is number 1. Why? Because more robust data support activity of the TC following relapse post CAR-T than vice versa. Both BCMA and GPC targeted therapies, immunotherapies are safe, active in patients with prior BCMA targeted CAR-T therapy. However, response to BCMA targeting therapy are likely less frequent and durable. And for patients progressing on a BCMA targeting TCE, recommend therapy with a different target agent or attack the different antigen. Disease burden, where the disease burden is too much, I think the epistemic or the bispecifics are the more easy because you have to put long time about the CAR-T, apheresis, all these things. Or if you collect the CAR-T, you can start something, don't wait the disease to float and you can lose the patient. This is more simpler slide. So 3 drugs, 3 therapies, BCMA targeted CAR, TC and a BCMA targeted ADC. BCMA targeted ADC is approved in Europe, you know that. Patient with equal access again. So prefer CAR-T over TC due to more robust data on TC activity post CAR-T and extended TFI and CAR-T offers. TC prefer TCR over ADC due to their higher efficacy but reduced TCR efficacy post ADC. That is very important. And in patients with rapidly progressing disease at risk of mortality during the CAR-T manufacturing period, prefer TC over CAR-T for faster access. And my last slide. It is IMWG recommendation sequencing. So holding therapy, TC calculated, PI and IMiDs and monoclonals is fine. You collect apheresis, bridging therapy, and then BCC targeted therapy. If disease progresses after CAR-T, you can always go for the GPRC based targeted immunotherapy or BCA With the targeted immunotherapy, the efficacy may be little reduced. BCMA targeted TC until disease progression. If there is a progression, the therapy with a different target agent. Thank you.
Thank you, sir. So we will take the questions in the next break. We will now move ahead with our keynote lecture since we are running behind that.
Pardon?
We are running a little behind time,
Sure, sure,
so
sure.
we will move ahead with the
Thanks.
keynote. I request the stage to be set up for keynote. Meanwhile, I will introduce our keynote speaker for the conference and the highlight of our conference, none other than Dr. M.B. Agarwal, who needs no introduction, who needs nobody. I am too small to even introduce him. We all know he comes all the way from Bombay. We know everything about Mumbai Hematology Group. We know what fantastic work he does. And we will be talking about Ask the Stamp Expert Asiminev, redefining the first step in chronic myeloid leukemia management. Dr. M.B. Agarwal is a very renowned hematologist and hemato-oncologist, and I think, sir, the applause is enough. I don't really need to talk about all of this. And I think, sir, would you want to invite your panelists on stage? Sir will invite his panelists on stage. The session is sponsored by Novartis. Thank you.
Well, thank you so much. First of all, I've not come all the way from Mumbai. I love to come to Delhi. Invite me and I'll be there. And even if you don't invite, I will be there. Chronic myeloid leukemia. Only a novice will say that we have conquered this disease. Lots in CML, despite all the advances in last 25 years towards its molecular biology, its laboratory diagnosis, monitoring, PKIs, first generation, second generation, third generation, we are still far away from conquering it. Look back in those who are practicing CML, less than 10% of patients are off treatment. That means we have a huge goal of doing a lot for the remaining 90%. And to that, we have our excellent panelists today, and thanks to the organizers for giving this panel to me, and that is both Novartis as well as Dr. Bhargav. Brigadier Dr. Satyaranjan Das, it's all your game today. Dr. Meet Kumar, where is he? Problem, okay. Dr. Sanjeev Kumar Sharma, he is very much there, of course. So, Satyaranjan Das, you are as good as Delhi. Though you are from closer to my city. What we are going to see today is number one, what have we not achieved? And I just set the ball rolling of what we have not achieved. Can we destroy the stem cell that is the genesis of CML? The answer is no. Do we know how to treat which TKI should be used for the first line? We don't know. What should be the dose of a particular TKI? We don't know. What's the ideal time to stop the TKI? We do not know. How to manage the side effect profile of the TKI? We do not know. Do we know the patient's profile? Who should get what? We do not know. And lastly, as I started, we have conquered only 10% of patients for even the biological cure. So we have a long, long, long way to go. And we have an additional little drop in the ocean of our failures, and that is a victory of this new kid on the block, Asiminev. And we'll see today how some of the questions which we've just raised have been answered. So Satyaranjan is going to tell us a lot of fallacies which we think we have conquered, but we haven't. Meet Kumar is now here. We are hiding from the... Okay. So he is going to tell us what is this new baby. And then Sanjeev Kumar is going to fine tune probably tell us about which patient, what to do, etc. So we will in these 30, 40 minutes tell you something which you might be wondering in your practice. Disclaimer, then basic succinct statement, agenda, unmet needs. So from Pune, deep response seeker and quality focused, couple of case-based discussion and then the summary. So yes, Dr. Brigadier Satyaranjan Das, what are the significant unmet needs in the management of CML patient?
Sir, thank you very much, sir. You have already told that sir, only that 10% of the patients are achieving what is required and 90% are not. So when TKI came here, this is coming as a magic bullet. Did it actually do the magic? Maybe to a certain extent, but you are right, sir. Only 10 to 15% probably achieved BMR or TFR, rest all not. So there are great unmet needs still exist in the CML patients. To me, it looks first more two important things. One is the first one is a newly diagnosed CML, and particularly the young newly diagnosed CML. Among them, particularly ladies, those who want motherhood. They come as a CML patient and what to offer and how they will continue motherhood. They will have their motherhood. That's a big unmet need. So what they want, their goal is that you do a DMR early and a TFR early. With the TKI, we are not achieved to do that in most of the cases, maybe around 10 to 15%. Maximum that will achieve a TFR by around 5 years or like that. That's also not so happening in India. So that is the most unmet need, that a young patient whose target is that I have to be off medicine, that is not met with TKI. Even the best TKI, we may achieve 10 to 15%. The another one unmet need is those are already under treatment with TKI. Either they are not tolerating, their quality of life is not good, or they are developing some kind of resistance for whatever reasons, the response or that they are not achieving the target that is required to achieve. In those cases, again, to give them a good quality of life or to help them stop from disease progression, we need something more like asciminib so that we can give them a progression free period and a good quality of life. I think, sir, these are the two unmet needs we are looking forward for, and they needs to be tackled. Not probably TKI is not going to help so much in those two scenarios.
Thank you, dear. So let me take you through some slides to explain what has just been told to you. How many of you are treating CML in your practice? Just raise your hands. So good number. So our panel discussion is relevant to you. So what this first slide tells you in the bottom part is in a new case of CML CP, TFR, and for that achieving EMR, DMR, MMR, and all that in a sustained fashion is an extremely important step. First of all, 10% of your patients do not come in the chronic phase. They are already in accelerated phase of blast crisis. So we fail straight away in those 10% of patients. Second, those who come in the chronic phase, there's something called early chronic phase, something called late chronic phase. In India, more than half the patients come in the late chronic phase. If you are in a situation like in the working at RRR or AFMC where everybody is screened every year, if I'm not mistaken, so people can come with my count is 12,000. Why is it? And then Satyarajan says 12,000 is because of CML-CP. So that's a very, very early case. We are not that fortunate. Our patient comes from last 1 year, I am sick, my count is 300,000 and my spleen is 24 centimeters. Hemoglobin is 7 and the platelet is 10 lakhs. So patients come very late, or the patient's biology is that they come very late. And you rightly said, half of the patients are young. So they are not talking about a life of 5 years, 10 years. They're talking about a life of 40 years. So they have to be cured, or else they will be taking a imatinib for 40 years with all its problem. Okay? So you have to think of all those lines. The second is the quality of life, which you rightly said. Now, those of you who raised your hands, 80% of you are giving imatinib to a patient, either Max Foundation, free drugs, so you are used to it, or cheapest drug, 1,000, 2,000, 3,000 rupees a month. So most of the patients can afford it. In the bargain, your patient is destroyed. He's puffed. His skin is depigmented or pigmented or hyperpigmented. He's got fatigue. He was working for 12 hours a day. Now he's working for 4 hours a day. He can't even run a panel discussion for 40 minutes anymore. That's the degree of fatigue. You may have GI disturbances. Either he can't eat or he overeats. He gets stomach disturbance. He gets diarrhea. He gets constipation. He's searching for a toilet around. So GI disturbances, fatigue, skin changes, skeletal muscular pain. How much paracetamol do you want to give him? So there's so many symptoms because of that imatinib. By any chance, if your patient is like my patient, big spleen and high count, you want to give 2G TKI, then that guy may die of myocardial infarction because you give nilotinib, or gets a gangrene of the leg because you give him nilotinib, or gets recurrent pleural effusion because you give him dasatinib, or gets pulmonary hypertension and dies because you give him dasatinib. When ponatinib was tried as first line, 2 people got myocardial infarction, succumbed. Ponatinib was removed from further trial in upfront cases. Dasatinib never became popular because it causes terrible GI disturbances and the liver problem. So all your drugs which you've used so far as your first line therapy have problems. So quality of life of a patient who has to take this drug for years because you can't achieve the goal of TFR, as you said, you said 15%, I said 10%. So 85 to 90% of patients probably have to take it for their whole life if it is working. But then what is the quality of life? That means you are searching for something which is more effective so that your first goal of TFR can be achieved by having a rapid EMR, rapid DMR, and so on. And the second is the quality of life, that the patient should remain as asymptomatic as possible during the treatment. And this is what is shown to you about the outcome of taking first or second generation TKI, which we have been doing for last 20-25 years. What you see over here is MR by 1 year, MR4 by 2 years, MR 4.5 by 2 years. First, you see with imatinib, nilotinib. Second is imatinib, dasatinib. Third is bosutinib. So none of these figures are very satisfactory. But that is all what you are achieving despite 20-25 years of that. And this tells you that if your BCR able level at the end of 3 months is more than 10%, it is terrible. If it is less than 10%, it's a little better. Less than 1%, then it is probably the best. But we don't achieve that in significant number of patients. What this tells you is that even at the end of 10 years, 88% of the patients are on treatment. Long-term treatment negates the patient's quality of life. And there is increased focus today on the quality of life as we just talked about. Adverse effects. If I get fatigued, if I get diarrhea, if I get skeletal muscular pain, if my skin is becoming bad, then what will I do? I'll stop the medicine off and on, or I'll reduce the dose without telling you, or take drug holidays, and so on. So patient's compliance takes a toss. This patient doesn't tell you that he is doing that, and you find that the BCR able is still not coming under control, and so on. So all the inconsistencies in the treatment are related to the intolerance to the drug. And intolerance therefore leads to the non-adherence, which reduces the chance of ultimately the TFR, which is your goal. If you ask the patient in the center that is shown over here, stop or slow the disease progression is the goal for half of the patient. Maintain or improve the quality of life is the goal for half of the patients, which we are not looking at. And why does all this happen with first and the second generation drugs? This all happens because we are giving a drug which is very non-specific in its site of action. It's the ATP binding site where these drugs are working, and this is sort of an ocean in the body, and therefore every organ is getting damaged. Whether it is heart because of nilotinib or ponatinib, whether it is lung because of dasatinib, and whether multiple organs because of imatinib. There's a study from AMI, which Dr. Das will know very well. The GFR, after 10 years of taking imatinib, gone. The kidney is fired. This is a study published from India, from Dr. Das's center. So there are very slow toxicities which we don't realize, and we give the drug for years and years and feel very comfortable. Max Foundation patients are taking imatinib for 20 years plus. So you have to be careful. So this slide summarizes this all, that imatinib, weak drugs, 2G TKI, toxic drugs, and we need a new molecule. So this unmet need was felt, but there wasn't a solution. And today we'll give you that solution. So, Dr. Meet, we come to you now. Sorry, you've been listening to dialogue between two of us. So, what is the modern approach to CML? What is the solution to all these headaches which we just talked about?
Sir, I think you have very nicely summarized in the sense that what are the problems, and now what we need to discuss currently is where are we heading towards. So I think this is the right moment to discuss these things. And these stamp inhibitors that have become available, so you're saying that it's an ocean of problems that the medicines, the first and the second generation TKIs are trying to address. In that perspective, if we get a one place where a specific molecule can go and bind without affecting other sites, that is something what we want, so that the efficacy is increased and the side effects are reduced. The stamp is specifically targeting ABL myristoyl pocket. That's the answer probably. And the myristoyl pocket is the place in the ATP binding site of the sort of ABL BCR-ABL molecule, and that is being addressed by this new molecule asciminib. I think this is what is going to help us prevent the off-target side effects and give more efficacy by binding to the right location and increasing the efficacy of the molecule.
Okay, excellent. So we are not only raising question, we are giving a solution. And this solution, as you see on this slide, while this new kid on the block, the asciminib and how it works was just told to you, we are acting at a very different site. No more we're talking about the ATP binding site. So it's different. Okay, first time it's a different molecule. US FDA gives approval to this molecule 4 years ago after the failure of second line of TKI. So you treated your patient with some two TKIs. After that, if there is a failure, what do we do in India? Transplant. Not fit for transplant, can't afford transplant, no donor available, etc. Leave him to nature, leave him to God, leave him for some kind of inferior therapy. You keep trying various agents. By the time he develops a blast crisis and succumbs. Not only that, what happened last year, US FDA approves this for the first line treatment of chronic phase chronic myeloid leukemia. And forget USA, this year, India, in May, approves this molecule for the first line treatment of CML chronic phase. And with that approval, the advantage is that the PAP gets in. That Novartis is able to help you, this patient, financially. What do you want in your patient? You want a molecule which is most effective, not just better. And we will show you today that this molecule is most effective. Second, you want the safest, so that the patient is not tortured. His quality of life is not distorted. I will show you today that this molecule has the least adverse effect profile. And not only this in the third line, fourth line, but upfront when it is used in a newly diagnosed patient. What you want is the convenience of administration. Melatonin twice a day fasting. Here is a molecule which can be given once a day. And lastly, the cost factor. Approval gives you the PAP, and that gives you decreased cost. So, Dr. Sharma, now your turn. How do we best identify and select a patient who are either deep response seeker? Dr. Das told us a lady wants pregnancy. So you want a deep response as fast as possible, or the quality of life focus, because you have to take the drug for a long time. So let's see your case profile.
Yes, sir. So, as already discussed, and everyone, whoever is having whatever disease, nobody wants to stay with the disease, and also nobody wants side effects because of the disease. What in case of CML, like here, what we can see is that who are the deep molecular response seekers are those whom we can give a treatment-free remission early, as soon as possible, and as for as long as possible. So, a young working male or female, whatever, but in case of females, like they are planning for family, in that case, it becomes more important that they take the treatment for a few years, maybe 2, 3 years, then stop the medicine, and we can continue monitoring them and they can have their normal life, uh, family planning. That is one aspect. Another, anybody who is young, working male, or any other in that matter, who also needs a good quality of life and he doesn't want to get tortured by the medicine as side effects, as everyone is discussing the side effects. So these parameters, all young healthy adults who want treatment, are the target points where we can achieve deep molecular response and can give them a treatment free remission, which can be achieved by a medicine which acts fast and acts deep. So And particularly elderly patients also, we do expect them also, sir, that they can become treatment free, in the sense they are already taking treatment for their comorbidities like hypertension, diabetes, and many other problems. In those patients also, we can reduce the drug interactions by giving some medicines which can work for short time and can achieve a longer remission times. So ideally, everyone needs this deep and molecular response and better response. But yes, young females and males, hardworking, working, are first priority.
Absolutely. So, in front of you is a young lady, Indian, 35 years old, married, has no children. She's just been diagnosed with a CML with a transcript which can be easily monitored, and she has a low risk disease. Chance of her being put on imatinib by you and me is extremely high. Low risk disease, put her on this drug. Now, she's being told that what all can happen to her. So this slide tells you that what will happen is the face will get puffed up, the skin will get discolored, she will get fatigued, she will not be able to work to the her potential, and so on. She is aghast. She is concerned about her cosmetic appearance. She is concerned about the duration of hours for which she can work, etc. So she needs something better. And on top of that, she is 35 and she just married. She has to have a baby very in near future, as fast as possible. And you ask her that, okay, we get you to the DMR, we get you off the treatment, maybe few years, maybe 8 years, she will be 40s plus. So you want something which can do the DMR as fast as possible. That DMR 2 years, and you can take her off the drug so that she can go for pregnancy. Now you look over here, the treatment milestones which are achieved by the older generation of TKIs. So you've got the various trials in the first column, you've got the duration of follow-up in the second column, you've got the name of drugs, TKIs in the third column. Now you look at the MMR achievement. You look at the MR 4.5 rates. You look at the discontinuation because of the lack of efficacy. It's not the best. But then that is what we have done till today. Therefore came this trial. If you see in the green in the last column, that is asciminib, 80 mg once a day, versus what you see is the control arm, which got one of the existing TKI, imatinib, or any one of the second generation, bosutinib, dasatinib, nilotinib, and so on. Equal number of patients, large trial, 405 patients about the age of 18 who have not been exposed to any treatment so far. And now look at this, the MMR and the MR4 results at the end of 2 years. And the bar, which is the tallest, is the imatinib bar. So the drug upfront used is more effective and faster effective in achieving the goals than all other TKIs that are available to you. And the side effect profile, if you just look at the numbers on the right side, which is for the imatinib, and the left side, which is for asciminib, except for thrombocytopenia, which is matching, all others are lesser figures. And the one which is put in the red circle is almost nominal, it's almost non-existing. Similarly, if you see the second generation TKI on the right side in blue, left is the asciminib. Once again, look at the figures, they are less, and look at the circle, it is markedly less. So side effect profile of this particular molecule gives you the best chance of having the better quality of life. And here I want you to see at the last column, which is put in the box. ASC is asciminib, 4 means 4 other agents, and first is asciminib used as the first line of therapy. So that is S4 first trial. And look at facial puffiness, rare. Skin discoloration, rare. Fatigue, less common. Key concern, general well-being, excellent. Work-life balance, minimal impact, and therefore long-term use is favorable. Second case, which also he discussed so beautifully, is a 45-year-old man. And in short, if I can summarize this, he wants to work to the maximum potential. Murthy ji has said that you should work for 12 hours a day, 6 days in a week. Now forget that. I want to work for 3/4 of that. For that, I have to have enough energy. So if I have to take TKI, how do I follow the principle of Murthy? Most of the patients of CML, when they are diagnosed, they are asymptomatic. Say the example of Ami. They are asymptomatic, and even in your and my practice, they got minimum of symptoms. The moment you start them on treatment, they become symptomatic. Everybody has got something or the other. And that's why the quality of life, see the curve on the right side, takes a big dip. And these are formal studies which have been published. So decreases the quality of life, the treatment gets discontinued, the doses get reduced, there is a non-adherence, there is a switching. And look at all the side effects, which I don't have to tell the audience sitting over here. There's imatinib, dasatinib, whatever drugs. There are all side effects which all of us see. As a result of which, what happens is shown on the right side over there. Patients change from the full time to part time, or they leave the job, become unemployed, or they take early retirement, or they stop working temporarily, or they increase work because of the cost of the treatment. So these are the effects of the treatment that we are giving to the CML patients. If you look at the adverse effect profile, once again, we have talked about asciminib is the best. Same thing is shown over here. We have seen this earlier. Same thing is shown over here. The discontinuation due to the treatment due to asciminib was 16% versus due to imatinib 46% in the red box. And our discontinuation due to treatment of asciminib 19% versus second generation TKI 30%. So I think from the published data, from the authentic data, from the research that's available to us, we understand a lot why asciminib is more effective and less toxic. Your 8-year follow-up published by Hokus and presented in the ASH meeting last year of asciminib, giving you an MMR rate of 66%, which is highest for any other drug. And you have a long-term outcome of 8 years for the side effect profile. No new side effects developed in the second half of that study, which has gone on now for 8 years plus and has been, in fact, concluded. Before I summarize, I request Meet to summarize what we have discussed so far in the next 2 slides.
Sir, what I understand is the molecule, the new molecule on the block that we're discussing has got the best potentials in terms of improving the efficacy. As we discussed, the MMR rates are good, the DMR rates are good, and they are the best as compared to any of the molecules that are available as of today. And when this efficacy comes at the cost of less side effects, that is what I think the most favorable patient-friendly drug that is available so far. Cost definitely is an issue, but with the access and the more affordable sort of availability being provided by the providers, that is the PAP program, this makes it a bit affordable. But still, I would say all the things said and done, but cost is still a limiting factor. But times to come, definitely this will also become more affordable, and more patients would be able to afford this type of drug, the wonderful drug.
Thank you, Meet. I will like to conclude by saying 3 ways you can approach your patient. And that will give you a way for each of your patient to each one of you. So I practice in Mumbai. I sit in Dadar. On left side of me is Malabar Hill. And on the right side of me is Dharavi. I work in 5-star corporate hospitals and I work in government municipal hospital. This fellow earns in crores per year. For him, everything is possible on the earth. For this man, even the food per day is a difficult thing. Okay? And you as a doctor has to treat both and all the in between. So we're a huge upper middle class today, courtesy of our Prime Minister, and your middle class also. Curve is moving from this side to that side, so you and me will be able to treat a lot of patients of Malabar Hill type, and we are having a good number of those patients. So what is your approach? 1, for the Malabar Hill. Best molecule, most effective, least toxic, can be given with all comorbidities, so that you have a quickest MMR, DMR, sustained DMR of the medicine, highest chance of TFR. So that is asciminib starting, asciminib continuing, asciminib at the end of the day stopping, and see whether the patient has achieved the TFR. The other end, Dharavi patient, starting with imatinib by one or the other method where it is possible to give him the cheapest possible drug. Let him accept some side effects. Let him take it for years. Doesn't matter because he can't do anything else. Try to achieve the DMR one day, have the sustained TMR, try to stop it and see that he has got his TFR, which you will get in those 10, 15, 20% of patients at the most if possible. Somewhere along the line, If you feel that the drug is failing, move on to a more expensive drug, which may be second generation TKI or which may be asciminib if by some method you can do it. So starting with the cheapest, maybe a weak drug, but moving on to a stronger drug is the second method of approach. And the third approach is the upper middle class or the lower middle class. He wants the best, but for a short period because he can't go on with it. So when you tell him the cost of asciminib, yeah, I can't take it for 10 years. So no, you take it for a couple of months. Let me get you into the DMR and then I'll give you a cheaper drug, which is a reasonable approach because you cut down the duration for which you will continue to take TKI and the chance of finally stopping and TFR can go up. So starting with the best drug, continuing it till your TFR, starting with a weak drug and then changing to an expensive drug because there is no other way, and starting with an expensive drug like asciminib and then within a short period cutting it down to a cheaper drug. So you could probably have a patient profile which can fit in these three. Depending upon you're working in a government hospital, municipal hospital, draining poorest to the poor, the third one may be the approach. And you're working in a corporate hospital where everybody with a coat and tie walks into a clinic, maybe first is the approach and then of course the central one. But you need to know that there is a molecule on the horizon which is superior, which is safer, which can be given with all comorbidities. You had myocardial infarction, it can be used. You had a CKD, it can be used. You had a cirrhotic liver because of alcohol or anything, it can be used. You got a very high tumor burden, it can be used. And I would say you got a minimum of the asymptomatic disease with 12,000 WBC count, earliest. If you give him the best molecule, he's got the highest chance of getting rid of the disease. Now, when I entered, you were discussing MRD in multiple myeloma. And there's a lot of discussion, should do MRD or not do MRD. I mean, it's a question of only finance. If I can do MRD and the patient can afford to do MRD, why should you not do MRD? Because any patient who can afford daratumumab and can afford teclistamab, he can afford 10 MRDs. So this question is out. You need to do the MRD for the patients on whom you can take action based on that MRD. And today, you've got the action available. In CML, you've got today a molecule which is little costlier than the other drugs, but is best. That's all what I have to say. We have time left for question answer. We would like to answer your questions, and the panel has to have patience to answer them. Please. I hope we have raised a lot of questions rather than solved everything. So 10, 20 questions. Yes, please.
Said to be a bullet and the best treatment. And today, over the years of 30 years, since I was going in mid-90s, now we have all large number of side effects it causing. Maybe with SNF, another 10 years down the line, we may have much more side effects. Certainly, from the bullet, we have moved to the missile to hit the CML, but I think it will be long term when we will know what are the side effects which are developing over a period, what we have learned from imatinib first or second generation.
So, excellent question, but this was a question to be asked in 2018. You're asking in 2025. So, as I said, Hocus has published 8 years data. It's not 25 years data, but 8 years data. And last 5 years of that 8 years data, no new side effect. So yes, you can have 25 years of data one day. I will not be there in this world for the 25 years of the data, but I am convinced enough that in 5 years there is no new toxicity. It's very unlikely that you're going to develop a new toxicity in the 6th year or the 7th year or the 8th year. So we've got 8 years data of this drug. So this question probably we have an answer today.
Answer one more thing in the answer to sir's question. It's off target that attacks are less, and so the toxicity profile is less because of its novel mechanism of action.
Absolutely. I should have said that as well. Thank you very much for adding this. So if you have those diagrams showing you the off target are non-existent virtually. That's why the least of the toxicity because of this particular compound. But of course, many other drugs being tried on the same pocket. We will have better drugs from this also. There are drugs. This has to be taken fasting. There are drugs under trial which can be taken without fasting. So we will have that one there. This drug can be I forgot to mention one very important point. For 315 mutation, this is an important molecule like ponatinib. Okay? And the dose is 200 milligram twice a day. Dr. VP Singh. The dose is 200 milligram twice a day. So dose is 400 milligram per day against 80 milligram for the standard. And the drug has survived because free from toxicity. Okay, so 315, 400 mg per day, routine patient 80 mg per day, and no side effects or the same side effects. So we know a lot about side effect profile of this particular molecule in five-fold the dose. While imatinib, when it was made from 400 to 600 in the Australian trial, it flopped. The side effect became so many that had to come back to 400. Nilotinib, 300 to 400, we had to come back to 300. Dasatinib, everybody knows the story. 140 to 100 to 70 to now 50. Because pleural effusion and pulmonary hypertension, I was a part of decision trial, first line, dasatinib. Paper was sent to Blood Journal for publication with 6% incidence of pulmonary hypertension. 6 referees, they refused. They say that means 6% of the patients will die of dasatinib because pulmonary hypertension is writing a death. So we cannot approve this drug or cannot publish this paper in Blood. Contagion was strong enough, we still got it published in Blood. But then that is what happens with a drug like first and second generation. Here you got a drug which can be given in 400 mg without problem, and you have to use only 80 mg. So I think we know a lot about the side effect profile. And those of you who have used asciminib, your patient never comes to you for side effects. I have a large number of patients, so I have a good experience of asciminib. Patient has stopped coming because of the intolerance. He comes only occasionally for intolerance or never comes for the intolerance. While imatinib, nalatinib, dasatinib, ositinib, you ask patient and you ask for one thing and he tells you 10 side effects. So long answer to your short question. Yes, please. Yeah, you. Yeah.
In your, I think diagram you showed thrombocytopenia is little higher.
Not higher. So thrombocytopenia is identical to the other drugs, but it's a transient problem. So you have to be ready with myelotoxicity of all the TKIs to begin with. Dasatinib is the worst where you face severe bone marrow toxicity. Thrombocytopenia you have to be careful about. And sometimes you may have to decrease the dose or stop the drug. That's temporary. Nikhil.
Wonderful discussion as you.
Thank you so much. Anything coming from the Nikhil is a stamp. Thank you.
That's very kind of you. I have more of a comment to make. We have experience of using high dose asciminib in two subgroups for which it is not approved. One is CML myeloid blast crisis, and second one is Ph positive ALL. We used it more out of desperation because both these subgroups, we had patients who were ponatinib refractory, intolerant, or there was progression of disease on ponatinib. So for the Ph positive ALL patients or even the lymphoid blast crisis, our go-to regimen was mini hyper CVD, I know, with asciminib. And after 2 cycles, all of them got into a deep response, flow MRD negative, and even molecular MRD of acceptable range, and we could take them to a transplant. And post last follow-up of around 5 to 6 months, all these patients are doing well. We had this publication in Leukemia and Lymphoma. It is published this month. So the point I was trying to make is even in these group of patients who are ponatinib refractory, higher dose of asciminib, 200 milligram twice daily, was very well tolerated. And these patients who have otherwise gone on palliation or a progressive disease, we could actually get them into remission. So that is something which we would.
That is why I say when Nikhil says it's a stamp, what is important is publish. So thank you very much for publishing this because that makes it more authentic because you got a peer-reviewed journal that accepts your paper, publishes it, it's available to all of you forever. So it's very, very important. Thank you so much for collaborating that.
Sir, can I ask a question to you, sir?
Yes,
it's me.
Yeah.
So you told that in the middle segment, you're saying, sir, to start with asciminib and switch to reasonable this thing. So how convincing that is? Does it not increase the chance of resistance?
So I was telling you that I'm talking about the group that yesterday couldn't afford anything, but courtesy over PM now belongs to the upper middle class. So when you tell them that you start with asciminib They ask you for how long? I say it's for very long. So he sits and calculates. He say, okay, 1, 2, 3, 4, 5 years. If I have to take it for 5 years, this will be the cost. I say, wait, is that a problem? He said, that's a big problem. I say, if I tell you that you have to take it for 6 months or 1 year, he said, then it's practical, it's possible. I said, you take it for that, let me get a DMR. And then maybe because you can't afford it anymore, I switch over to a lower drug. Maybe you will not relapse, and maybe I will be able to put you into the TFR. So this is a practical problem which you will face every day once you start prescribing an expensive drug. But patients can take it for some time, but they can't take it for lifelong, or they can't take it for very long duration. Not that this is a Ramban and every patient is going to get TFR successfully. So there will be patients who have to take it for a long time. So you have to have a way out. And I think what I said is theoretical is not theoretical. All these three groups will take care of all your patients. So you've got a lower class, you've got an upper class, and you've got this middle class. These three approaches will take care of all your patients. And you have to make a joint decision between the patient and you.
So one question from me also. So as hematologist, oncologist, like in myeloma, first we started with single drug, then doublet, then triplet and quadruplet. Today we have got drugs with two different mechanisms. I saw some new trials going on, combination of TKI, and although intolerance and toxicities are more in high risk disease, in blast crisis, all those. What is your experience? Have you ever?
Absolutely. I mean, this is a sponsored session. So we are supposed to discuss what is approved. So everything that we discuss was approved. But if it was a lecture, I would have given, there's a lot going on combinations. And we have slides for that. I'm giving that talk in Raipur next Saturday, where I have been allowed to give a lecture without any compulsion of published data or approved data. So you have data on asciminib, nilotinib, same company, asciminib, dasatinib, two different company, asciminib with imatinib. Side effect profile, efficacy profile. I must say at this stage, I don't think we have enough data to say that there is a patient profile where you should straight away put the patient on combination. So I will wait for the data. But not VP Chaudhary got up, I said, he would ask me, what about pediatric patient? So there is a data on pediatric patient, not yet approved in US FDA. There is a liquid preparation that is already available. The dose schedule has already been worked out. We are looking at the metabolic profile, effect on the growth, all those which are important for the pediatric patients, bone metabolism. So one day, probably pediatric patient, approval will come. One day, combination may be through. So all this is something for future, but all unapproved indications. What we discussed today was all approved, US FDA and Indian authorities. Any more questions? Thank you. If one person is 1% wiser, we did our job. And thanks to the panelists, thanks to the Dr. Rahul Bhargav. It's very rare for me to get an opportunity to speak to Delhi crowd. So wonderful. Thank you, Bhargav.
Thank you, sir. For the next session on Hodgkin and mantle cell lymphoma, I would like to call on stage Dr. Ankur Jain, Dr. VP Chaudhary, and Dr. Ashok Rajoria. And the first talk for this session, I would like to call Dr. Narendra Agarwal to discuss the recent advances in the management of relapsed refractory multiple myeloma. Thank you.
Thank you very much. Though the session is Hodgkin's and mantle cell, but the talk given to me is myeloma. A little contrast, but still it's a lymphoid malignancy, so I mean it's fine. So it's a sponsored talk from Pfizer, and the discussion is on elranatamab, which is a bispecific antibody targeting BCMA. So most of my slides are focused on discussion over trials of elranatamab. And these are something very basics about myeloma that we all know, that it's a disorder of malignant plasma cell proliferation with
which can be detected on marrow examination or in the serum with presence of N protein or a light chain. And then the manifestations or symptoms are called CRAB. It's a very famous acronym. The global incidences of myeloma are nearly 176,000 new cases in 2020 globally and 117,000 deaths during that year. It's nearly 1.78 patients per 100,000 populations. It's a global burden. You can see the huge number of patients diagnosed every year and they die every year because of this disease. So we definitely need some good treatment options, though we are having very good treatment options now available with us, but still there are scope of improvement, and these are risk factors for myeloma. We all know that old age, male, black race, radiation exposure, some chemicals like petroleum industry exposure, pesticides, and immune system weakness. These are all risk factors. Other than that, genetic risk factors are there. I've seen few families having more than one patient within it, father and daughter, father and son together. So I've seen a few patients with me where there's family clustering, and interestingly, BRCA1, BRCA2 genes are germline mutated genes are associated with familial cases of myeloma. And this is myeloma genesis starting with primary genetic event, which is usually a translocation involving IGF gene. Later on, secondary uh, genetic events leads to symptomatic myeloma and finally extramedullary disease. And these secondary events can be various mutations like RAS, MYC mutations, or deletions or gains in 1P, 1Q, 17P, and various other important high risk genes. And this is how symptoms develop because of anemia. There can be fatigue because of this thing, immunoparesis. There can be heightened risk of infection. There can be renal dysfunction due to various causes, but mostly because of light chain deposition in the tubules. And then hypercalcemia, bone fractures because of bone resorption, because of heightened osteoclastic activity. And there are various biomarkers developed over the span of years for risk stratification and for identification of various targets for treatment. And recently we have NGS also available even in India, though it's in the initial stages, but we are here with NGS also. So I think we should perform NGS in myeloma patients for our learning as well as to identify new risk factors and therapeutic targets. And this is the evolution of myeloma treatment starting from 1960s when melphalan was first used in myeloma patients in combination with prednisolone. Later on in ninth decade, the autologous transplant with high-dose melphalan became a standard of treatment, and thereafter in 2000s, proteasome inhibitors, IMIDs, and now antibodies and various other classes are included into the armamentarium. The treatment should be individualized, and various factors has to be taken into consideration. Are patient-related factors including age, the frailty, the performance score, the eligibility for transplantation. Similarly, disease-related factors like cytogenetics and tumor burden, aggressiveness of the tumor, the presence of extramedullary disease, and prior treatment history in those patients who are relapsed or refractory to initial treatments. These are very important, especially we should take into account the prior drugs, the residual toxicities of the prior drugs, and the duration of remission with the prior treatment. And these are guidelines by ESMO, and we can see that all the drugs can be used in the front line and subsequently at the time of relapses. So there is no such reserve drug in myeloma mostly, but there are more drugs which are approved for more than one or two line solo patients. So these are newer drugs, and later on I believe that these newer drugs too will be approved for frontline treatment. Even biospecifics too will be approved because that has been a story with myeloma. A drug comes for relapse and refractory setting, and that later moves to the front line. And that's also very good for our patients that they receive best treatment in the front line. And this is how the treatment goes mostly with initial induction and consolidation followed by maintenance. The maintenance can be very prolonged depending on the time of relapse and then relapse treatment. So this is the usual story with every patient. Coming to the use of biospecifics, we should understand that we have T cell mediated tumor killing process in our body. It requires uh, antigen presenting cells, the active MHC, which is expressed over antigen presenting cells, then various pre-stimulatory molecules like CD28 to establish this immune synapse between the antigen presenting cell and the T cell, then various cytokines for tumor cell killing, and simultaneously there should be no inhibitory signals or mechanism to counter this immune mechanism. What happens mostly when tumor progresses is called immune energy or immune tolerance. And why it develops? Because of chronic recognition of an antigen by the T cells or the immune cells, which may lead to feedback inhibition of the effector T cell function. This is called T cell exhaustion. And why this happens? Because of natural mechanisms of feedback inhibition of T cell by CTLA4. Sometimes there is loss of co-stimulatory functions and molecules. Sometimes there is down regulation of MHC1 molecules. And occasionally, and in some particular tumors, there is pitching in of immune checkpoints to counter this mechanism of T cell mediated killing. So, what we actually need to bridge T cells with the tumor cells, and this bridging should be independent of MHC. Then there should be no feedback inhibition of the T cells. There should be no blocking by immune checkpoints. And so here comes the role of immunotherapies, T cell based therapy, the CAR T therapy, and bispecific T cell engagers are one such treatment available to us. So this is uh, the structure of antibody, and BCMA is the B cell maturation antigen, is the good target available on plasma cells to be targeted by CAR T cell or the bispecifics. So this BCMA can be targeted with antibody drug conjugate, with the specifics as well as CAR T. And our one of the important bispecific is elranatamab, which is a bispecific targeting CD3 and BCMA. At the other end, it's a humanized antibody. It consists of BCMA and anti-CD3 targeting arms paired at IgG2A backbone with nullified FC binding function, which is very important. If it binds to FC, it can get cleared from the circulation, or it can mount a different immune response other than the T cell immune response. So it's very important. So alternative basically bridges a tumor cell with the T cell, and it activates T cell uh, irrespective of the MHC activation or antigen presentation. So it doesn't require an APC and MHC activation. And then it results in release of various cytokines from the T cell and ultimately tumor cell killing. And these are the structure of antibody we all know. So this structure is modified so that it's not cleared from the circulation by FC dependent binding. And this is some results of the trial, the study design, that is magnetism 3 trial. It included refractory patients of myeloma who were treated with at least one line of therapy, including PI, IROD, and CD38 antibodies. And patients must have adequate organ function and moderate marrow function with platelets more than 25,000. So cohort A patients were not received any prior BCMA targeted therapy, while cohort B patients were also there who have received any one of the targeted BCMA targeted therapy. And it was a phase 3 trial, and nearly 125 patients were included in the cohort A. And here we can see that high proportion of the patients were in nearly 96% of the patients were triple class refractory, and 52% were penta refractory. So penta refractory is a new class. We all must be aware that these patients are refractory to both PI and both IMID as well as daratumumab. And nearly 15% of the patients had RISS3 disease to start with. High-risk cytogenetics was there in 25% and extramedullary disease in 31% of the patients. And at the data cutoff, 33% of the patients were still receiving elranatamab. Progressive disease, lack of efficacy were the most common cause of discontinuation, and this is how at 6 months, nearly half of the patients were still receiving elranatamab, and at the end of 1 year, nearly one-third of the patients were still receiving elranatamab. And the overall response rate was 61%. And most of the responses were seen were deep responses, at least VGPR. Only 5% of the patients were in PR, rest 55% of the patients were in VGPR, CR, or stringent CR, and most of these patients were also MRD negative. And secondary on endpoints, overall response across subgroups. So three important classes, and we can see that the responses were not that good. The extramedullary disease responses were little poor. The RISS3 patients and penta-refractory patients. So these three classes were not showing very good responses to elranatamab. The rest of the patients were responding to the optimum level. The time to response was very short, only 1.2 months. So as soon as you start elranatamab, by the end of 1 month and a half, most of the patients were achieving good response. The duration of response was better. We achieved a CR, while it was still good for those patients who couldn't achieve a CR. And the duration of response without extramedullary disease or with extramedullary disease was almost same if patient is achieving a response. Similarly, the duration of response was little poor for patients who are having RISS advanced stage disease. So long-term efficacy, we can see that over one-third of the patients achieved either stringent CR or CR. Median progression-free survival was 17.2 months. Median OS was 24.6 months. And this is about safety. Most of the adverse events were manageable. Grade 1, most of the hematological events were grade 3, 4, while non-hematological adverse events were grade 1, 2, so manageable. Cytopenias was a problem mostly seen in nearly 40% of the patients. And CRS and ICANS were not a problem. Very rare, only grade 1, 2 events were recorded. Infections were very common, 69% of the patients were this reported infection. So to summarize, Magnetism 3 was a phase 2 registrational trial of elranatamab monotherapy and in heavily pretreated patients with relapse and refractory myeloma. Responses to this molecule elranatamab was rapid, deep, and durable among a diverse population reflective of real-world patients with relapsed myeloma with a median progression-free survival of 17.2 months and a median OS of 24.6 months. And no new safety signals were recorded. So this progression-free survival is actually good as compared to any other BCMA targeted therapy. I think that teclistamab is still having almost similar PFS, but other BCMA targeted antibody drug conjugate are not up to this level in the trials. The dose schedule is not that difficult. During first week, there is a step-up doses to counter occurrence of CRS. So initial dose is 12 milligrams on day 1, 32 milligrams on day 4, and later on 76 milligrams every week till 6 months, and thereafter the dose can be on every other week. And we can come down. I've treated a patient of relapse refractory myeloma, a young patient with elranatamab. Patient achieved a stringent CR after 1 month, and we could cut down the doses to alternate week even after 3 months of the therapy. That patient was having certain infections. Thank you very much. So how many of you have used elranatamab in your practice in any of your patients? किसी ने नहीं.
Thank you, Dr. Narendra, for giving a good review of what is the recent development and this special reference to Anupam. I keep the hall open if there are any questions from the August gathering. What do you prefer, this or a bone marrow transplant in a relapsed patient? You know, relapses are of two types. One, patient who stops the treatment relapses. Then the other is who is on treatment and started the where the markers are going up and you think it is a relapsing now. And
So mostly nowadays, patients are on ongoing indefinite treatment, mostly in my clinical practice. So I do not stop maintenance therapy. And if somebody relapses, that patient relapses on therapy, not off therapy nowadays. So we have to see the prior therapy if patient is, if we consider patient still sensitive to one of the PI or the lenalidomide or imide, then we prefer to use a combination of PI imide with or without daratumumab if it's not used previously. Even satumumab, if used previously, we can still use if it's off for more than 6 months and the relapse happens after stopping daratumumab for more than 6 months. So in that way, we can use the same medicines if we consider the patient still sensitive to the previously used medicines. And if patient is refractory to the ongoing treatment and suppose no good options are available, then bispecific is a good option. In such scenario, these drugs should be pitched in teclistamab or elranatamab, whichever is available. I think teclistamab is nowadays available. Elranatamab is going to be available very soon in India. It was provided on compassionate basis, free of cost to our patients in last year, and we have treated a few patients with this, and we had good experience of using this in our patient.
any questions, comments?
So I have a question, Dr. Narendra.
Yes.
Thank you for a wonderful presentation. Now, we have two bispecific molecules for myeloma, relapsed refractory myeloma, which is teclistamab and elrantamab. I'm talking about BCMA bispecifics. So, if you have a patient of relapsed refractory myeloma who is BCMA naive, which one would you choose, whether teclistamab or elrantamab? And what are the key differences with respect to cross-trial comparisons between these two drugs? Because you said that the incidence of CRS is lower in elrantamab, but the median PFS was almost similar. So, are there any further differences which could help us guide choose any particular drug?
I believe that I have very little experience of using both the source, but I have some experience. So I believe that both of the drugs are almost same in the toxicity profile as well as efficacy, and I will choose one which is a cheaper in the cost, which is more affordable, definitely. So that's my, I think, first criteria to choose one, and rest I will learn over time. I think we are using teclistamab now in phase 4 trial as well. So rest I will learn over time.
Well, if there are no questions, I thank you, Dr. Narendra, for
Thank you, sir.
the
Thank you very
wonderful presentation, and Dr. Rahul, the organizing, and his team for giving us the opportunity to be here. Thank you.
Thank you, sir. Thank you, chairpersons. For the next talk, I would like to call Dr. Dinesh Jain, Dr. J.M. Kunjar, and Dr. Siddharth Sood as chairpersons. Dr. Meet, sir, please. And for giving the talk, I would like to call Mr. Swarsad K. Nath. The topic is AI in clinical hematology.
Manik is a great speaker. He's from AWS, and to be honest, hilarious thing is, जब तक हम AI में काम नहीं कर रहे मुझे लगता है क्लाउड ही तो है, ये इतना महंगा क्यों होता है? बादल ही तो है, क्लाउड इज बादल.
But then we realized that Amazon makes more money than entire healthcare facility in India just selling their cloud. Entire Indian healthcare industry, one side, and cloud selling on one side. That's one product for Amazon. And you'll be delighted to listen to Manik and give you a different flavor. That take home message will be that we all need to include AI into our own daily practices. So Sasat has developed some remarkable things, and then over to Manik. I mean, both are brilliant speakers. So 10 minutes. So let's listen to and dwell into the future of hematology.
Good morning to everyone. Thank you, Dr. Babu, for introducing. Our is an important session on artificial intelligence. Artificial intelligence has got a significant role in hematology, and it promises to make hematology more precise and more accessible in diagnosis and management. Our speaker is Dr. Swast Kenaj.
Yes, sir.
Yes, sir.
I'll start my presentation. Good morning, everyone, and thank you for the opportunity. So, the topic is AI in clinical hematology, decision support tools, and predictive analytics. It's a non-technical overview of applications that we have built under our Jivana AI team from Fortis Gurgaon. And so, I want to start with some of the challenges that we face in hematology today, starting with complexity and expertise. So, complex hematology cases need expert interpretation and time, and the lab results alone require high level clinical judgment. So, this is where AI can help pathologists as a you can say a partner. So, we don't want to replace pathologists or hematologists. We want to uh, aid them with the help of AI. Plus, there's a problem of delays and access, like missed opportunities for early intervention. And the rural populations often lack access to specialist care. So, that is another problem which AI can come in. And plus, the third problem is not a problem only in Hemat, but it's a problem across specialties of documentation burden, like administrative task. That's where also the AI can come into the play. And continuous monitoring of patients, which is like for example in BMT patients, continuous monitoring is very important. AI can play a very pivotal role in that. So I want to start with some of the uh, innovations that we have made. So recently we won the Catalyst Innovation Grant at Doctors AI for an innovation called Thal Sathi. It's a digital platform to strengthen the thalassemia ecosystem in India. So what it does is basically it has four portals. There's a patient portal, there's a doctor's portal, there's a lab portal, and there's a thalassemia clinics. So it's like you can say it's a aggregated system where everybody is connected. So for example, tomorrow a patient want to book an appointment for their transfusion. They can do this through the application. Similarly, if a lab wants to detect the variant of thalassemia, they can easily do that just by uploading the HPLC and the CBC report into our system, and the AI will automatically tell what variant of thalassemia does the patient have. So we also presented, like specifically for the lab portal, we presented our research, which basically takes HPLC and CVC reports and detects the thalassemia variant. And we won a second prize for it in the Dr. AI conference oral presentation. So it's a retrieval augmented privacy preserving AI framework for automated hemoglobinopathy diagnosis in India. So we tested it across 10,000 reports, both HPLC and CBC reports, to detect the variant of thalassemia. And the accuracy was 95.5% for Thalsathi. So you can say as to the 10,000 cohort was divided into two, there are some very direct cases which can be easily detected using the HPLC and the CBC reports. 65% of those cases detected directly by a decision tree without the implication of application of AI. So that decreases the compute burden. But 35% of the cases they were handled by our RAG system. RAG is basically in simple words you can say
It's a method where the large language models accesses an external source so that the answer is very accurate. So the RAG that we built is, you can say, it's an expert in thalassemia. Uh, and this also aligns with Fortis Gurgaon's long-term initiative called End of Thalassemia 2035. Next, we got a grant from IHS for building a post-transplant care app. So the problem is that post-BMT patients, they need continuous care. And for that, we wanted to build an application where, it gets connected to a wearable to track their fever, their other vitals in the body, and can send triggers when there's a problem. So this is a very simplified dashboard, as you can see on the right side, that we have created for tracking the vitals and what is the today's schedule in terms of medications, so that uh, each patient is tracked after BMT. Then we have something called as AI Caller. AI Caller is, actually we wanted to extend our care beyond the clinical walls, and we wanted a caller which, takes updates from the patient. So what it basically does is that I'll just show you a demo here. We have the sound on, right?
Hello, Mr. Singh. This is Jivana from Dr. Bhargava's clinic. How are you feeling today?
I'm okay, but can you tell me what medications do I have to take today?
Today, you need to take tablet Valsivir 500 milligram, tablet Pancosib 40 milligram, tablet Emiseb 8 milligram, and tablet Domstol 10 milligram. You can also take syrup lactulose or tablet Dulcolax or Isabdol husk if needed for constipation.
Are there any prescribed medicines for headache? I am having a headache today.
I see you are having a headache today. The discharge summary does not mention any medicine for headache. Please consult your doctor for specific medical advice.
Okay, thank you. Okay, so this is just a demonstration, but the important part that we need to understand here is that before an AI caller calls a patient, the AI caller should have full context of who the person it is calling. So that can be provided through discharge summaries and medical reports. So here you can say on the left hand side, you can see there's a context before call. So we provide full context to the caller before calling a patient. And that's why it could say that there is no prescribed medicine for headache. You please consult the doctor. And the caller will not give anything which is not in that context. So that is very important to safeguard our patients, and we don't want the AI to hallucinate. So that is very important. And you can create a patient on the dashboard and then you can immediately start the call. So it's very easy that way. Uh, so you can use it for automated follow-ups, adherence checks, instant support, and intervention alerts. So this is AI caller for you guys. Um, then we have something called as Cura script. Cura script, again, I have a live demo here today. I would like to show you that. So here we have a dashboard of patients, right? You can easily go and add a patient here. Like I'll say Ishwar Singh, for example. Just add add the UHID, add the patient, and then you can start recording. So it's like a automated prescription generator. You can either add text, you can either add your voice. So I'll just quickly so I'm not a doctor, so but I just have something like already set up. A patient is a 56-year-old gentleman, case of multiple myeloma, received 4 cycles of bortezomib, lenalidomide, and Dexa. Further plan is to get myeloma profile PET scan followed by DMT and weekly bortezomib 2.5 mg subcutaneous once a week for 8 weeks. Lenalidomide 10 mg for 21 days and 7 days off in a 7 monthly cycle. Uh, Along with Dexa 20 mg once a week, which has to be taken after food.
with and 40. Tablet Valsivir 500 mg once a day. Patient has to report back after 4 weeks with CBC, LFT, and RFT. So this is something that I gave. Let me and like before you know it, uh, you will have the output. It's working a little slow here. Yeah, it's the network. Yeah. So because of the internet connection, it's a bit laggy here. So it gives you the full report. So diagnosis was multiple myeloma, as I said, and all the medications are printed in three parts. There is medication, dosage and schedule, and instructions. It's right on your screen. And if you miss something, so you can just click on suggestions. The AI will give you suggestions. So for example, you forgot ondansetron, or I mean, I firstly don't have idea about this, but the AI will give you suggestions. It's tailored in that way. And you can add this and you can go ahead. Monitoring instructions, which the doctor said, precautions. Okay, so if the doctor forgot to add precautions, you can add that. That's it. And what you can do is you can then save your instructions. You'll get a preview, and then you can directly hit print. So the best part is that it is very simple for the doctors, and it can be tailored in your letterhead. So this is the letterhead of Fortis Institute of Blood Disorders, and you get all the things printed there. And for example, I forgot symptoms, right? So what I can do is I can just go back, click on edit. I can say symptoms: high fever above 104, 100.4 degrees Fahrenheit, and I can save changes. And again, I can just hit print, and you will have the prescription ready for you. And currently, we don't have a printer connected, so you can just print it out. Uh, One more advantage of this is that everything is everything can be saved longitudinally. So if you want to add a new prescription tomorrow for Ishwar Singh, you can add that from here. Right. So this is something, one more innovation that we are working at Jivana AI Fortis. Uh, Apart from that, we have something called as RELIT. RELIT stands for Relevant Literature. So it's a weekly newsletter which is tailored as per your specialty, as per your areas of interest. Uh, your topics handpicked. We have an AI powered filter. So the idea behind Red was, so the problem sent from Dr. Bhargav sir. So we had a problem of scraping through research which is substandard nowadays. A lot of so publication in the research domain has become so easy nowadays that a lot of substandard research is getting published. But we want to filter them. So we have a proprietary AI algorithm which filters all the relevant research for you and puts it on your inbox. So for that, I would also like to give you an example. So here's the Reddit newsletter. This is for this week in hematology, and so it gives you an AI score. If the score is higher, it will be on top of your feed. And most importantly, why you should care. So, for example, if I'm a BMT specialist, then it will give me tailored answers like why I should care reading this, and it will give you tags like breakthrough. It was published in Nature Communications. It's a quartile one journal with a very high H index. So, so that you stay updated with the latest research which is going on in the world, and it's very difficult to keep up actually. Research data, research publications, they get it multiplies by many folds in a very short span of time. So that's why we came up with RELIT, and RELIT stands for relevant literature. Then we have something called Jivana research. This is a very new vertical actually. It's like from going from hypothesis to publication. So our team at Jivana AI, we truly believe that the most you can say quintessential research that could, like the people who could do quintessential research in the medical domain are doctors, but the problem is that they don't have the bandwidth. Either you treat patients or you do research. You can't do both. Like your concentration cannot handle both, right? So That's how we came up with Jivana research. So we take care of doctors' hypothesis to publication. So we again have a AI powered agentic pipeline. So you must have heard of AI agents nowadays. So we have a pipeline which takes the research intent. So we ask the doctors to fill a research intent form. They fill the research intent form, they upload the data, and then we come to an agreement that the IP stays with you, the data is yours. We are just mere facilitators in getting your research published. So complete research support with statistical analysis. We deal with both retrospective and prospective studies. We can do meta-analysis for you. Uh, there's a like if you want us to design the study for you, we can also do that. And it's everything is automated, so that's why the TAT comes down. But at the end of each publication, there's always a human reviewer who will cross check the research publication which is going out there to the world. So the most of the part is automated, but at one point there's some human intervention which our team takes care of. And thank you. And I would also like to mention some very important people who have given me this opportunity. So Dr. Rahul Bhargav sir is one of them. Dr. Srini Nathani ma'am is one of them. And we also have Sumit sir here. And all the upper management like Mr. Yashpal Rawat sir. And Moin is our one of the most important you know techies, I would say. Like he was fresh into his stuff, but he's a star. And this was also Nath. Thank you so much. Yeah. Yes, sir. Yes, if you have any questions related to AI, okay, we have questions after that. Oh, yeah, sure.
So Manak is from AWS, and he's going to enlighten us about what the AWS is doing. And I liked his when he came for a AI club. He said one thing: the only thing which is going to remain is your voice. No writing, nothing in the future. All is voice to text. So everything will become whatever you speak can be described, can be interpreted, and with the use of AI, it can prompt you to the next level. So Manik and Zaid is also here who has been helping us. His own startup is there on the AI and has done some phenomenal work in the genomic arena to standardize the genomic interpretation where you actually reduces the burden of a doctor to report a genomic report. So over to Manik. The most exciting part is the release. It will help all the clinicians to remain rest with the key updates which we get onto a Sunday inbox. So you will have a weekly update of interest which gets published. It will be put on in your email pattern. You can say on the Sunday after you can actually read it or what.
Think all this, what he showed, is just 8 months of work. It's not even a year that Swarsat has joined us, or Moen has joined us, and they didn't really explain. This guy, Moen, he's a first year graduate student. He's not even yet a graduate. Okay? He's studying, he's there with us, and it's phenomenal. Yeah.
Am I audible now? All right. Thank you so much. First up, I'd like to thank Dr. Rahul, Dr. Srinidhi for this opportunity, wonderful opportunity on a Sunday morning to be here and present to a wonderful audience. My talk today is going to be very short because mostly the fireworks are already done. So what I'll do is I'll try and set it in the context of how you can bring AI into the clinical space and how AWS can help you do that, because we typically have been using AI in our conversational, personal use terms where, let's say, we're all using ChatGPT, Perplexity AI, and stuff like that. But those are more general and generic in nature. So you essentially can ask, rather than a Google search, you can just simply talk to a AI API and get a response. But more often than not, those responses are non-deterministic. What I mean by that is, if I be asking the same question and you be asking the same question again, the answers will be different because AI is built that way, right? So how do we standardize AI response in a clinical setting? Because we don't want AI to hallucinate and give us responses which are not clinically relevant. So mostly the talk is about how we bring AI into organizational in a hospital setting and help improve responses from AI, right? My name is Manoj Chakravarti. I'm a senior solution architect. I primarily work with hospitals across India, and my only job is to see how AI solutions can be incorporated in the clinical space, in the operational space, finance, HR, in all domains in a hospital setting. So with that, let's look at one of the videos. Can I have the sound, please, as well?
All right, that's good. That was a simple explanation of what AWS does. And for those of you who are unfamiliar with, let's say, what AWS or cloud computing is, typically we would need a lot of hardware, which can do all these algorithms and computation somewhere, right? You'll have to run these applications somewhere, specifically the ones which Swarshut was already showing you, and all the big, large language models have to be put somewhere and they have to be run somewhere, right? And most often than not,
The technology landscape has moved into a position where people used to do this at their hospital premises. Like now things cannot be done there anymore. So you don't have a data center in the hospitals anymore. Those have to be shifted onto somewhere called as cloud computing, right? So here, if you see on the screen, there are two regions in India which AWS operates from. One is in Mumbai and another is in Hyderabad. All the large scale applications that you have been very happily using, let's talk about Vijayatra as one of the examples, runs out of the Mumbai data center, right? Where you have the facial recognition and you can walk into an airport as if you're walking in a park, right? All of the security, governance, data privacy, not storing the data beyond your travel duration, all of those are taken care at the back end for you. Now, what I'm trying to show here is that um, almost half of the internet and the applications run on the AWS cloud. Think about any of the applications that you've been using up till now: Netflix, Amazon Prime Video, Hotstar, all of them run on AWS. This is from one example. Again, hospitals, and I'll talk about a couple of references. Hospital operations are also running from AWS. So what we are trying to say is that since this is patient's data, those cannot be actually sent outside of the country. So if you're running the AI model which has to work with patient data, the data has to remain in the country. And of course, with the new DPDP bill coming in, there are stricter regulations on how you move data, how you generate them, how you store them, effectively over time. So why AWS? So AWS has been essentially the dominant cloud provider in the cloud computing in 2006, and up till now we have been consistently ranked as a leader in the space, even running most of the AI workloads on the cloud. AWS has been rated as the KLAS healthcare lead for 2025 as well. And the important thing to understand here is that we have some of the purpose-built services that we offer. If you take health imaging space, we have services that you can upload a X-ray or a CT scan image, and it can basically annotate that image and give you a report. We have services around Health Scribe, which you have a doctor-patient conversation in a clinical setting, and it can easily convert that into a diagnosis or a summary report or a prescription as well. And some of these we have been running successfully across India in the hospital setting today. In pathology space, if you have whole slide images, you can interpret that whole slide image, also annotate it. Tata Memorial is actually using that solution for now. And multiple other things around transcribe medical, where you can put in a handwritten prescription from a doctor and it can basically figure out every single thing, digitize it. This is very important in terms of when, let's say, patients will have past medical records, and those are all foreign patients, right, who do not, or maybe language is completely different. So you have the ability now to use AI and extract all the information that is written on a handwritten prescription note and convert that digitally, and also include that in your longitudinal journey so that so that clinicians can look at it later and create or do a triage while they're suggesting treatments. Now we do all of this in the remit of security and privacy. So there are compliances, whether that be FedRAMP or HIPAA or GDPR in Europe, where you have some limitations around how you store and manage this healthcare data. And we adhere to almost 145 compliance and certifications in India as well. But today we talk more about AI. So I'll speak about how the entire landscape has changed in the last 2 years. We started off here in 2003 with the advent of transformers. Completely different architecture, because for the first time, us as a human race could generate text, voice, speech, music, images, videos, and everything that could be generated using transformers started here in 2023. 2024, we saw for the first time co-pilots. Co-pilots, let's say, co-pilots helping us make better decisions. Co-pilots helping developers write code faster and better. And those things started coming in 2024. Then in the end of 2024 and the beginning of 25, we saw RAG. RAG was a concept wherein, let's say, I have a generic LLM which doesn't understand my hospital setting. Let's say, for an example, in the previous sections, we heard about TKI and some of the medical terminologies, which LLM might not be even aware of. What happens then? You give it some documentation which has all of that data, and you basically attach it to the LLM so that it can find that information in a database. And then it uses that databases to answer you more specifically and being contextual aware, right? And that is what RAG was. But it still doesn't give you the power to do autonomous things that you want AI to take action on its own. And that is where agents came up, right? So what exactly are agents? Agents are basically AI taking action on your behalf. So you would have basically told an AI system that if you see this as an input, then take this output on my behalf. Okay, so this simplifies, let's say, the day-to-day life activities that you would normally do. Let's for example say that, and this is currently happening across the board, where AI agents sit on top of e-commerce platforms, and basically when you say that I want to have, let's say, a toaster which is above 5K and let's say 4.5 rated on Amazon or Flipkart, just give the list and maybe put that also onto the cart, and it can go ahead and do all of that for you, right? So this is what I'm talking about when you basically write English language queries, and today you type, but tomorrow is when you will use voice, because that's the most natural mechanism of communication that we as humans know. All of the application interface which have keyboards and clickable interfaces will evolve into a more voice-based setting. So even if you were to scroll up and down, you would use a voice interface to do that. And that is where when you give a voice command, your agents will then go and do the job thereafter. Now, this is one agent. How does agents collaborate together? Because one agent might not be able to do everything that you need it to do. So then comes agents in a loop where multiple agents come together to achieve a particular task autonomously. And you remember example which Schwarzer gave, which was a very good example about how multiple agents collaborate together. So it would be something like you have a supervisor agent in top which would say that, okay, go do this on my behalf. But some part of it would be extracting patient information from a clinical database. So that would be a separate agent which can understand that data, clinical agent. But other part could be, okay, you have figured that information, but is there any regulatory compliance protocols that have been given by, let's say, ICMR in this case? So you'll have a separate agent which is only trained to filter through regulatory frameworks. And then you might have another agent which can filter through publications, right? And see what is a latest literature document. And you bring all of that together and push the response back through the supervisor agent to the user. So now you understand how previously in the beginning when this entire thing came up, we only had one LLM doing very generic work with low levels of accuracy. Now what has happened is you have specialized agents doing things that they are specifically trained to do, and then a supervisor agent basically responding back to you and completely abstracted for the end user. So end user doesn't even understand the complexity of how this entire thing has been built. And uh, then AI is capable of building and writing code for all of this today. So you don't have to have a lot of developers to do this. Now, quickly moving on, we have a bunch of agents currently which can actually do all of this work, clinical trials, claims integration, market research. But for paucity of time, I'll quickly move on to show you some of the things that we have been doing. Fully autonomous agentic AI systems can actually do reasoning as well, finding out treatment pathways. And cancer patients, that could be figuring out from a maze of different treatment solutions which matching a patient profile and a treatment pathway. In the beginning, in today's session, we were discussing about having different patient profiles and different cost structures, and then how do you have medication given to them. Now think about AI prescribing that and helping the clinician do exactly that. Couple of examples, we can do summarize patient exam history over a long period of time, let's say 8 years, 10 years, and you would want to have a consistent view of how the patient has evolved, positive or negative both ways. You can have patient pre-screening for clinical trials or actually generate a treatment plan for patients as well. To summarize, you can have a bunch of use cases and things around clinical workflow and efficiency. Think about you going on to the IPD, having the daily rounds, and you actually can talk to a voice bot talking about this is the patient, this is the current condition, and this is the medication that I'm prescribing. Rather than typing all of that, you just give a voice prompt, and that gets converted onto a prescription automatically, right? And we have models which are now capable enough to do all of that, understanding the medical terminology and the clinical wordings that you're using in the conversation. We also spoke about care management. So this is more clinical. This is more about how do you improve patients' experience while they're there in the hospital. And then a whole lot of things around medical research and education. Since we have very less time today, I'll basically move on to the demonstrations piece. But a lot of life sciences and pharma companies and hospitals are using these agents as these are the two solutions. There are agents which are already open source, so you can go and see for yourself what these agents can do. A bunch of things which I spoke about those use cases earlier, but these are freely available for you to now go and use them in your organization. Now, taking a deep dive here for some of the important things around biomarker discovery or biomarker supervisor in which ways where we would want to see clinical biomarkers. Let's say we have done a RNA sequencing or a DNA sequencing, and we would want to find out how that relates back and the different variants that would have come up in the sequencing results, pathology results, and all of that. So these all have trained agents which can basically look at the data and then prescribe what needs to be done. Then clinical study supervisor, if you have clinical research. That is another area, and we were alluding to it earlier that doctors do not have that much of time to do research, but now with the agents, they can basically offload some of the research work to these agents. Now, let's look at a user flow, right? How this will evolve. So let's say a user is asking a question around, can you process a whole slide image of a particular patient? So now this is the supervisor agent, which understands that I need to look at a tumor image, and it basically sends this information to a pathology agent. Okay. Now pathology agent would respond back, but the second question is, can you also show me the identify the top 3 high impact variants? Now it would basically understand that this is asking me to do a variant interpretation and pass on this to a variant interpreter agent. And similarly, then the third question could be, can you identify a literature which has seen these variants and can map it, and can you map it back to this particular patient? And then you have an evidence researcher which can go and figure out literature on top of that. Now, what has happened here is that rather than you going and figuring out data from your HMIs, your EMR, your LIMS, and your genomic analysis, and your radiology reporting tool or a pathology reporting tool, you have a one-stop shop, which you ask questions in natural language, and then you also get responses back. So you don't have to basically do and combine things with different tools or interact with different tools. So how does this look like in a real life setting? I'll maybe show you the other demo. So you click on this and you basically are asking about a particular patient here. This is Chester. And you're saying what conditions does Chester have? So from his previous EHR data, or HMIS data, you can actually have a list of what the patient has. Second question is, what are the genomic variants that this patient has? So now I'm going into a genomic study and figuring out that he has chromosome 19 and which positions and which alleles are coming up. They're basically asking, can you link this back, these particular genetic variants that have come up with an increased rate of heart attack? And it says that these are the PubMed databases, and I could see there needs to be more targeted researchers because I could not find a link correspondingly. Now, and you can keep on going asking questions around the socioeconomic status currently, and you can see that you have all of that information comes from your socioeconomic background. So now you also understand the patient profile because you now want to map it back to the treatment plan. And if you see all of this time, you have guardrails built in that what all this can answer and the APIs where you can get the data from. Yeah, just about to close. So essentially what will happen at the end of this demonstration is that we will basically be asking that, can you prescribe a treatment? Now, you don't want an AI agent to prescribe treatments directly to the patients, right? So it would basically, because of that guardrail in place, it would come up and say, like, for example, this is a patient, can you recommend medical treatments for similar patients? It comes up and says, sorry, I can't give medical treatment and advice. You need to book an appointment and go through proper channels. How does that happen? That happens through the guardrails in place. So this is how you would put AI in a hospital setting. And happy to take questions if you have post this demonstration. This is currently running at multiple research institutions and hospitals, Dana-Farber, UC San Diego Health, Stanford Medicine, NHS. But happy to take questions if you have any. Thank you.
Want to bring a new flavor to the meeting so that we all aware of the AI, what is happening in the AI space, and some bright minds will get ignited to develop their own solutions in the space of AI. We have been developing CAR T cells, we have been developing newer therapies, but I think AI is also a very, very important component to include into our lives so that we can, by 2030, we can make things much more faster, robust, and declutter our minds so that we can do something constructive, because we have been talking about we don't have time, we don't have time. But all these agents working together will actually declutter your mind and will give you a space and mind space to publish and to innovate. We have got brilliant minds sitting in this room, and we think that we will be on that top notch research institutions in the world as the time goes by. And that's where the AI will come in.
So we will, in case if you want to see the solutions and everything, it's all outside and on the stall, and they can give you live demos. We will move ahead with the sessions. Thank you. We can take questions and network outside as well.
Thank you so much. Coming back to lymphoma, I would now invite Dr. Colonel Rajiv Kumar, who will be talking on how relevant is BMT in mantle cell lymphoma. Thank you. Welcome, sir.
Rafa. So after the artificial intelligence, let's come back to the empathetic human intelligence. This is a very huge topic to do justice in 15 minutes. The topic is BMT still relevant in mental cell? And obviously, it will have two parts, autologous and allogenic. And the specific behind this topic is the current debate on allogenic versus CAR T mantle cell lymphoma. So, mantle cell lymphoma, it is a confusing disease. I have always been confused by this disease. I'm still confused. It is a rare disease, around 6% of all NHLs. It has got a very wide age spectrum, although the given age is 68 years old. So half of the treatments in the past are not applicable to them. And it is very unlike other lymphomas, low grade, high grade, malignant presentation, nodal presentation, indolent presentation, invasive presentation. We look patient to have a combination of all those. But one thing is clear that it is incurable. And another thing which is very critical of this was that there is no way of autologous transplant in CRT. So it is a very different kind of disease. So when we talk of transplant, we are mostly looking at the stratification. So it all started with VP, but as we all know, VP did not cover the main three links, the blastoid morphology, QI67, and TP53. So VP-C came, then VP-G came. But the problem is some of them have been incorporated into the treatment decision, and previously the main treatment decision was whom to take up for autologous transplant. So VP was never taken from that decision-making. So we look at the additional biological and clinical features which predict worse outcome with chemoimmunotherapy and autologous transplant. These are the four: the blastoid and pleomorphic variants, the TP53 alterations, complex karyotype, and POC24. The POC24 has come off late, and if you're relapsing within 24 months of your therapy, then the prognosis is bad. So here the allogenic, CAR-T, BTK inhibitors, all can start kicking in. This was what we used to do. Frontline and so younger patient, give chemoimmunotherapy, follow it up with autologous transplant in CR1, then with rituximab. And then it started getting challenged by the BTK inhibitor and the bispecific. In the relapse refractory, again the thought process is same. Somehow get to CR2 and go out for allogenic transplant. There is no rule of autologous CR2. And again, the challenges here are the CAR-T cell therapy. So this is a chart taken from Hoffman. And what you can see here is that even with the existing high-dose therapy, we could still achieve a PFS of roughly 60% at 5 years with the conventional therapies of R-hyper-CVAD or the Nordic regime of R-CHOP alternating with R or high-dose cytarabine. So even existing therapy in younger patient, percent of PFS, if the newer therapies are to come in, they have to beat this. So the best two things about auto-HCP, it started with its comparison with interferon. It was very good. Then it started getting added up to R-CHOP and Valdac and rituximab. But when your PFS was still 43%. And in this large study of 10,000 patients, autologous showed very impressive results at 5 years. And then came the LINER trial, which added rituximab maintenance, and we can see 4-year PFS was 83%. And one important thing which got added subsequently was use of MRD, which otherwise is not there in mantle cell. But if you are MRD negative after autologous, you have got 75% 10-year survival. So that is why data that needs to be kept in mind when we're talking about algorithmic and CAR-T. With the autologous, the conditioning that we is open to discussion. But we are more interested in the high risk MCO. And what we need to know here is that although at 5 years, you have a 66% EFS, the patients continue to relapse. And as you can see in those three charts on the right side, that EFS continue to decrease from 66 to 40% in 15 years. And if you are high risk VPC, it goes down to 25%. This doesn't happen with other lymphomas, but it is continuously relapsing. So that is a major problem with mantle cell, which needs to be kept in mind while we are talking of CAR-T. This is the review which is used for the frontline published by the EHA guidelines this year. Again, classifies into younger and fit and unfit patients. But the question today is there is still a role of allogenic HSCT in MCM in the era of CAR-T? And this was how do we position each other, CAR-T and allo-HSCT? So if we look at allo-HSCT, certain things here are very clear. Over the period of time, certain things have been established. One, there is a strong gene effect, but it is applicable to a very small group of patients. The work is better than NOC, and allo-HSCT, the data is still evolving. So what will be the traditional indications for allo-HCT in the non-CAR-T era? Post ASCT relapse, primary refractory disease, myeloma, also in CR1 or less than CR1 we can consider, or CR1 is within high risk molecular factors. So the 5-year PFS achieved was 56% with allogeneic transplant. Although there are no RCTs to cover, but this is one figure that we should keep in mind because of all the lymphomas, allogenic fares best in MC. So we don't have any RCTs. The first four are the non-randomized studies which have been done. And then there are some registry data published by CIBMTR and EBMT. And you can see that the disease-free survival is close to around 40 to 50% with allogenic transplant in CR2. The major thing revolves around TP53. So we need to see if TP53 can the allogenic transplant overcome the TP53 effects. So it was beautifully brought out in this study. 32 patients, TP53 effect was negated by allo-HCT. Because that is one thing we will be talking in context of CR CAR-T also. The other thing is if you are PET positive, what happens after allogenic transplant? If you are not able to achieve a complete CR and there is some kind of PR. Again, the effect of LSCT on PET positivity was that although you continue to relapse, but still it had you could salvage around 25% of patient with allogenic HSCT. And the third is you are primary refractive. You have a patient who has relapsed and now he is not responding to any chemo. So what will happen to them if you take up for allogenic transplant? 25% long-term survival, durable remission is still possible with allogenic. Again, all these three things are not seen with allogenic transplant in any of the lymphomas. So MCL is a different case. So let's see what CAR-T data says. So this is the main ZUMA-2 study, which has got a 3-year follow-up. It had a CD28 co-stimulatory domain. 68 patients were there in study. CR rate was 68%. That was very impressive. And the non-relapse mortality was just 3%. And the third important data here is that after 24 months, nobody relapsed. So these three things we need to keep in mind when we are talking of Brexu-cell, which was used in ZUMA-2 study. So as we can see here that the CR rates are fairly high and the DFS is also good. But what is important here is that whether you have a TP53 mutation or not, whatever the morphology and if you have used BTK inhibitors or not. Initial response to CAR-T is irrespective of all these high-risk factors. But if we go to the right side, we see that eventually the disease morphology, physiology, pathology eventually catches up and the survival starts going down. The second molecule is the Lisa cell, which was part of this Transcend trial. This has 4-1 video of the post-inverted domain. 88 patients were given. again, very impressive 73%, 72% CR rates. And it's important to remember here is 73% of the patients were more than 65 years. But unfortunately, it has got higher CRS and neurological toxicity. So cartoon high risk CR, high risk potential, as you can see, around 30 to 40%. You can get that OFS and PFS. So now this has got approval, and the 24-month duration of response is 42%. But again, one thing which stands out is second primary malignancy. Almost 17% patients landed up with this. And all these were trial data. When it was checked in the real world study, this US Lymphoma Party Consortium studied it, and we took all the difficult patients who were excluded from Zuma. And interestingly, the CR rate was 82%, and patients continued to do well. Meanwhile, again, the same thing. Irrespective of the disease physiology or the genetic makeup, initial CR will still be achieved. So, how do we interpret this situation at this stage? Most of the high risk features have near equal responses with CAR-T, whether it is TP53 or blastoid. But if you are not able to achieve CR with CAR-T, then the outcomes are dismal. And the PFS after CR will still depend upon these high-risk features. But the question is, can we consider CAR-T after LOSCT? The next question is whether CAR-T is useful in the BTK naive patients. And what happens if CAR-T is used post LOSCT? So these are all again the same confusing questions which are coming up again and again. So what's the challenges with CAR-T? Manufacturing failure is an issue, time is an issue, bendamustine if you are used earlier, again that is an issue. All the products are not seen. We don't have any data for the Indian CAR-T so far. The US FDA guidance is not there. What should be the optical timings? And we cannot apply the trial results to the general population. Also, we are aware that the MCL is incurable. We have seen the 15 years relapse rates. And the durable response in high-risk patients with LOSCT is also there. So you cannot write off LOSCT. Even with refractory, you can have 35% long-term survival. But interesting recommendations have recently come up where CAR-T has been suggested by USTCT and BBMT before stem cell transplant, even in TP53 and mutated mantle cell. So now we come to the main question, CAR-T versus LOSCT. Which one we should take? The problem here is you cannot sequence LOSCT after CAR-T because it is impractical. Most of the patients will be unfit by the time you delay your LOSCT to such a long period of time. And only a minority of patients who develop post-CAR-T cytopenias will actually be candidates for LOSCT. And LOCT will have their own issues of donor availability, and we don't have any assays comparing between them. Financial toxicity is already known. But the concept here, which I would like to bring, is best therapy for worst disease. For a very long period, we have been following that the worst disease should be kept as a separate cohort, and the best therapy should be reserved for those things. Really, that may not be the right approach, and the only thing we should decide between the two is the TRM. And as we can see, the TRM in CAR-T is 3 to 4%, which is almost 20% with allogeneic HSCT. So let us see what is the guidelines and recommendations today. The CT, CID, TR, EBMT, all three have come together to make these guidelines. This itself tells that it is a confusing issue. We will not go into all the consensus statements, but what is important here is that CAR-T or allogeneic transplant as consolidation, both are acceptable. That is the first recommendation that they are giving, that in patients who are having TP53 mutation, you can use any of them. So if you are having a TP53 mutation is present, then this clinic is recommending CAR-T over allogeneic HSCT in relapsed patients. And the panel doesn't recommend allogeneic transplant in relapsed MCL patients who are refractory to anti-lymphoma treatment. So these two important points need to be kept in mind. So regarding the timing of application, when should CAR-T be used? This panel is now suggesting that CAR-T therapy should be given to patients after they have relapsed after use of BTK inhibitor. So if you are exhausted with BTK inhibitor, there is no doubt that CAR-T should be your go-to drug. So what is the role of allo-HCT in such a situation? The role of allo-HCT is again for patients who cannot either afford or who cannot tolerate. So if you see the sequencing, the general spirit of these guidelines is go for early CAR-T and reserve your allo-HCT for future therapies. So current is not going to change much. Possibly we're going to continue with immunotherapy followed by allo-HCT followed by rituximab maintenance and use BTK inhibitor in second line and possibly use CAR-T in the third line. Although now trials are coming up which are trying to push CAR-T up before the use of BTK inhibitor. And allo-HCT will be for very select group of younger patient. But there is one more kid which we are forgetting, that is our BiTE antibodies. But unlike ULBCL and follicular lymphoma, these two molecules have shown some use, but none of them has been approved by US FDA. So as of now, BiTE is not an option in mantle cell lymphoma. So I leave you with this. This is the present guideline. Again, it is as confusing as we started. Where to place which one, younger patient, older patient, high risk, not so high risk, TP53, not TP53, and BTK inhibitor naive or BTK inhibitor sensitive. So all this will have to be finally used, but this new one you have to keep in mind that the anti-CD19 CAR-T is coming up the stairs and it is now coming up first lapse of mantle cell lymphoma. Thank you. Are there any questions? Yeah.
PFS post-CAR-T patients. We are now landing up with a few patients who are coming, of course, taken the CAR-T in a trial in US and then coming back here, mantle cell is first line. Now we are like, what do we do now? We are going back to BR plus ACAL in them. So PFS and any.
You are talking of first line
Yes, as a part of trial there.
Okay, and after that,
Relapsed within 6 months.
so if you're, that is something which is very clear if you understand the physiology of mantle cell. That if you're going to, even if you see both the trials, out of the 88 patients who were infused, 48 died. So, and if you see all the trial data as they are being reported, you can see the effect of the pharma presence on that. The data is talking of something which you don't want to know. What you want to know is what is the survival at the end of 2, 3, 4, 5 years. So the thing is that we don't have long-term survival data like for allogeneic SC. So coming back to your question that if the patient is relapsing after CAR-T within 6 months or 8 months, we know that they are all poor risk. The point is, CAR-T will not induce any new kind of mutation by the very nature of its action. So maybe your chemotherapy will still be effective. And after that, you may have to go for allogenic instead of autologous. That is the only thing that may change here.
Absolutely, sir. I mean, it's just an odd situation where, like, you're already post CAR-T, you're just 8 months into diagnosis what's going. Because it was in a trial, well documented and explained to the patient. But yeah, yes, sir. Thank you.
Thank you.
Thank you, sir, for the excellent talk. We now begin with session 4 on MBS and MPN, and for which I would like to call Dr. Sumita Chaudhary, Dr. Amit Upadhyay, Dr. Rajul Bodka, and Dr. Ashok Rajoria as chairpersons. And for the first talk, I would like to invite Dr. Farhan Naeem, who will be talking on Jakavi in intermediate 1 myelofibrosis.
So, good afternoon to everyone. Thanks for the organizers for giving this opportunity. So, today I'm going to speak on the ruxolitinib in the intermediate 1 myelofibrosis patient. So these slides, this is a sponsored session from the Novartis and slides are provided. This is my disclaimer. So when before I start with the ruxolitinib in the intermediate one, the term written myelofibrosis story. So just I will start with the time when I started my hematology training. That was a time when the patients, because this myelofibrosis is a strange disease. We have few patients who are doing so good with our minimal treatments. I can say few patients are on thalidomide for years together, coming and doing fine. But there are few patients who does so poorly that it's very difficult to salvage. Even they have such a short survival and a very tough disease. If you ask me before 10 years, it was a very tough disease. Not for every patient, but for a selected group of patients. So, but we remember more for the patients who are the low risk, who are coming for the years to us. We remember more about these patients. But when we talk about the patients who are high risk patients, these patients they hardly survive. We see a year or 2 year. This is the story when I started my training. What we were doing, what we are offering to these patients. Those patients coming with the anemia, we are using drugs like ganazole, EPOs, and steroids. Those with having a splenomegaly, high TLC, high platelet counts, we're using hydroxyurea. This was the era when time when we started. But then came a drug with after the trial with the name of comfort, when that gave us a lot of comfort that the ruxolitinib was introduced, and that has changed the life of the patients for the high risk large spleens, lot of constitutional symptoms, and it was difficult to see these patients giving hydroxyurea gives a response of a year or more, then it's become a static response, and it was really a difficult disease to manage. Not only they get a static response after a year or two, they start having some side effects which are very difficult to treat. So definitely this comfort has gave us a lot of comfort, but after that it started, the thought started coming, how can we extend the role from the intermediate 2 and high risk to other risk categories. So not only this thought process comes from our real world data also. As we started using ourselves, anyone a large spleen with constitutional symptoms, and nothing can stop us from starting the ruxolitinib in these patients, because when there is a lot of cytokine release and symptoms, they are really bad in myelofibrosis. So this is how the concept start coming. How can we use in earlier, especially in the patients who are symptomatic. So if you ask me if you leave other from the IPSS or DIPS score which we commonly use, so from the other than the constitutional symptoms, the patients are doing fine. But those having constitutional symptoms, really no nothing. Which even in real world practice, everyone starts using the ruxolitinib early. So as we know that ruxolitinib is a well established, effective, and well tolerated treatment for the intermediate 2 and high risk myelofibrosis. Approximately one third of patients have intermediate 1 risk disease at diagnosis. The symptoms and splenomegaly have a prognostic impact, significantly affecting the survival in MF. So, as we all know from a lot of trials being conducted, that what the two things like is the reduction in the spleen size and the total symptom score is something which actually impacts the have prognostic impact, and now of late we can see the survival advantage also. So, as we know, it's a progressive disease. Treating patients with less severe myelofibrosis, like intermediate 1 risk, earlier in disease course, may improve the outcomes that I will be discussing in next of my slides. There is a growing evidence for ruxolitinib in intermediate 1 risk myelofibrosis, including the real world studies involving hundreds of patients. All the major international guidelines, include the ruxolitinib as a treatment option for patients with intermediate 1 risk disease. So here I will be discussing in the favor of ruxolitinib in intermediate 1 risk category. I think for speaking against, I think there are audiences which can ask the questions speaking against also at the end of the talk. So coming to my first the point, that as we all know that from that lot of trials being conducted, that in the intermediate 2 and high risk category, it's a very effective and tolerated treatment option. As we can see, that spleen response in comfort 1 and 2, it's really very significant. And the total symptom score, if you see in these two studies, it's again, these are two things which was this was studied in the comfort 1 and 2 trial. So this is the, let's say, latest data is coming after the 5-year follow-up of these patients of comfort 1 and 2. So now you can see the two graphs are separating, and there is overall survival at 5-year pool data, and it shows there is survival benefit, but still many can question this because a lot of crossovers were there in these studies. So as we can see, this 5-year data from the comfort 1 and 2, that 53% of respiratory patient achieved spleen response at any time. 59% of patient had a spleen response at any time on study on comfort 1 with median duration of response of 168 weeks. The probability of maintaining a spleen response was 0.5 at 3 years, and almost same at 5 years also. The response was maintained. 1/3 of evaluable JAK2 positive patients had a more than 20% reduction in the allele burden. So again, this is what we can see now. This drug has got a disease modifying effect. So when this drug has come and the trials were there, the what we were looking for was the improvement in the symptom score and the spleen size. Now it's very clear that it can reduce the allele burden and has got a disease modifying effect. This is what been reflected in the overall survival benefits, which now coming in the late in the these follow-up studies. And there is if you see the fibrosis, there is improvement in the fibrosis, 16%, 18% worsening, but 32% had a stable fibrosis. So again, even myelofibrosis is a progressive disease. Even if we get a good number of patients with stable fibrosis, it's an advantage in these patients. And as we know, the adverse events, they are mainly the hematological in the form of anemia and thrombocytopenia. So next, again, the tolerability data of ruxolitinib in long-term follow-up. So if you remove, apart from these hematological toxicities, the other toxicities were not very significant. Even in the long-term studies, they found even less than the initial studies. Now it's an important slide, the ruxolitinib disease modifying effect, which I was discussing. You can see the annual burden in the patients with placebo, those on ruxolitinib and crossover patients. So both these are showing a significant reduction in the allele burden also. And next is showing the fibrosis, bone marrow fibrosis, as we have seen. That's significant. If you send even the if you remove those that reduced fibrosis and those that increased fibrosis, but 32% had the stable fibrosis. So coming to the next part of my discussion is, so which we discussed that around 30% of patients has an intermediate one risk category at the diagnosis. So there are different risk scores which are being used. So most of us are using the IPSS and DIPS score, and so if we see from actually what the importance of the risk scores are. So one important is when to initiate the treatment. It's very difficult to decide when to initiate a treatment in the myelofibrosis patients and when to go for the allogenic transplant. And now that there are newer scores in the form of MIPSS and GIPSS, which include the mutation inspired and the genetics inspired these prognostic. What the important of this prognostic scoring is, if someone is having a more than 50%, near a 50% 10-year survival, I think we can avoid allogenic transplant. And those who are having less than 50% 10-year survival, these patients should go for allogenic transplant. And but it's still it's very difficult. Most of them is still using DIPS as a score. And what decides what is the importance is when. So starting ruxolitinib, does anyone look for the score? I don't think in the real world practice anyone, I again say, anyone having a large spleen and constitutional symptoms, we most of the time we jump and start the ruxolitinib in these patients. So still the use of these scores are to decide whether to go for the allogenic transplant or not in these patients. What is the so I'll rush the slides. So the myelofibrosis patient have decreased survival regardless of the risk category. This we know already. We know. So symptom affect most patients in intermediate or high risk categories. So not only the patients in intermediate 1 or 2 or high risk, the patients with lower risk categories are also affected by the invalidating symptoms. So these also need to be addressed and they need the treatment. So again, the symptomatic patients, even in the intermediate 1, they need the treatment. So splenomegaly, a quality of life impacted myelofibrosis patient, and we see the patients in IPSS 1 category around 40% have a spleen size of 10 to 20 centimeters. So as we know that two important points which decide the patient's just a minute. The two major challenges in the management of myelofibrosis are symptoms and the splenomegaly, and these are the two factors which decide the outcome. Also, as we have seen from the previous trials, they have a prognostic impact regardless and debilitating impact on the quality of life and significantly affects the survival. So as you can see, this importance of symptoms in the myelofibrosis, and this is something which is the most important, which impacts the quality of life of these patients. So we can see the graph, the splenomegaly and myelofibrosis prognosis. Those having a large spleen size, definitely have a poor prognosis. So the spleen response influences the outcome of ruxolitinib treated patients, as we have seen from previous trials. These are most of the things are the repetitions that we know that spleen size reduction and the total symptom score reduction, they significantly influence the patient's quality of life and survival. So as this just to show that this is a progressive disease. Even intermediate 1, the median time to progress is 2 years. So it's quite high even in the intermediate 1 patients. So I'll just shortage of time. I'll rush some slides. So I think I got even less than 15 minutes. I think. So treating patients with less severe myelofibrosis earlier in the course of their disease when splenomegaly or symptom scores are relatively milder are likely to be more responsive and lead to the improved outcomes. So this is not from the real world data. Now we have even that in because there are certain studies, especially in the when the drug was given as a compassionate basis in some countries, where the studies were performed and that has shown even the patients who are in the intermediate one risk categories also got benefited. So I think this is all what we already discussed. The better clinical outcome with ruxolitinib initiation in less advanced myelofibrosis. If you can see those patients having spleen size 10 to 20, less than 10 and more than 20, they all these categories they have in patients in less advanced myelofibrosis, they have improvement with the treatment with the ruxolitinib. So this is study which I was discussing. This is a JUMP study. So this included all the patient low, intermediate 1, intermediate 2, and high risk patients. Most of the time, it was actually prospective expanded access trial in the countries which have where it was given as a compassionate basis. They have seen the patients even in the intermediate 1 categories, and they have found that it is well tolerated by patient in all risk groups with similar adverse event profile. Lower risk patient remained on treatment longer than high risk patient with fewer discontinuation due to the adverse events. It was a well tolerated drug in the patients of intermediate 1 category, and the spleen response and the symptom score response was significantly higher in the patient with IPSS intermediate 1. So this is the study from where the data started coming off in the patients of intermediate 1 risk category. This already discussed. So this is another trial, the robust trial. So this is almost similar trial as the comfort 1 and 2. The only thing they have included the patients who are intermediate 1 risk category also. And again, they found that the reduction in the symptom across all risk categories was seen in a spleen response and total symptom score. Both was significant in all the risk categories. The shortage of time, I will rushing the few slides. So what all these studies, if you take the JUMP study, robust study on all these real world data which are coming up, they show that the patient in intermediate 1 risk category of myelofibrosis, they also have a well tolerability. They have also have a similar spleen response, and they have similar total symptom score improvement. So if you go with all these studies which are available, they show that It's a drug. It can be it as we see the benefit in the intermediate 2 and the high risk patients, same we see with the intermediate 1 patients also. So coming to the all international guidelines, now even the NCCN, they have a recommendation to be used for the intermediate 1 risk category. I think with this I will finish my talk. So I spoke most of the things in the almost everything in the favor of intermediate using ruxolitinib in intermediate 1 myelofibrosis. I think the questions from the audience can be for against also. So any questions, please?
Anybody, any questions? I think what is more important in addition to the symptom response is also the reduction in the allelic burden and probably a better event-free survival, which needs to be seen in real world. So I think that is what is more important when you start it early in the course of disease.
So as we were initially worried, the one thing which is comes worry for everyone is using for the long term and the resistance coming up. So this is one concern, but till now this not being seen in the trials. And I think once a drug shows a disease modifying effect, then I think it should be used earlier in the course.
So one more question. How do you see the infection profile in these patients when it's just like an early intervention? So how do you balance with the risk and the effect?
So actually, the one important thing is when we saw the long term data of Comfort 1 and 2, the infections other than the non-hematological toxicities, they found the incidence less. So whatever incidents we have, like we know the increased risk of infections, especially tuberculosis in our country, but long-term use has not shown any increase in the infection risk in these patients in these trials.
So I have two questions actually. Number one is that in intermediate one risk, is it like if the patient is symptomatic, then only we should start ruxolitinib? And the second question is, if we are taking the allelic burden, how frequently we should monitor a patient on intermediate one risk having ruxolitinib, and then how we should monitor that allelic burden?
So when I started my talk, so one thing which I said that intermediate one risk category, everyone is using. Why? In symptomatic patient. Why? Because this is something which actually like tempting us that start ruxolitinib. When a patient with a large screen comes with high grade fevers, comes with loss of weight, lost 10 kg, 20 kg weight, nothing can stop you. You will definitely start ruxolitinib. That's a beautiful drug in managing these constitutional symptoms. But exactly they have not seen in the trials. I think most of the patients what where the experiment started, because data comes from where? From the expanded access trials, from where the compassionate basis drug was used. So in which patient it was used? Most of the patients were symptomatic patients. So there is no difference that whether it was started just for the high age, just for the low hemoglobin, but it's a combined data. There is no, they have not shown that this patient, only this percent patient because of symptoms. I think most of the patients in these studies also, they were symptomatic patients. So it's still the role of intermediate one comes in more in the symptomatic patient. But once it is showing reduction in the allele burden, this shows there is a disease modifying effect. So this is one point where I can say that we can use even in the patients of intermediate one other than symptomatic, less for just for the age, just for the low hemoglobin and or any other indication. And coming to allele burden is still is an investigation. Most of the time we are no one is using just checking for the allele burden. So it's a parameter for the investigation. And I think this would be used in the trials only, can be used in the trials.
Okay, sir.
So thank you.
Thank you, Dr. Farhan.
Thank you so much, sir. For the next talk, I'll invite Dr. Nikhil M. Kumar to discuss the management of low-grade MDS. Please, sir.
I thank the organizers for inviting me for this talk. Really happy to be back here again. I think we'll stick to discussion of management of anemia and low risk MDS. So as we all know, MDS is essentially a condition where there is ineffective hematopoiesis resulting in cytopenias and related complications. Despite all the NGS mutations and all that, it is fundamentally important to understand the difference between low risk MDS and high risk MDS. Low risk MDS is essentially a maturation arrest at the level of common myeloid progenitors and the differentiation to megakaryocyte erythroid progenitors. So this is what leads to ineffective erythropoiesis and essentially cytopenias. Whereas high-risk MDS is a more proliferative condition where there is excessive proliferation of long-term hematopoietic stem cells as well as the myeloid cells. And because of this, there is a high risk of progression to acute leukemia. Looking at the timeline of approvals, post 2019, we've seen a lot of approvals for MDS, starting with luspatercept in 2021. And going forward, imetelstat was approved last year in 2024. And the year prior to that, 2020, decetabine cedarzine oral was also approved. Moving on to a case, 56-year-old female presented to us with excessive fatigue, received several courses of hematinics outside, was transfused twice in view of fatigue. No infections, no other lymphadenopathy or hepatosplenomegaly on evaluation. Found to have anemia, MCV of 102, reversal of neutrophil lymphocyte ratio. The markers were essentially normal. Since patient had received a fair trial of hematinics, we went on to do a bone marrow examination which showed 2% blast. Erythroid dysplasia was noted with 20% wing sideroblasts. An NGS was done which showed SF3B1 mutation at a VAF of 31%. So very often we would see whether patients need an NGS once there is a morphological diagnosis of MDS, especially with something like ring sideroblasts, in which case we expect SF3B mutation in majority of the cases. Is an NGS required? So we'll come to that later. The erythropoietin level was less than 200 in this patient. We are all familiar with the WHO 2022 classification. This patient would fit into MDS SF3B1 mutated and low risk. Before we move on with the treatment, it is important to realize that dysplasia is not synonymous with MDS. We need to rule out nutritional deficiencies, take a thorough history of drug intake, alcohol, and during infections, it is very, very common to have dysplasia in the marrow. Also, many patients do take herbal medications and alternate system of medications, which also can have dysplasia in the marrow. So before we label the patient as MDS, it is worthwhile looking at these factors. And also important to remember that many autoimmune conditions can also have marrow dysplasia. So once we diagnose risk stratification, we have all been following the standard IPSS-R risk stratification, where patients are stratified into very low, intermediate, and very high risk. I'll not go into details of this. This is something which we have been following for all our patients based on various prognostic variables like cytogenetics, bone marrow blast percentage, hemoglobin, platelet, and ANC. Patients are stratified. Molecular risk stratification has literally changed the treatment landscape. Many patients are re-stratified. Many low-risk patients are re-stratified into high risk or the other way around based on the mutations. So in today's day and age, every patient needs to get a next-generation sequencing because many patients, when we think of them as low-risk MDS, we might be in for a surprise when we look at mutations like TP53 and other high-risk mutations in many of these patients. So this is a mutation profile in patients with myelodysplastic syndrome. And based on this, patients are risk stratified. There is an online calculator available for this. And based on this, patients are risk stratified into very high, moderate, very low, and low risk. This also incorporates the IPSS-R risk stratification and over and above the mutation profile of these patients. So going back to our patient, are all SF3B1 mutated patients low risk? The answer is no. Based on the co-occurring mutations, these patients can have very different prognosis. If there is an associated ASXL1 CONNEX1 or other mutations, we very often see that SF3B1 mutated patients have an inferior outcome. So even if there are ring sideroblasts in the bone marrow and patients are diagnosed to have MDS RS, it is still worthwhile getting a genetic testing done because co-occurring mutations with SF3B1 have a significant impact on prognosis. So this patient was diagnosed with MDS low blast and SF3B1 mutation. The erythropoietin level was low. After discussion with the patient, was initially initiated on erythropoietin. Many of the patients we see in our practice fit into this category of low risk MDS. Do we need to treat all these patients? Probably not. However, patients who have cytopenias, who are symptomatic at diagnosis, need treatment. The primary goal of treatment is to elevate the symptoms, reduce or eliminate the transfusion requirement, and most importantly, improve the quality of life while minimizing the treatment related toxicity. It is important to note that patients who are transfusion dependent tend to have inferior overall survival. This was from a study way back in 2007, where they noted that patients who are transfusion independent tend to do better and have a better overall survival, making it prudent to reduce transfusion requirement and strategies in low risk MDS. We have several treatment options available. ESAs, which we commonly use, lenalidomide, especially for MDS with 5q minus. Luspatercept has been approved and this has shown promising results, especially in patients with SF3B1 mutation. Imetelstat is a recent approval, especially for patients who have failed one or two lines of treatment. Even in low-risk patients who do not respond to the other treatments, we very often resort to HMAs. Erythropoiesis stimulating agents is acceptable for treatment of symptomatic anemia, especially in patients with a baseline erythropoietin level less than 200 or even 200 to 500 in select patients. Patients with deletion 5q, ring sideroblast or mutated SF3B1, it is important to identify these patients because we can treat them differently with effective agents. Immunosuppressive treatment works quite well, especially in a hypoplastic MDS setting. When we compare the two erythropoiesis stimulating agents, both erythropoietin alpha as well as darbepoetin alpha have similar efficacy and toxicity. Hypertension should be controlled as this is a common side effect that we see with both these drugs. Large studies as well as retrospective analysis have not found increased thrombotic risk or increased risk of transformation to AML with these agents. The target hemoglobin is around 10 to 12. We are on the side of caution and we do not give EPO when the hemoglobin crosses 11.5 12 as higher levels have shown to have increased risk of thrombosis. We usually expect a response within 6 to 8 weeks of starting treatment, and there is some data to suggest that even in patients who don't respond, combining USAs with fulgastrin, the response rates are slightly better as compared to erythropoietin alone. However, what is problematic is that the median duration of response is usually around 18 to 24 months. Can we really predict which patients are going to respond to USAs and which patients don't? There is a scoring system for low-risk MDS based on the baseline erythropoietin levels as well as the transfusion requirement. According to this, patients are given a score and we can stratify patients who will likely have a good response versus patients who are unlikely to respond to EPOs. This was a study which was published last year in Lancet. For MDS 5q patients, even those who are transfusion independent, a low dose of lenalidomide at 5 mg was shown to delay the onset of transfusion requirement. These were patients who were asymptomatic and transfusion independent, randomized to receive low dose lenalidomide versus observation. And as you can see, in patients who had received low dose lenalidomide, the transfusion requirement and the onset of needing transfusions came in much later. Luspatercept is a drug with a unique mechanism of action. The TGF-beta SMAD23 superfamily interaction is responsible for arresting erythropoiesis, and this is aggravated, or this is one of the mechanisms for ineffective erythropoiesis in MDS patients. Circulating luspatarcept binds these TGF-beta superfamily ligands, thereby arresting this process and allowing the erythroid maturation. The development has come in through a long way, initially with the medalist trial where luspatarcept was compared to placebo, and then going forward, the COMMANDS trial, which basically compared luspatarcept with erythropoietin alpha. This was a landmark medalist trial with randomized patients to receive luspatarcept versus placebo. The starting dose of 1 milligram per kg every 21 days can go up to a maximum of 1.7 milligram per kg. And as you can see, at different time points, 8 weeks, 12 weeks, 16 weeks, transfusion independence was much higher in patients who received luspatarcept, and so was the mean hemoglobin levels. COMMANDS trial was a landmark trial which basically randomized patients in a 1:1 fashion to receive luspatarcept versus epoetin. Response assessment at day 169 and every 24 weeks thereafter with post-treatment follow-up. The primary endpoint was RBC transfusion independence for more than 12 weeks with concurrent increase in hemoglobin of at least 1.5 gram per deciliter. The secondary endpoints were transfusion independence at 12 weeks and 24 weeks. Safety signals were assessed. As you can see, in patients, especially who are positive for ring sideroblast, there is a significant improvement in the transfusion requirement in patients on luspatarcept as compared to epoetin alpha. Though this requirement Though this difference was lesser in RS negative patients, in almost all other subgroups, be it patients with low erythropoietin versus high erythropoietin level, ring sideroblast, non-ring sideroblast, mutated SF3B1 wild type, in almost all the subgroups, the transfusion independence rate was higher with patients on luspatarcept. I'll skip this. The last drug to be approved last year was a one of its kind polymerase inhibitor, imetelstat, and this was approved based on the phase 3 IMOS trial, where imetelstat was compared to placebo in IPS's low or intermediate risk MDS in those patients who are refractory to ESA or EPO and transfusion dependent, requiring at least more than 4 units over a 8 to 16 week period. The responses were favorable with patients on imetelstat showing lesser transfusion requirement and more patients being transfusion independent on long-term follow-up. I'll summarize my talk with this slide. This is from a JCO oncology practice published this year. In low-risk MDS patients who are asymptomatic, who are not transfusion dependent, supportive care would suffice. In symptomatic patients with anemia and a 5q deletion, a trial of lenalidomide with or without erythropoietin stimulating agents would be the first line of treatment. If there is no response or patients do not have a 5q deletion and have ring sideroblast or SF3B1 mutation, it is essential to look at the EPO levels. Even in patients who have SF3B1 mutation or ring sideroblast with a low erythropoietin level, erythropoietin stimulating agents can still be used effectively in many patients, considering the fact that these are way cheaper and luspatarcept is still relatively expensive for a long-term indefinite treatment. However, if patients have a high erythropoietin level, USAs are less likely to work. In patients who don't have ring sideroblast, 5q or SF3B1 mutation, luspatarcept can still be tried as a first-line agent, and if these don't work, imetelstat can be used at relapse. In our practice, we very commonly use HMAs like azacitidine for these patients, especially who have failed initial treatment with ESAs and luspatarcept. I conclude here. Thank you for your patient listening.
Thank you, Dr. Nikhil, for your excellent talk. Just wanted to ask you, would you place danazol somewhere in the algorithm in a patient who doesn't have a 5q minus or a SF3Q1?
So we use danazol very commonly in our practice because for most patients, even now, luspatarcept is not affordable. So the options we have for real practice are very limited, which includes ESAs whether it is epoetin alpha or darbepoetin, we use routinely for all our patients, especially when the problem is transfusion dependency. But once patients fail ESA, the other agents are very limited. If luspatercept is not available, imetelstat is not available for most, we are left with either lenalidomide or few agents like danazol. So in some patients, it is known to work, and especially in patients with a hypoplastic MDS, immunosuppressive therapy, just like how we treat an aplastic, hypoplastic MDS, many of them do respond to cyclosporin, danazol, or even ATV. So yes, all these agents have its place in practice, but with standard guidelines moving away due to availability of new agents, that is why it is not mentioned in the current algorithms.
Thank you, Dr. Nikhil, for elaborating this topic in such a calm manner, which you always do. I would like to re-emphasize one thing which he said, that dysplasia is not always equal to MDS, which we as a hematopathologist face quite difficult, because MDS is most easiest as well as the most difficult to make diagnosis. So the mimickers which he told is always good to rule out them first, then to move ahead to make a diagnosis of MDS. So thank you so much.
Thank you.
Thank you, Dr. Nikhil. For the next talk, I now invite Dr. Suparno Chakrabarti, who will be talking on the role of cellular therapy.
Don't bend it. Straight.
Straight is
Symmetrical. That's your problem. ट्रांसफर कर लो ट्रांसफर कर लो ना लगा के रखो वही कर लो नेक्स्ट ये लास्ट Can I have a mic? Yeah, for everything of if you have time. Yeah, so Rahul is really insisted safe way, and I'm not really what to talk about really. Because there were too many things happening of late with us. So, I mean, I would start on the premise that, of course, I'm talking about foundation. And that entire story of transformation in the context, the GAH and TBI. Now we can have both GAH and TBI, the patient will be cured of TBI or die of TBI. You can have TBI and no TBI. It's possible. Or you can have TBI and no GAH, the patient with some TBI. Now, how can we predict or decide as to how to make this happen? Where you get no GPA, and that's what in critical balance economy, the only way of transformation is. Now, with this background, I would shift the focus and put some questions to the people sitting over here. That, so this is the the basic premise of T-cell activation. How T cells are undergoing or serial within
antigen recognition, the PCR MHC interaction. So without PCR MHC interaction, nothing is going to happen as far as T cells are concerned. So when the T cells or would be T cells are released from the marrow and migrate to the thymus, so they have three things. One, they would recognize the cell kinetics, or they would not. Believe me, 95% of cells will not recognize cell kinetics and they die. And this cell is called death by the ignorance. So the thymus is ignoring it. Go to bed. You're not going to live. The second possibility is that reacting to the cell kinetics. The recognizing cell kinetics every time. The thymus cells are not too good to be, hanging around the body. So you also get lost. So who are the ones who stay? The ones who show lower ability to circulate. They will then proceed from the cortical to the medullary thymus, and I'm not getting into the process, and they will release the circulation as non-autoreactive self-MHC recognizing T cells. On the other hand, there are some cells which intermediate. Then, depending on the situation within the thymus, is there not are these cells going to express CD25 receptor? When they will they express of CP as a concentrate, these cells will become the primary presenting. So at the end of the day, we are left with conventional T cells, CD4 and CD8, 9, when the fetus is born, and regular T cells, which are going to counter the autoreactive T cells. So with that premise, what happens is that there are billion T cells in the circulation, and billions are produced every in the hour of body. And one in a billion T cell will have a particular antigen. Take for example, with a CMV, where it's colon cancer, there is a Epstein-Barr virus infection. One antigen in one T cell will decide whether this virus will be encountered with the T cell or not. And in that case, the T cell will be the rest of the clause will become a million T cells. And out of those million T cells, if you encounter the virus, majority will die with this called an activation induced death. And some would survive as memory T cells, very few cells, 2 or 3%. And those cells need not be going to the cortical end and the same antigen is involved. Now, this is very, very antigen specific, and there is a reason why nature has created a whole meaning like this. If you let the T cells run more, a human body will not survive on the involved. And why is that? T cell activation is a humongous energy active process. So when I'm just casually saying that one T cell would become a million T cells in 72 hours, it's consuming an energy equivalent to running this whole building, you have to understand, within the human body. So can we survive this supplementation and they have both hands? We can't. That's what we call the COVID-19 infection. It was not COVID-19 which was killing us. It was this humongous cell reaction which was killing us. And who was figuring it? The antigen presenting cells or the macrophages. But what happens due to this antigen sensitivity? That when our take, for example, a B cell AL, and a T cell will be directed against it to eliminate it. The leukemia outnumbers it, the leukemia boxes it. It cannot kill those leukemia, and the leukemia ends. So for last 20 years, the scientists, especially from November, they were trying to override this whole process. That let's not get into this medicine PCR business and create a situation where we can identify the antigen directly and kill the cells through the process of B cell activation without engaging the matrix PCR interaction. And so was born CAR T cell. Now what happened next? Leukemia was cells got dead, of course. But what we did not understand, did not expect, or did not anticipate was a humongous level setup. The anti setup, the acrylic setup, it happens because we have overridden the natural path. We don't have any control over that anymore. So when the whole thing happens to a natural process, there are species to switch on and off. Like you know, the gravity that gets activated, you know, difficulty in this lightation for the post stimulation part. When this gets activated through the ligation, the antigen, subsequently the post stimulation receptor tracking. So that's that process. Now, when you're making car, you are integrating to move up. So you're not having an antigen implementation absolutely. So the signaling is very different than what happens actually to these act. And that is the reason that when these systems get activated, so what we call on target toxicity. These are on target toxicity. Now, my parents, is it an off target toxicity or on target toxicity? No one knows that. Humongous amount of paper is going on to understand that. I don't know. Just like simply ligating anti-19 missile talk to the T cells, the T cells are working out. Now, those who are into car, I mean, that what is the purpose of manufacturing car? You are taking CDP cells and you are constituting the car, the environment. Some are doing 3-4 exploration, indicate the exploration is getting cost 40%, 50% will be cost in front of, but we do not know which cells is the constitutes. Whether they are going to be CD4 and CD4 9, CD4 memory, CD4 central effector, CD4 what's so we are using the France. And most importantly, and I found that regulatory T cells are measurements. So are we guarding the threats or are we solving the threats? What is that? That is where the issue of the God of denial. If we can figure out which cells we consume and how we share the threats, we might be solving this problem. But how much time do I have? Take it. Okay. So what will you tell me if I tell you that he says about the primary um, candidate for are constructs. T cells were an afterthought in the process of, farming the immune effectors. They were easily available, easily transmissible. The more difficult transmissible cells used to be probably histology, when organization, and that very difficult to get in that. So when people are transducing our constructs into T cells, we are pretty much going into a deep sea. And I just told you that one of the or the savior mode is locked in the middle and is a regulatory T cell. Now what happens in the regulatory T cell is that if you have regulatory T cells in the midst, the IL-2 which is produced during the T cell proliferation is being consumed by the Tregs much more effectively and efficiently than the uh, T cells which are getting activated, the conventional T cells which are getting activated. And in that process, the T cell activation slows down. So when we are doing CAR-based process, it's not. So people who are into CAR, they have lost sight of this completely. They are into killing the tumor. They are trying various methods to reduce toxicity by, say, introducing catheters to switch off the IL-6, EMCSS, etc., etc. But the basic point is this, and that is what I am telling you today, that it is not through altering the CAR construct or introducing various cytokines switching off or on is going to solve the problem. It is to recognize the activated T cell and regulatory T cell interaction, which happens in a normal homeostatic situation, in a normal infection, in a normal cancer situation, to try to replicate that. Now, the beautiful example of that is what? Tumor infiltrating lymphocytes. I don't know how many of you, because we are hematologists, we are not into the solid tumor domain. We don't know that, again, Rosenberg started this some 10, 15 years back. And recently there was a publication in patients of melanoma. Those who received pills and responded, 70% of them are disease-free at 10 years. So what do we do with pills? So we take out the tumor, we create a single cell prep, isolate the CD3 cells or whatever cell I want, culture them, expand them, infuse them. Now, all those T cells are not cancer specific. So how do we identify the cancer specific cells? When I was describing T cell activation, I intentionally did not mention it. So these T cells did not die a natural activation-induced death within the tumor, right? So these T cells are alive within the tumor, and how are they alive? So T cells which are alive within a tumor microenvironment, how are they alive? Because they should have undergone an activation-induced cell death. Because of chronic antigen exposure, they have expressed the receptor PD-1, which is just letting them survive without death. This is the process of exhaustion. They're exhausted, they cannot exert their anti-tumor function, but they're alive. They can still be reawakened. And when from the tumor these cells are isolated, if we isolate them based on PD-1 receptor expression, we would be actually isolating tumor specific T cells. And so when you again introduce them to, so how do we get over exhaustion? Just simply expose them to IL-2. Culture them with IL-2 and the T cells will wake up again. wake them up, expand, infuse. It's not abrogating the natural law of TCR-MHC interaction. And the same can be done in biological universe as well. I mean, this is something that we are working on. And if I get down right now, so understanding this concept. Okay. So you have patients with myeloma, you have exhausted your options, you are going for vaccines. However, you are well, I am harvesting the marrow of this myeloma patient. I'm isolating T cells from the but we are still getting lymphocytes. We are getting a kind of rescue on nanoparticle. I'm taking the marrow and I'm taking out the T cell. I see the ignorance, you know, the speaker. I'm isolating those T cells, finding those T cells, I'm taking in vitro, they're taking my own cells, they're doing for me. Human experience, not just one thing, but multiple sorts of media. They are multiple antigen antibodies, not one for the antibodies. So can you appreciate the difference between our antigens as a blood and multiple antigens? And if this is successful, it's a far bigger opportunity for what we have so far. And this still learning.
A couple of years back, the dendritic cell came for a multiple myeloma, and then probably the science didn't grew because that was the concept to eradicate the MRD by harvesting the dendritic cells with myeloma.
Dendritic cell influence the brain, tremendous cytokine release that skills to a dendritic cell vaccine for brain. So when you act the dendritic cell with the cancer antigen and you then become the cytokine release. And when you try to aggregate that cytokine release, so there is a still lot of tension in the dendritic cell there, which is not been explored for you know. So, as I said, there is a humongous prospecting diabetic cell therapy, which is us. So, we have actually explored another way of doing diabetic cell pulsing, uh, which, you know, has not been very successful until now. So, how do we activate or deactivate? So, my interest was in this doing actually uh, deactivate or why should I say that, you know, make these dendritic cells important as antigen presenting cells in conform non-malignant allograft or GVHD situation. So if you are trying to kill cancer by pulsing them with this, no, I am trying the other way around for GVHD, which is partly achieved by ECG. One of the mechanisms of ECG is still known. So we are trying it in vitro. There are few things tried, they are not successful. Another recent paper came by a couple of months back in blood where they said the bone marrow has got less of NK cells. These people not react as quickly to daratumab and people who got NK cells. Then kept me thinking about is that because of the deficiency of the NK cells in the marrow, that's why they escape it as being killed. I mean, more benign NK cells, T cells you have, and you all work on NK cells, phenomenal for getting from that. So, what is the thought of the NK cell science and somebody think this way back. Rahul, it's a fantastic question. Now you have to get 1 or 30 minutes to answer this. I really appreciate that Rahul, that so much of science in him which only came out to the middle of a stone over here. I'll just tell you that we have looked into this because, see, the interesting bit is anti-CD38 fluoroptic myeloma cells, but a large proportion of NK cells express CD38. So when we are giving daratumumab, we are eliminating NK cells as well. And this daratumumab, which is not conjugated with the toxin, is 40 to 86 to NK cells. So it is a double-edged sword. And that's why we often find that when you are using daratumumab in a relapsed refractory setting, it does not work so well as when you are using it upfront. So of course, inherent NK cell dysfunction is one thing, and daratumumab induced NK cell elimination. Yeah. Thanks for bringing this up.
So, congratulations for two things. Finishing your talk with just two slides. And then the other thing is the challenging the dogma. I think it just makes us think that what we know is maybe we know very little. And what I understood, so you are just saying that a minimal interference with the mother nature and using that cells to kill the cancer cells. Um, can you just tell when you do this, is it going to work with leukemia, lymphoma, other cancers, and will the CRS and toxicities be less? Is that what the thought process is? If you do this, so they select out the cells which are there in the genes and then stimulate them with as minimal intervention, not in cars and trying to stimulate. So, is a thought process that this will cause less toxicity but be more malignancy specific?
Yes, very good question. And actually, this slide I had put in as an afterthought when Srinidhi called me. Said, "Why do you have slides?" So I picked up this slide which was actually on adaptive anti cells. I put this extra slide on this and got it, changed the heading and got this. There is a whole talk on what you are mentioning right now on the back of this. So basically, we have done this with NK cells. I cannot, don't have time to detail, but yes, if you boost the natural process, and mind you, I mean, when you are doing NK cell modification in vitro, not but cytokine induced modifications, there is something called cytokine addiction, cytokine starvation, and cytokine deprivation. Specifically, so CD50, IL-15 is the cytokine used for NK cell circulation. Now, if I keep NK cells for 3 days with IL-15, they become Hatta. I keep them for 7 days, they're ready to die. I keep them for 15 days, they are ready to kill. So a lot of cells, why NK cell therapy has not succeeded? This was a part of America's popular visit. That why NK cell therapy has not succeeded because we overstimulated them. And what is something they are becoming dependent on the cell. Then we are taking the system and using it it doesn't require the team jumping around. So people have whatever I do something over he does themselves were restored to feel leave the power of the so the economy of the being given to the patient. So give them the certainty and then these cells, the moment I will be level comes down, the radiation into the cell. So there is activating into the cell and there's the radiation into the cell. So the doing more is not yours. And some 10% is doing less, which we have tried to do for very good results. But again, for someone. Okay, last question. I think that's just expressing to make us know what cells are infiltrating the tumor at what point of time, whether we will early at diagnosis versus the late relapses, which still can in the future probably next or by 2030 can give us knowing what we use. Absolutely. Identifying the subset is very important. So, NK cells, right? We know about characters of the often by European. Then we go into serials and clinical cells. Up to 115 something like that. Now, whether they are functionally separate or not, we don't know. They clinically separate. Now, some of them might be more kinase as an anti-tumor, some of them might not. That's a different question, but this is a tremendous issue of research which we will not. Single cell only is absolutely. That's the question for
So that is spatial transcriptomics, and that does in situ single cell RNA sequencing in in the spatial orientation of the tumor, and it can tell you all sorts of co-expression also, and it's an image based thing, so you can really talk out the entire architecture of the tumor and understand where what is situated. So So one flow cell, that is one slide because it goes as a microarray. 150 section has to be taken and it will go. So you can put one lymphoma sample or you can put 197 on one slide. And one slide costs $7,000. So, I mean, if you do it, one slide is $7,000. You can do 197, but then that is a theoretical. No, this is Zimio. It's a separate machine. There is no sequencing involved. So it is $7,000 divided by the number of samples. So you don't have to take $7,000 from everybody. Yeah. No.
working till about 2018, 19, 21, about all nanopore RNA sequencing of healthy donor samples, patient samples to understand infectious. And that's another topic. Yes, I mean, of that also we detected a number of subsets, different gene signatures, different gene expressions in different individuals based on the genotype, the status of infection, etc., etc. And yes, it's also possible. I mean, what near transcriptomics for heme malignancies is possible on nanopores. Just another last comment. Here's what immune transcriptomic kit. There's a certain kind of
Yeah, we do. We do. So yes. Yes.
so technically, Linux is looking at a translated product. You are looking at the transcribed product. You are looking at the RNA. You are Linux in
Protein.
you are 390 with it.
Not really. Not really. Little more advanced. Yeah. I mean, yeah, he knows about it.
Thank you, sir, for the lucid talk. Thank you, chairpersons. We now begin with session 5, which is the infectious disease. The first speaker, I would like to call Dr. Neha Rastogi Panda to talk about Letermovir. And the chairpersons, I would request Dr. Yatendra Parashar, Dr. Meet Kumar, Dr. Kirtana J, Dr. Nitin Bansal, and Dr. Shirok J to please come on dais. Thank you. Good afternoon, all. First of all, thank you for bringing this topic because Letermovir, and as we are advancing in the space of the transplantation, we have been hearing for 1.5 day now And we are also entering into the space of more bite therapies, more CAR therapies. So this game changer is essentially required because CMV at the outset becomes always a problem. So when I start my slide, I would say that we are all in the country where the CMV reactivation is always have been a problem because we are quite high seroprevalence zone. And just to talk about, we have been seeing this paper which we presented was a pre-letermovir era. When we saw that more than 100 plus adult allogenic transplant patients, we got close to 70% of the CMV reactivation rate. I'm talking about the allogenics. So in that settings, when the CMV reactivation comes high, when it goes before 30 days, it causes a lot of toss in terms of the graft loss, even at the risk of rejection. And beyond that, increased risks of transfusions, both the bug and the drug also remains a major problem. So when we know that preemptive therapies have been not much backed by the myelosuppression, not backed by the nephrotoxicity, so we always needed a molecule which helps in prevention of the CMV reactivation. So talking about the letermovir as a molecule, so we all know about its mechanism of action. So other than the normal drugs which causes from the DNA multiplication level, letermovir works on the packaging area, which will inhibits the CMV DNA terminase complex, and that is required for the final CMV DNA packaging. Then how it prevents the reactivation and inhibits the multiplication further. So we all know about that now. It's a now new onset reality. Both the adult and pediatric transplant teams have been heavily using the letermovir in their set of patients for the CMV reactivation prophylaxis. Of course, it has been also extended in the solid organ transplant as well. Spectrum, one very important thing to highlight to all of us is a cyclovir has to be simultaneously being used with the letermovir because it is not going to be protective against the herpes per se. Regarding the pharmacokinetics, as we know that it is being rapidly absorbed from the gut and also the elimination is majorly excreted in the feces. One important highlight with the interaction, we all know about the cyclosporin. I'm just going to tell you about a little bit on the roles in tacrolimus as well in the next of the slides. Dosage and recommendations, we all know about 30 kgs. We have if cyclosporin 240 mg, without cyclosporin 480 mg. For the pediatric age group, although there is a difficulty in cutting down the capsule part, we are soon coming up with the pellet formations also. But for the time being, 30 kg, 15 kg to 30 kg, you can give as much as less for the 6 kg of a kid as well. Coming to the efficacy and real world data, so this was the landmark trial of NEJM which has first backed the letermovir usage in the adult allogenic population. And this was a quite big 560 plus patients data. And they have come out to be significantly low risk. If I just cut short on this and coming to the summarization part, that it has been clinically reducing the CMV reactivation rates at 24 weeks, which was in its initial primary endpoint, in close to 37% versus 60% in the non-letermovir arm, which was very much statistically significant. And the best part about it is, as we all know, those all drugs are backed by a lot of myelosuppression and toxicity. So compared to that, this molecule has very mild toxic effects. We all observe nausea, vomiting, though they are much confounded by the concomitant cyclosporin usages and all. But it was very mild and well tolerated by all the patients. Another paper showing the systematic review and meta-analysis of most of the observational studies, which were close to 48 in number, and they have been found out is that the letermovir usage is not only reduced with the significant CMV rates, attributable mortality, and also decreasing in the terms of the relapse rates, which can be a question of debate also, but at the same time, it also sometimes reduces the risk of immune reconstitution as well. So this is our own data which we have just recently submitted. So we have an experience of so far 22 CMV seropositive patients in adult allogenic settings, which we have started on day plus 7. Majority of them were AML, followed by MDS and the ALL and other indications. And we all started them on the day plus 7, thanks to the compassionate access programs and the compassionate access through the generic and the bioequivalent letermovir. To the rest of our things, we saw that amongst those 22 patients, CMV reactivation occurred at 6 patients only. Of them, 2 had the intermittent, the organ involvement in terms of colitis. One point I want to highlight is that those patients also have, of them, 2 patients also have a concomitant GVHD. So we still need to know that increasing the immunosuppression still has its own bearing, even if you are using letermovir as a CMV reactivation prophylaxis. Also, one of the patient has a low level viremia that is less than 1,000. So in this patient, we still continue on letermovir, which has been now validated in few studies, even recommended for the low level viremia. Now we all know about this established usage of letermovir. We have been hearing a lot about it. What is the future and the data looks like in terms of both perspective and our perspective? Pediatric data set, which is also being increasingly used now. What is about the secondary prophylaxis? So many of you transplanters have come across that you have started the patient on the initial valacyclovir as a routine prophylaxis, and in the mid of something you develop the initial first CMV episode. You come out of that ganciclovir episode, your CMV comes down to less than 1,000. You continue your post-transplant journey, and now we are more afraid of getting a reactivation of CMV again. So can we use and place this letermovir as a secondary prophylaxis? What about the breakthrough data, resistance, drug-drug interaction, which also remains a one important concern, and usage of extended duration of letermovir prophylaxis? So just to talk about each of them in a minute. So use of letermovir as an efficacy and safety in terms of the secondary prophylaxis comes also important. And this highlights the also, so this is about the pediatric data set. As I showed you that the capsules are available, but it is little difficult to take them as a whole. So we still have to open it up. But for the time being, these are the few studies which has been done in the pediatric data set population, and they have been shown that the significantly more risk of CMV reactivation in the letermovir arm as compared to the control group. The another study is by the Italian Association of the Pediatric Hemonc Group, where they have retrospectively recruited almost 87 plus children in across 11 centers, and they have seen that none experienced in the CMV clinically significant reactivation rates. This is our main experience till date. We have so far 20 patients who were initiated on letermovir, and they were started on day 7. Though the even high risks of breakthrough were there in the pediatric population, which was kind of attributed to there are major breakthroughs in the sickle cells. So we have hypothesized that their ethnicity is such which makes them more prone to the CMV reactivation. So one option can be sickle cell undergoing a haplotransplants usually. You can start the letermovir even on day +1. They have seen that early reactivation causes quite a lot in the sickle cell population when they undergo the transplant. Regarding the secondary prophylaxis, I'm talking about, so as we say that first episode of CMV has gone, and now we are introducing letermovir in any time post-transplant to prevent the secondary CMV reactivation reduction. So this was a paper of the Compassionate French Access Program where they have recruited those 80 patients, and out of those 80 patients, only 4 developed a further breakthrough in the rest of their post-transplant period. The another one point I want to highlight, how many of us has come across that we have started letermovir and see the CMV reactivation or the CMV number comes as 546 copies or 600 copies or for that matter 1025 copies. So how many of us will try to switch? I mean, of course, by the definition or the guidelines, they say, okay, any number which is significant more than 500, switch to the empiric drugs. But the problem of the fact is, switching someone on ganciclovir were technically 2 weeks versus seeing that can we continue on letermovir was a question. So we have come across a lot of studies and it came out that these viruses also have something called as blips. So they have a subsequent small fluctuations in their copy numbers. And in few of the patient, in fact, one patient I've also invested in our study as well, where we just diligently monitored the viral load and we never changed the letermovir, and the patient cleared out CMV viremia in the subsequent weeks of time. Regarding resistance in CMV, so we were talking about in the military break about how much common is the resistance of CMV. So one problem in the resistance of CMV is technically not much access to the resistance testing still in our country. Second thing is CMV viral load has to be at least bare minimum 5,000 and above copies to detect the resistance mutations. So we know about the refractory versus the drug resistant mutations and the resistant CMV. So in terms of the letermovir resistance, though we all know the theoretical mechanism, but practically there is hardly any data which said that letermovir resistance has come up so far. So this was a paper on the CMV breakthrough and resistance during the letermovir prophylaxis. and they recruited 226 patients, out of which they took out that 95 patients who had a breakthrough at different point of time. Letermovir per se resistance was not shown in any of them, but they got the CMV breakthrough because of usage of steroid exposures in one of the other, GVHD prophylaxis, steroid resistant or refractory GVHD requiring the Jakavi or any other drugs, including the etanercept in the longer run. So they were more associated with the CMV breakthroughs. Drug-drug interaction, just one highlight, voriconazole, because that is one of the commonest antifungal prophylaxis being used in post-transplant. While vori is being metabolized by CYP2C19, as the letermovir is one of the inhibitor, so it actually reduces the voriconazole action in the post-transplant settings. So wherever we are using these two combination, try to have a therapeutic drug levels being ready for the voriconazole levels. Extended duration, another thought process, because in our of the studies, two of our patients have the reactivation at the day 130, whereas the usual trend and the usual guideline says that you can use the letermovir up to day 100. So when we are using the extended immunosuppressions, when you have a GVHD in between as an event in the post-transplant, can we extend the letermovir duration even up to day 200? There are group of studies being there for encouraging that usage, but of course, cost has to further come down, and we need more data to actually evaluate this part. So the ultimate thing is to conclude is actually to begin this thing. We need more and more studies and centers regarding the letermovir usage in the different population and in different settings, which we have mentioned. Extended prophylaxis, how CMI monitoring. We were just discussing in the previous lecture about the immune monitoring mechanisms. So even CMV, the almost dearly of all, we need to know that how the CMV monitoring in terms of immune refunctions. We have now established immune reconstitution panels at our centers, but we also need the specific pathogen-specific immune monitoring in the longer run. Low-level viremia, low role of letermovir to still continue. Letermovir has its place in the BiTE therapies, in the CAR T therapies, and of course for that, we have just launched the CMV working group with ourselves under the aegis of ICHS, which is International Immunocompromised Host Society, where we all should combine and collaborate our own letermovir immune data so as to have a more meaningful conclusions in the end. Thank you so much for your patient listening.
Thank you, Dr. Bala, for very advising. I think I'm going to do many of my things, but highlighting how some patients are really involved between a Delhi and a Rajasthan. One side is PhD and one side is finding the MD application. I think it is a game outside in those seasons. Although that is not a primary indication, but it's a secondary recognize to be a real game changer in some of the patients. And that might be a context which we can start exploring not as family purposes, but as a context of cost and everything else we involved.
This continuity continues in assessing the need of continuing economic patients are let's say and the time is not in countdown.
So actually, quantiferon, lot of data has been there on the kidney transplant patients already in the literature. And we can kind of, so the problem is the kinetics of the T cell in a solid versus the HSCT is quite different. So we have come up, of course, the way we do the CD4 monitoring in our own HIV population, something like that in both terms. You can have a CMV based T cell and the NK cell because NK comes first and then followed by T. If we have quantitative monitoring of the both, in taking the terms of these dips, like what Dr. Anusha has mentioned, you have bringing up the GVHD, the patient is on the steroids, reducing the dose of cyclosporin, weaning off the cyclosporin. So we can have, if we have a trendy way of monitoring it, maybe 2 weekly level or a 3 weekly, we can discuss on that. Then in that terms, we can think on the duration of letermovir, I would say. Yep.
Yeah. And that's why.
Right. So correct me if I'm wrong, Astha ma'am. So ma'am is our lead for that. So we have NK cells, we have T cells, we have T helper, T reg also. We have the B cell population, of course, which comes in the later one. Yeah, no, not in. That's what we were discussing about. Yeah. Thank you.
Great, ma'am.
can we come down on the weekly checking of the CMB levels when as we are giving? Is there any weekly or can we come down?
So that depends upon also the duration when you go out. So usually when we say that the first 30 to 60 days, because it's a whole game about the immune reconstitution, I would say that all of them are allogenic transplants. I mean, especially mud and mapo, I think weekly monitoring is still required. For the MAT CBL, you can come down after 30 to 45 days, which is at the peak level when you get the CMV reactivation. After then, we can go about to the fortnightly as well. I mean, still, we need to check with that how comfortable all of us are we with that.
I don't get any data to show what the actual cause really from basically and how it feels like an over so before. I'm sure it's still evolving, but that will be very interesting to see because it's not a lab-based situation. Some of the recent patients have got ATG as a part of the plant, and went on to get ATG as a part of mud. In a very recent situation, there's like providing the admission. It will be very interesting to see what tradition was given and how post-platform work is for the context of the model.
Absolutely. So one of the paper which I showed about the secondary prophylaxis, that French compassionate program, they included those 80 patients, of which almost 60% of them had ATG being used in one of their conditioning regime. In fact, 6 or 7 patients of that, I'm forgetting the exact percentage, but they have a second transplant also for the some or the other post-transplant complication. So the letter movie has been placed in such a way that these kind of population should be benefited the most, but we still need to see the long-term further data of, because we are only seeing right now at the day plus 90 or day plus 100. What happens to the immune reconstitution post that also is equally important to see. Right. Thank you so much. Thank you, Dr. Neha. Thank you, chairpersons. For the next topic on vaccination, I would call Dr. Chavi Gupta to please speak, and the chairpersons, Dr. Satish Kaur, Dr. Kirtana J, Dr. Radhika Sarda, and Dr. Jatin Ahuja, please.
So thank you, organizer, for giving me opportunity to talk on this topic. So as I could see, lunchtime is there and not everyone is very interested. So I will go very fast. So everything started with this, then come this. Now another bus, which is, so we have an opportunity to explore vaccination in our Indian population. So as we all know, this is a protocol for vaccination in hematopoietic stem cell transplant where we start after 6 months. As early as we can give influenza within 1 to 3 months if there is an outbreak, influenza and COVID. Now PCV13 is being replaced by PCV20. So the schedule for PCV20 remains same. Now, in immunocompetent patients, PCV20 is self-sufficient and we do not need another booster dose of PPSV23. But some people and some researchers say that if we give PPSV23 after PCV20, it will provide an additional coverage. So it remains same. And now we have Hexa vaccine in India for Haemophilus influenza B, Tdap and IPV. Schedule remains same. And this is meningococcal vaccine. It's ideally advised to give after 4 weeks of pneumococcal because of interference in immunity. And the live attenuated vaccine we start after 24 months after proper immune reconstitution. And live vaccines are contraindicated whenever there is an ongoing immunosuppression, severe hypogamma globulinemia, and recent immunoglobulin therapy. So now it looks very simple that this is a chart. You can definitely give vaccine, but it is not because patient is already on immunosuppression. So there is whenever you give vaccine in immunosuppressed patient, there is a reduced likelihood of achieving a robust immune response. But you have to weigh and balance against the risk of acquiring fatal infection. So vaccination is like in a frail tree shadow, even a small seed of protections grow mighty. So it is definitely a helpful thing. Now, vaccine seroconversion in immunocompromised patient is rated as good, intermediate, and poor, and all hematopoietic stem cell transplant and even now CAR-T, they comes under poor response category because the immunity achieved is less than 40% of the as compared to the healthy population.
So your minimum immune criteria must be that there should be absence of GVHD, CD4 cells should be more than 200, normal IgG levels, so that there is an ability to produce protective antibodies. But at the same time, the patient should be on minimum immunosuppression. Now, when to delay vaccination? I, Ideally, when the patient is having GVHD on high dose steroids or gamma globulinemia, vaccination should be postponed. Otherwise, the immune response will not be achieved. But in case of influenza, high risk of transmission, ongoing seasonal outbreak or epidemic, it is advisable to give vaccine because some protection is always achieved. Now, rituximab is a B cell depleting agent. So, ideally, vaccine should be delayed 6 months after the last dose, and live attenuated vaccines 1 year after the last dose. Now, there is a latest literature which says that you do not have to withhold methotrexate with the vaccination. So, this was a data from some rheumatology cohort where they say that do not withhold methotrexate. Now, immunoglobulin and donor lymphocyte, they do not interfere with the vaccination, so schedule can go on. Now coming to the CAR-T. So CAR-T is recently a new therapy, not much data, but whatever data has been extrapolated from the hematopoietic stem cell transplant with adaptations based on immune response. So the cell-mediated immune response recover early as in the hematopoietic stem cell transplant, and the delayed humoral recovery is there. There is a universal B cell aplasia which can go up to even 24 months or 2 years. Even after the quantitative recovery is there, there may be functional deficit and IgA may remain suppressed. So immune reconstitution after CAR-T therapy, which is considered as an ideal, absolute CD4 must be 200 and CD19 or CD20 must be 200. And for the humoral recovery, IgA is considered as a marker of humoral immune reconstitution because there can be interference with the IgG levels because of ongoing IVIG replacement. So 3 key parameters should be there to achieve good immune response for vaccination in CAR-T patients. Now, this B cell hypoplasia and hypogammaglobulinemia may persist for 2 years, so they can affect the vaccine response. So in CAR-T therapy, exactly the same schedule from hematopoietic stem cell transplant cannot be extrapolated. It has to be a customized one. This is a timeline of infections we all are aware. Now the recommendations for CAR-T therapy. In influenza and COVID vaccine can be given pre-CAR-T and then as early as post-CAR-T after 3 months. Rest all vaccines are resumed inactivated vaccines post 6 months of the CAR-T therapy. And now you can see there here it is written that after first dose check titers, then you resume the vaccine. So what is the meaning of titers? I will come to this point. So, in hematopoietic stem cell recipient, these patients are considered immunologically or vaccine naive, irrespective of pre-transplant or donor vaccination. Means if you give even a pre-transplant vaccination, there is no utility in post-transplant patients. So, this same school of thought does not go with the CAR-T cell therapy. So in CAR-T cell therapy, it has been said that preferably give influenza and the COVID-19 vaccine 2 weeks prior to your infusion. Rest vaccines you can resume after post CAR-T infusion. Now, why it is said? Because CAR-T cell trigger and cytokine release syndrome and COVID-19 and influenza are notorious one viruses. They also induce this inflammatory systemic response. So this response, whenever the patient gets infected, so it becomes a very heightened response. And it has been seen in the studies that a lot of studies are there with influenza and COVID that if you give pre-CAR-T, they are able to achieve some kind of protection. So at least the severity of infection will be very less. So only these two vaccines are approved or has been said that can be given before CAR-T. Now it is the immune response achieved with CD19 CAR-T and BCMA CAR-T therapy is different because BCMA CAR-T depletes all B cell maturation antigen expressing plasma cells and are associated with lower antibody response as compared to CD19 cell therapy. Now, if the patient is having given CAR-T therapy after hematopoietic stem cell transplant, then what has to be done? So, for example, if there is a patient with hematological malignancy, he has already received bone marrow transplant and already vaccinated according to protocol. Now, he has gone into the relapse and planned for CAR-T therapy. Now, what will you do?
what should be the vaccination protocol. So case 1 scenario, that patient has gone completed full course of vaccination post BMT, or there might be a possibility that post BMT patient is relapsed and CAR T therapy is planned, but the vaccination has not been completed yet. So what should be the protocols in both the scenarios? So in both the scenarios, after CAR T, start vaccination as per the recommended schedule and check protective titers after first dose. So if the protective titers are achieved and patient vaccination has been completed post BMT, then no additional vaccines are required. But in second case scenario, when if there was an incomplete vaccination, if your titers are achieved, you complete the vaccination course. But if the titers are not achieved, you defer till the patient achieves full immune reconstitution. So is this possible in Indian scenario, because we do not have facility to check titers for each and every vaccine, and it adds to the cost also. So it has to be a protocol has to be made according to the Indian scenario. So these are the recommendation of revaccinating timings on cellular therapy after BMT. So some experts say you can start after 3 months with demonstrated immune reconstitution and no ongoing immunosuppression for killed or inactivated vaccines, and for live vaccines after 1 year with no ongoing immunosuppression and demonstrated immune reconstitution. So these are the research topics. Actually, the literature with the CAR T is very less because it is a new therapy, and whatever is there, there are very patchy few studies. Much of the literature is available with mRNA COVID vaccine, and we in India we do not have mRNA vaccine. We have a viral vector vaccine. So, but it is believed that they will assume the similar response as mRNA vaccine, and in forthcoming our respiratory syncytial virus vaccine will also be there, and still date there is no much data about this vaccine in CAR T therapy. So there is a paucity of data. Whatever has been extrapolated from hematopoietic stem cell transplant or immunocompromised population, pre-existing immunity seems to be preserved post CAR T patients as compared to the hematopoietic stem cell transplant. Now the need of hour is Indian data. So ideally, there is Indian hematology and ID experts should collaborate to develop national consensus recommendation to develop protocol for vaccination in CAR T therapy. Thank you.
Thank you, Dr. Chavi, for a wonderful presentation. You definitely mentioned about possibility of mRNA vaccine in Indian context and vaccination for COVID in these patients. So how do we process the knowledge we have with the vaccine which is existing with us, very CRT patients?
So actually, the whatever the literature is there, it is there with the mRNA vaccine, but not available with our Covishield or Covaxin. But both are the killed vaccines or your T cell dependent vaccine. So it is extrapolated that they are also going to achieve good response, just like pneumococcal and influenza vaccine. But data is not there.
The reason is that I think the adjuvant vaccine and the live vaccine should be avoided. And especially that is why the shingles vaccine, the shingles, is also not to be given before prior to 1 year. Once they complete the 1 year plus,
No, after 6 months,
no,
it is also a recombinant vaccine.
after 3 months,
Viral vaccines, live vaccines are to be
provided
contraindicated.
apart from the adjuvant vaccine like shingles also. Rest like
Can be given.
Tdap.
After 6 months, it can be given, but that is not a very life-threatening infection, and already patients are on some kind of immunosuppression. So we have to prioritize the life-threatening conditions like your pneumococcal, influenza, and COVID.
So, before coming over here to your session, we are also going through the same guidelines. So ASCT has recommended some guidelines about CAR T
Yes,
cell
so
vaccination
every
patient.
guidelines,
And
all these are
one of the best
consensus
center which
recommendations.
they have recommended is the uh, Fedrid Hutchinson Center of this, which is in Seattle. They are the most expert, and all over the world, they are all the guidelines are followed from this center only. They are saying that if it is an adjuvant vaccine or it is a live vaccine, it has to be given after a year. Before
yes,
that,
yes.
all this Tdap,
Inactivated vaccines. Yes.
hepatitis A, hepatitis B, this can be given along with the titers evaluation.
Yes, titer evaluation is given, but in Indian scenario, we do not have facility to check every titers.
Yeah, but
And
at least with tetanus, we can test. We can test the
Whatever
happy levels,
possible you
happy
can
levels.
test, but it will add to the cost. So better to provide
Any
vaccine.
person going for CAR T therapy,
And even
definitely.
for the literature which is available, the response achieved with pneumococcal vaccine is very less in every study. So
Thank you. Yes, it's come.
Question. Most of the CAR T, especially the BCMA ones, we have a lot of B cell aplasia, which goes on for very long. And we know that some kind of it's like a marked response also. So in that perspective, in our settings, when we don't have a much of tighter facilities as well, we have a B cell aplasia. How you position those vaccines?
So these vaccines, most of them are able to achieve good cellular immune response, so which is self-sufficient to protect from the infection. So even for the not in our scenario, even whatever the international literature is there, everywhere it is written that they are able to achieve good cellular response. Yes, humoral response are delayed because of the multiple reasons, but they are able to achieve good cellular immune response.
When we have antivirals, if you cannot measure fractional values, and you say that 400 or around indirect case, you can measure RGA levels. Because it will
I yes.
indirect.
No, we have to give vaccine only when your IgA levels are achieved.
So that's the question I was asking because we in the CAR T we measure even a further higher. We measure the cells exactly. So not an indirect. Even if the B cell markers are also low, which will be there for a year, the context of is that we still need to give the vaccine because as she mentioned
Because
in the
B
beginning,
cell immune response may be delayed even for the 2 years. So you can definitely give vaccine, and most of them are able to achieve T cell dependent immune response, which is better than B cell response.
When the extension was more office was up one year, what they mentioned specifically ensure immune reconstitution was happened.
At least T cell immune reconstitution should be there.
That should be the more important.
Yes, so yeah, that's I mentioned it.
Um, I- can I ask a question once? Ma'am, regarding in myeloma, patients receiving daratumumab, how safe is to administer vaccine and what are the minimum vaccines we have?
The concept remains same. Your minimal immunosuppression and daratumab is a immunotherapy. It is not a post-transplant or your CAR T therapy. The concept remains same. The minimal immunosuppression, the urgency if there is an outbreak like influenza season is going on, and so the protocol remains same. The vaccines remain same. So minimum at least influenza, pneumococcal these are to be given.
thank you so much, ma'am. Thank you, all chairpersons. Last but not the least, we now begin with panel discussion on infectious disease emergencies and transplant unit. And to moderate the panel, I would now like to call Dr. Nitin Bansal. So the panelists, I would invite Dr. Radhika Sarda, Dr. Madhur Arora, Dr. Nikhil N. Kumar, Dr. Upendra Sharma, Dr. Swapnil, Dr. Vikas Deswal, and Dr. Jatin Ahuja, please.
Dr. Vikas is not there. So, since everybody knows lunch has been served and this is the last talk, so I'll try to finish in 15 to 20 minutes or so. So, I have been asked to moderate the discussion on infectious diseases emergencies in transplant unit, real world cases and pitfalls. In my PPT slides, I have two cases, but I think considering everything, we will be able to discuss only the first case. So the case vignette one is acute myeloid leukemia. I mean, you can ask, stop me in between. I have predefined stops where I will try to ask the questions to the panelists. But if you feel anything, any clarification or any other correction is needed, please don't ask any questions related to hematology because I don't know anything. So acute, this is all copy paste. Acute myeloid leukemia, adverse risks with all these mutations. This case is being done in 2024, and this is an haploidentical stem cell transplant. She also has an insulin dependent diabetes mellitus and she has been diagnosed with AML since January 2024. And during the induction, she got flagged when as an induction chemotherapy, and she had ESBL, sorry, NDM equal to BSI during induction with some lung nodules with negative galactomannan in serum, which was managed with oral with isavuconazole. Now, after that induction, she has undergone further chemotherapies also, and now she is being put up for transplant. So her pre-transplant workup is fairly unremarkable. Her CMV serostatus is D plus R plus, and her pre-transplant HRCT is normal. The conditioning regimen is flu-cy TBI with post-transplant cyclophosphamide. The total dose of CD34 is this much. And day plus 2, patient develops high-grade fever with chills with no major localization. Vitals are stable. And this is at CBC, TLC is low, 530, on normal platelets and mild anemia. So at the time, the working diagnosis is for fever is febrile neutropenia with no localization with immediate post-stem cell infusion. So what are the next steps? These are the options: blood cultures, 2 sets with an antibiotic, cefosel, or any other antibiotic with blood cultures plus antibiotics as per stool surveillance results, or only blood culture and no antibiotics, no cultures, no antibiotic, or you have some other different ideas. Anybody who wants to take up?
Day 2 of haplotransplant, there is also possibility of a haplo-related CRS, which is the most common thing that we see in the first 4 to 5 days. So typically, patient develops fever by day 1, day 2, and it lasts all the way till day 5, day 6. But still, since the patient is neutropenic, we would err on the side of caution, send for a paired aerobic blood culture, and start on cefoperazone sulbat. And the other strategy which we use in this setting, especially if the platelet count is preserved, sometimes we do give an NSAID. So we sometimes give 1 or 2 doses of naproxen, and since it's an inflammatory fever, it can settle with that. Only if the platelet is normal, that is something which we can do in this setting.
Okay. I mean, points against giving an NSAID is generally it will mask our clinical judgment. Unless and until it is too high, like it's unmanageable, then only I think that way we should go that way. I would differ in that in only one aspect, that we would restrict ourselves from starting an antibiotic. We'll just send blood cultures and wait and watch. And depending on the hemodynamic stability, we can judge to start antibiotics. So we took blood cultures, but no antibiotics were given, as our primary diagnosis was haplos stem cell infusion related CRS, as Dr. Nikhil said. So fever subsided slowly by day 5 after post-transplant cyclophosphamide given, and cultures were negative. For the next 5 days, till day plus 11, she had 2-3 spikes of fever, for which she was given cefoperazone sulbactam, but cultures were negative. We could not find any cause of that fever, but it was like not much of a trouble for us. At day plus 12, she developed high-grade fever with chills, with perianal mucositis, and blood cultures were taken, and meropenem was started. Like cefosel was stopped and meropenem was started. Within 12 hours of this fever onset, so it started to become hypotensive. So empirical colchicine was added, since she had history of CRE previously also. She is profoundly neutropenic, as you can see, and expected also. So day plus 13, fever and hypotension is persistent. Cultures are negative so far. Nothing from the microbiology lab has been called for. Hypotension was present, and she was started on anatropes with profound neutropenia. So current working diagnosis is febrile neutropenia with hypotension, not responding to meropenem colistin. What are the next steps? Should we just wait and watch, or should we add more antibiotics? And these are the options. Yeah, obviously she has a pick line. Yeah. All the lines, there's a pick line, go for it. Pick line.
So one thing is that I would like to replace colistin with the ceftazidime with estronem, and apart sending from the repeat blood cultures. And in the meanwhile, I would also like to add, since the patient is in the first 1 month, I would also like to add the echinocandin also.
From antifungal point of view, she was on posaconazole prophylaxis. Sorry, I didn't mention that. She is on posaconazole prophylaxis. She is perianal mucositis.
Because the colistin was added because
just yesterday.
Pardon, sir?
Colistin was added just a day before.
Yeah, just a day before. Because colistin, if there is no UTI, we can easily check by the urine routine. If there is no pus cells, we can easily switch from either colistin to poly B, or we can better switch to the ceftazidime and estrogen combination.
Okay.
And then even removing the meropenem also.
She is being on.
But at least
since she has a history of CRL to that, instead of going to Zenison the PGP consider colistin to polymix.
Okay.
Examine the perineal area if any abscess or collection is there.
No, there is no abscess, no collection.
Since the patient has very side and the decline as well, where the order plan was coverage.
Okay. Okay. So what we do generally is that we don't add gram positive cover like this because MRSA is very less. I mean, I have not seen an MRSA in BMT so far. I don't recall. But I agree with adding a gram positive cover in the sense that enterococcus may come in. So probably TG cycline is an option. But generally we avoid TG cycline in very sick patients. She is quite sick. So again, not a good choice. Regarding use of Casavia empirically, we generally don't recommend because it's quite a narrow spectrum agent. Like it won't cover Pseudomonas, may not cover, it will not cover Acinetobacter and may not cover Pseudomonas also. So what I would have done would have just continued and waited and watched. That's what I would have done.
But the patient is going into hypotension.
Yeah.
Yes, I will basically with that, we can do the same and blocks of already been started. And fish hypertension still.
Okay, so let's move on. Sure.
Escalation in terms of maybe now you have a better molecule in terms of Astronam, Avibactam. So will we still think about Miro, Tico, and Colestine or versus
TG is always out because it's a
TG was
clear sign.
TG was never. I also said that TG we would not prefer, but I was just trying to answer her question of
Right.
MRSA. That's why I said TG.
So the coming to the point that amongst the house we will still stick to this regime or should
I think everybody wants to switch that. Everybody agrees that we want to switch. See, I am the only one who is not. Yeah, she wants to switch to polymyxin B. Madam wants to add teicoplanin, and I think the
Maropoly if the patient is stable, but if the patient
is not stable.
hypotensive, yeah.
Patient is not stable.
So then
Patient is on inotropes.
yeah, not clear. Yeah,
Definitely. Sir.
If fever is coming, culture is negative, Procal will also help here. Why I am saying that is, the Procal is negative, especially in the haplo setting, you have two phases of CRS. One comes initially and second comes during the period of engraftment. So this hypotension, persistent fever could be part of engraftment syndrome or a CRS kind of thing. So although antibiotic, I agree, we should keep this also in mind.
Yeah, I agree. So procalcitonin definitely helps, but I mean the point is that if we would have done the procal serially, then only it would have helped to take decision right now. Like we have not done it earlier, so I think. Okay.
The problem here is that IL-6, as he was saying, if you're doing it serially only, then it helps. So, and we know that CRS will come 9 out of 10 times in PTCY. And if your culture is repeatedly negative, you're not having a definite focus of infection, antibiotic has to be upgraded. But you have to consider CRS because you'll have to use your tocilizumab, or some people also use steroids in that case.
So I think we'll move on. What we did was we stopped meropenem, but the Casavi-Astronam combination were over colistin. Colistin was not stopped. Culture remained sterile. So day 14, high grade fever is persistent, still on hydrox, with neither any improvement nor any deterioration. Now the blood culture flagged, like this is day 14, the blood culture flagged and it showed yeast. So what are the next steps? Should we add echinocandins, as Dr. Jatin was saying, and stop posoconazole? Continue posoconazole, add amphotericin B, wait for final ID and AST of yeast.
so we can add echinocandins, maybe caspofungin in this patient.
Okay. Any like?
I would like to continue the at least posaconazole and add the echinocandin till the time I have the detection as well as the I would say finding of what's the nature of the yeast, whether it's a I would say Candida group and what kind of species is there. Then after I will decide further what to be de-escalated.
But you want two antifungals on board?
As of now, till the time I have the final report of the yeast.
Take one content and wait for the culture reports. If there's any change, I will change the kind of whatever as the purpose.
We would also add echinocandins in this setting.
Do you want two or one?
One. because it's been a breakthrough on POSA either ways. So
Okay, and the patient is near engraftment, so chances of mold infection is also slightly low. Anyway, I mean, I agree with that. Adding an echinocandid, there's obviously no question about it. So we move ahead. So finally, Candida tropicalis grew, and it was like resistant to azoles. Both fluconazole and voriconazole was given with fairly good MICs to caspofungin and micafungin, and sensitive to amphotericin B also. So we switched to caspofungin and stopped other antibiotics at that time, and she started to engraft also. So now we had a proven candidemia in post HSCT host who was near engraftment. Now question to the panel is: should we remove the PIC line, keep the PIC line, repeat cultures if persistent candidemia, and then remove? This is a more practical question, not like theoretically.
Would like to retain the PIC line. And if the patient is getting stable, we'll like to repeat the blood cultures. And if the culture is getting negative, we'd like to maintain further continuation of the PIC line.
Then can be cases are agreed. See the various of it's
So
so if they
traditionally,
had persistent fever, I agree with Dr. Madhur. We would have actually removed the PIC line couple of days
earlier.
back. We would have removed it earlier. If it is day 12, day 13 of line, patient is having fever, there's no other obvious focus. Even before the cultures came in, probably we would have taken out the line.
Actually, this is where there's a difference in the guidelines. The American guidelines quite clearly say that in this situation you have to remove the line and then put in like candidemia cannot be managed without removing the line. But the counterpart is that in patients of like hematological patients where the primary source of candidemia is GI translocation and the bug which grew also was Candida tropicalis, primarily going from our gut, you can consider not removing the line, just treating it, waiting in like wait for the response, repeated cultures. If there is no other metastatic focus, you can keep the line also. There's a difference in the guideline. That's why I just asked this question. Reason for asking was this.
the bias.
Resistant.
But giving sometimes people wait for 20 to 40, keeping the line waiting like so it's like the standard of
So the line was removed. So the Kesmo was
I agree.
continued and pick line was removed on the same day of the culture result. So she had an engraftment of her WPCs on day plus 17, and culture became negative after 3 days of casfofungin. Fever subsided, and next 3 days she remained affected. At day plus 20, remember she is also a diabetic host with insulin dependent diabetes, and with all these things going on, her sugar also became erratic, so she became hyperglycemic in between as well. At day plus 20, she noticed an ulcer over her palate, and there was some pain and mild swelling over her left cheek with no fever, and she was currently on caspofungin as everybody had agreed right now. And so we did an MRI also, which showed uh, like sinusitis was there, and it was a unilateral sinusitis. So at that time, the working diagnosis was a new onset palatal ulcer with unilateral sinusitis in an immediate post SSHT host with diabetes, with type 1 diabetes and erratic blood sugars of late, and currently on cyclosporin. So what are the possibilities and next steps? These are the options which I thought of. You can obviously think of your own ways.
next step would definitely to follow ENG and before you try to take a swab or try to see if KOH can.
So I tried to scrape off the palatal ulcer, but I could not do it. So that was
For
not.
previous simple sinuses and what, so we can still try, give it a try.
Swabs generally we
Come and take a biopsy.
biopsy also, yes. So that was done, but would you like to wait for that? Obviously, that will be done. It will take some time, but
I would like to
switch or you just continue.
I would consider it.
As the antibiotics were already de-escalated, so this could be either bacterial or fungal also, fungal in form of mold. So in that context, it could be either of the two. I would like to go for first pass and getting the QH testing immediately, and then I will be deciding whether I have to go with the ampho-B or restart my IV antibiotics again.
Okay.
We'll probably start on at least meropenem, go to amphotericin while waiting. We'll definitely biopsy the lesion, wait for the reports, but we would empirically start amphotericin and meropenem for
So
this.
you want to switch to amphotericin B or continue amphotericin B plus caspofungin? Because amphotericin B is sensitive. So Candida
We will switch
tropicalis
to
is sensitive.
We will switch to amphotericin.
Let's stop that.
And add an antibiotic before we get.
Same, so switch to liposomal amphotericin B.
Okay, so the test and all was done like the next day. Obviously, by the time we got all these reports, the day was over, so the surgeon would have gone and things were done next day. But we switched to liposomal amphotericin B and test was done.
The cultures from the debrided tissue did not grow, and we added meropenem. I have not put in the slides. The histopathology report is on your screen, and the which could not pick up anything. Neither the cultures, neither the stains could not. KOH exam was also normal. So over the course of next few weeks, he continued to improve. Swelling came down, and in the next 5 to 7 days, she became largely asymptomatic with plan to discharge. So at day 16 of antifungals, total of around 16 days of antifungals were given, 6 days of casofungin and 10 days of liposomal amphotericin B. From an ID standpoint, our working diagnosis was candidemia with right maxillary sinusitis and a palatal ulcer with negative tissue for microorganisms. What to give on discharge was the question. No antifungals needed, or use isavuconazole, continue shift back to casofungin, or continue liposomal amphotericin B. So it will be very difficult to discharge around liposomal amphotericin B. So you will have to consider that way also. And patient wants to go home. They don't want to stay further in the hospital. And patient is fine. She is not feeling that. She's feeling good. Dr. Adhika? This is pure ID. Okay. So what antifungal would you like?
Then there will do again to score third. If the patient is from the nearby center, I would not be giving any antifungal. If there's a logistic reason, patient is coming from far place, then on the safer side, I will start with the isoconazole. Patient is already engrafted now.
Patient is engrafted.
Grafted, yeah.
Continue active. Already test has been done, the treatment has been done. So then he out of fungal infection was there. We have already given almost 2 weeks of antifungals. I will switch to isopronazole and discharge.
Okay. Anybody who disagrees with this?
The last two options are very difficult. So discharging on an injectable has its own challenges. You would probably discharge this patient on isavu.
Okay.
And there are centers who don't give an antifungal once patient engraft.
I
But
agree.
our practice is usually to give it at least for the first 2 to 3 months.
I would like to continue cascofungin for time being.
Continue casofungin. So it has to be given as a OPAD.
Yeah.
Okay. That is a little tough to explain to the patient as well as to the team. So she was discharged on isavuconazole and remained symptom free for next 3 weeks. And she was given cyclosporine bacterial prophylaxis acyclovir. This was pre-Letermovir era. So CMV monitoring was done once weekly. She was doing well. At day plus 45, she came back with fever for last 2 days with chills and rigor with no other localization. And on exam, her was relatively unremarkable. Palatal ulcer was healing. She had a PICC line in situ at that time also, and basic labs were okay. This is a CBC report. Apart from anemia, there was nothing much to be spoken about. So she was admitted, started on first line antibiotic cefosel. After 48 hours of admission, she remained febrile with no clues for the diagnosis of fever. We considered possibilities of UTI as she was a female and diabetic. We thought it could be PICC line related. She was having a PICC line for long, or it should be could be some other breakthrough fungal infections because of her diabetic status. Also, we were concerned, or and it could be some other community acquired infections. She had been into the community for last 2-3 weeks or so. So urine culture and blood cultures were done, which were negative. PICC line was removed empirically, and HRCT thorax was done, which was also normal. She was not into dengue season, and we could not find any other cause of suspecting more community-acquired infections. But antibiotics were escalated to mirror. Despite all these 4 days into admission, she continued to have fever with chills, with rigor. There was quite significant rigor twice a day. So what is the working diagnosis now? And so basically, I mean, cut it short, we can say it's a PO in a post HSCT host. And what are the possibilities and how should we go ahead? So these are the questions.
How is the GVHD status under control?
She's doing fine.
CMV?
CMV monitoring we were doing, it was negative.
The possibilities. If the patient is clinically hemodynamically stable, we'll consider waiting and watching.
No, I mean, we are waiting and watching only for us. Urine routine has been done, which is normal. Urine culture is negative, but no, nothing.
Might do an abdominal imaging to see for any candidemia or focus of candida.
So more imaging.
Yeah.
Great.
Every ultrasound abdomen.
Exactly.
So what are the possibilities then? I mean, I agree with imaging. That's obviously we say it's a PUO, so probably
candidiasis.
Okay. But she was on isavuconazole.
Any other viral reactivation? Sorry. Any other viral reactivation?
Okay.
Adeno.
She didn't have any symptoms. I agree. We could check it, but she didn't have any end organ symptoms of any viral.
No localization sign.
No. Apart from fever, with quite significant chills and rigor. That too twice a day.
Have you done a tropical workup for this?
Tropical, we didn't do, I mean, we didn't do the tropical workup because I think this was in the dry season, April, May, if I'm not wrong. We didn't expect any mosquito borne illnesses to be there. So we didn't do, but I mean, I agree, we can do that, but generally these patients are immediate post necessity, mostly protected. And I mean, what I can tell out of my experience, we don't see too much of tropical things going on
Again,
at this moment.
we would definitely remove the line.
Still pick line is still
Pick line is there.
Still pick line is there.
Pick line we removed after she got admitted. We removed the pick line. I agree.
And the fever and
Fever is still persisting.
So we would get an imaging done. True. We would get an imaging, get an echo done. And at least in our setting, in such a patient, we would get a biofire, regardless, even if the cultures are sterile, we would probably get a blood biofire.
Okay. So what we did was we did a PET CT scan. We showed metabolically active focal lesions in the spleen with nodular soft tissue thickening in cutaneous and muscle planes, and there was no other metabolic active disease elsewhere. We did a beta glucan which showed positive, which was positive as 0.22, and we did a biopsy of the cutaneous nodules, which showed collections of foamy histiocytes, plasma cells hit with multinucleated giant cells, fibrosis, and neutrophilic exudate. Special stains for funguses were negative. So at that time, we made a diagnosis of disseminated candidiasis, and we stopped the isavuconazole and meropenem. We shifted the patient back to caspofungin. This was the mistake which we did actually. We forgot that the patient has Candida albicans candidemia, and which was resistant to azoles. And we shifted the patient to amphotericin B. Patient improved, and we forgot that the patient actually was having metastatic candidiasis only at that time. Probably that sinusitis was also part of that illness only rather than uh, uh, anything else. We got swayed in. So this was likely an overlook. Fever subsided in 12 days, and I think caspofungin was continued for 5 weeks. So this was the case which I had. If time permits, I can discuss. Otherwise, sir, I can.
Good one, good one.
Thank you. Thank you to the panels.
this would have not been possible without us. Somebody has been there who has been helping us out. There are many more people behind the doors who have making this niche to what we are and culminating into the end of this 1.5 day conference. Phenomenal outcomes, phenomenal huge factor of approaches, new technology that we use. I think we should look forward for the next year conference the better maintain the problem of having a better content so that this becomes the start action point for the year long journey where people look forward coming to a conference and they get engaged with the ideas, not only engaged with the ideas, but they go back and start the process of research and helping the country. I think it's a phenomenal thing. I think your team has been phenomenal. And I'm not entire team goes really, really was hard for this game. Big round of applause for the other companies and the pharma. Everyone keeps hanging out with ingredients, all the speakers who have things out and get the presentation. You know, yes, that we have this time. When we go confident, we have our own data to present. So then it's solved. Then it's a good bad, we what is situation that yes, to get the article of our data. I think thank you everybody. Open for that. Say good luck, goodbye, assume next year the same animal you cast me or will be and everybody started the so, but
the omics in hematology, which will talk about genomics, transcriptomics,
thank you.